Hi, welcome to the NEET PG core revision series where I'll be taking you through the most important topics in pharmacology that are asked in the NEET PG for your upcoming NEET PG exams. So let's start with the first topic, which we have pharmacokinetics. Now, the first thing here is routes of administration. Coming to the oral route. So, oral route, we know that whenever you give a drug by the oral route, the absorption occurs through small intestine and the stomach, but always because of the larger surface area of absorption, the absorption is greater in small intestine as compared to the stomach. Then the first pass metabolism is a very important factor which determines the bioavailability of the drug which is given by the oral route. So, higher the first pass metabolism, more will be the wastage of the drug and less will be the bioavailability. So, first pass metabolism decreases the bioavailability of a drug. Bioavailability of a drug. So, examples of drugs which have high first pass metabolism can be memorized by this mnemonic. Pre-systemic metabolism leads to high nitrate dose. So, pre it is propranolol, salbutamol, morphine, lidocaine, testosterone, hydrocortisone and nitrates. So, what happens when we have drugs which have high first pass metabolism? So, either we have to give a very large dose of the drug or we have to change the route of administration. So, just as we do with lidocaine, because it has so extensive first pass metabolism that it is impossible to give it by the oral route. So, we have changed the route of drug administration for lidocaine. So, what is bioavailability? What is the definition of bioavailability? So, it is the fraction of the dose of the drug which reaches the systemic circulation in the unchanged form. Unchanged form. It is denoted by the alphabet F. Okay. So, what is the formula to calculate the bioavailability? F is equal to area under curve of the oral route or by the oral route divided by area under curve by the IV route. Why IV route? Because IV route has 100% bioavailability. Okay. So, if we have to compare, so how we compare this? See, this is a plasma concentration versus time graph. So, we take a single drug and we give it by the IV route also and we give it by the oral route also. So, let's say I have given the same drug by the IV route and it immediately enters into systemic circulation, right? So, the graph that we get is like this for the IV route. And the same drug, if I give it by the oral route, it will take time to get into the or get absorbed into the systemic circulation and then ultimately go like this. So, this is the oral route. So, what you do? You calculate the area for these graphs. So, for the oral route, so this would be the area, right? So, you calculate the area under curve here, and for the IV route, so this whole would be the area that is by the IV route, right? This one. Okay. So, this you calculate the area under curve for the IV route and then you just divide oral over IV and that is how you get the fraction. And if you go on to get the answer in percentage, simply what you do is you multiply by 100. So, the answer would be now in percentage. That means 40% bioavailability, 50%, so on and so forth. So, that is how you calculate the bioavailability. So, moving on to the important next concept is the transdermal patches, and let's first discuss a question which had come in the previous years. So all the following drugs can be given by the route shown below except. So please see the exception is asked. Always read the question carefully and see what is hidden in the question. Okay, so whether it is fentanyl, rotigotine, scopolamine, atropine. So this is a patch which is shown, right? So we can make out that this is a transdermal patch. So the answer lies in if we know that what patches are available in the market. Only then we can say that which of the patch is not available. So first let's go and see what is a transdermal patch. So this is the structure of a transdermal patch here. So in the transdermal patch, you see it is just like a band-aid that you have, and it's a thick band-aid which consists of the medication inside, and then you peel off the layer and stick it to the skin wherever you require it. So this is the drug reservoir here. The drug is present inside, and there is a rate control membrane through which slowly the drug is being released, and it enters through the skin and definitely enters into the small capillaries in the skin and enters in systemic circulation. So this also route, it bypasses the liver. So it bypasses the first pass metabolism. That is very important. Another important thing to know that because the drug is released very slowly, this route cannot be used in emergencies. It is not a very emergencies. So because it doesn't give rise to peaks of the drug. So there are no immediate peaks that you achieve with this. So can't be given in emergencies. Also remember that sometimes students get confused whether this is a topical route or a local route of administration or systemic. So because the drug is entering into the systemic circulation here, so this is your systemic route of administration and not local route of administration. Remember this, okay? So this is a systemic route. All right. So what are the important examples of the drugs which are available in patches, and what are the indications for which they are used? So that is a very, very important thing to know. So first is scopolamine, other name is hyoscine. So this is used in case of motion sickness. Motion sickness. Then nicotine. Nicotine is used for smoking cessation. Nitroglycerin is for prevention of attack of angina or prophylaxis. Prevention of attack of angina. For acute attack of angina, we use sublingual route, not because this is not an emergency use, right? So, but to prevent any further attack or future attack of angina, there we can use this as a patch. Angina. Fentanyl or buprenorphine, so these are analgesics. So they can be used for chronic pain, like for example, cancer or post-op pain, chronic pain. Lidocaine, it is used for post-herpetic neuralgia. Clonidine for hypertension. Estradiol for hormone replacement therapy. Testosterone also for primary, or you can say just in hypogonadism in cases of hypogonadism. Rivastigmine, it is used for Alzheimer's disease. Rotigotine for Parkinson's disease. Selegiline for depression. Oxybutynin for overactive bladder. So if I have to go back to the question, so you know what other drug formulations available in patch form. So we can now solve this question here. Fentanyl, yes, it is available for analgesic purpose. Rotigotine for purpose of in Parkinsonism. Scopolamine for motion sickness. So the only option left with us is atropine. So atropine as such is not yet available in the form of patch. Okay. So let's move on to the next question. This was also a previous year question and very, very important concept. Which of the following parameter is used to assess the rate of absorption? Whether it is Tmax, Cmax, half-life or the area under curve. So we have just now done that area under curve actually is used to calculate the bioavailability. already that we know about, right? So here, this curve. So let's first understand a little more in detail about this, that this is a graph that is available to us, and Cmax and Tmax of formulation A is compared with Cmax and Tmax of formulation B. Okay, here. Now, can we say here that the Tmax, which is the time taken to achieve the maximum plasma concentration by A, is less as compared to the Tmax of B, right? Because Tmax achieves of B achieves it at a later area or a later point here. So it is faster. Tmax has achieved the Cmax faster. So we can say the quick, fast means the rate of absorption is faster for A as compared to B, because how fast the drug has been absorbed and it has achieved the maximum concentration. So Cmax just tells you about the maximum concentration achieved, right? So Tmax tells you about the rate of absorption. Half-life is just telling you about how much time has been taken by the drug to reduce to 50% of the plasma concentration, of its initial plasma concentration. And area under curve, this whole area, actually this tells you about the extent, how much drug has been absorbed. So the extent of absorption is determined by the area under curve. So rate of absorption is determined by the Tmax. So important is to know the difference, because it is asked extent of absorption is told by area under curve, while the rate of absorption is determined by the Tmax. Okay. So what is now the effect of pH on the absorption of a drug? So let's see here. We have two drugs. One is an acidic drug and the other is a basic drug. So let's see how the absorption and excretion can differ in each. So acidic drugs, they are, always remember, better absorbed in the same media, that is the acidic media. And basic drugs are also better absorbed in the same media, that is the basic media. So same media or medium, better absorption. Why? Because acidic drugs in acidic medium, they always remain unionized, right? Unionized. And unionized fraction and the lipid soluble fraction always is better absorbed. Okay. Now, coming to the excretion part. So, what happens in excretion? So, because they are better absorbed in the same medium, they will be excreted out, remember, in the opposite medium. So, acidic drugs are excreted in the basic media. Basic drugs are excreted also in the acidic media. It's opposite, right? Remember, if you remember this one rule, you can easily make out the second rule. You don't have to remember both the rules, just remember one rule, absorption in the same media. So excretion will be in the opposite media. That remember, right? Because, and here what is happening here basically, why is it getting excreted, not being absorbed? Because acidic drug in basic medium, they become ionized. Similarly this. So ionized fraction is never absorbed easily, it is excreted out into the through the urine. So therefore, we make use of this very important concept in managing drug poisoning. So we have two types of drugs, weakly acidic and weakly basic. Strong acid, strong basic, they do not follow this rule. But this is only meant for weak acids and weak bases. So when weakly acidic drugs like aspirin, phenobarbital, acetazolamide, phenytoin, warfarin, tricyclic antidepressants, whenever there is overdose toxicity with this, how can you remove this drug? That is when they're excreted into the urine. What you do, you make the urine, because they're acidic. So remember the rule, they will be excreted in the basic media. So you make the urine more alkaline, right? So how can you make the urine more alkaline? With the help of sodium bicarbonate. So we can give sodium bicarbonate. This is injected and the urine has become alkaline. So these drugs can be easily, so this is a treatment, easily excreted. So this is asked as a question. So what about basic drugs like morphine, atropine, diazepam, amphetamine, cocaine? So first remember, all of them will have ene, or this is the only exception, am, ene or am at the end. So that therefore this means that they are the basic drugs. So basic drugs, how to excrete them faster, that you make the urine more acidic, right? So how can you make the urine more acidic? So we give ammonium chloride, or ascorbic acid, vitamin C, ascorbic acid. So this makes the urine more acidic and helps in the excretion. So this rule can be made use of in drug poisonings. The next important concept is volume of distribution. So what is the volume of distribution, or it is denoted by the apparent volume of distribution, because this is not the exact values that we get. So what are the factors which affect the volume of distribution? Is lipid solubility of molecular weight of a molecule of the drug. Now always remember, volume of distribution will be directly proportional to the lipid solubility, because you know that when the drug first it reaches into the systemic circulation, this is called as absorption of a drug. Now from the systemic circulation or from the blood, it now has to enter into the various tissues. This is called as distribution. So when it has to enter, it needs to cross the endothelium of the blood vessels, as well it has to cross or the the cell membrane or the cell wall, the cell layer, that is has to cross. So it is made up by the lipids are there present here also, there also. So lipid solubility is a very important factor. If the drug is more lipid soluble, it can easily cross the endothelium as well as the cell membrane. So this is important. So directly proportional. Molecular weight, if the drug is very high in molecular weight, it becomes difficult for the drug to actually pass through. So distribution might be less, or it might be a little more difficult or less as compared to drugs that have smaller molecular weight. Plasma protein binding. So plasma proteins are the proteins which are present here in the blood, right? So they are present in the blood itself. So what happens is that some drugs, they get bound to the plasma proteins while the other are free, or like some molecules of the drug, they are bound and the other molecules are free. So for example, we have given a drug, and some drugs are bound to the plasma proteins and others are lying free here. So remember, the drugs which are bound to the plasma proteins are called as bound fraction of the drug. The free one is called as a free form. So this free form can easily enter into the tissues. So free form of the drug is available for action. The bound form is not available for action. So therefore, plasma protein binding is inversely proportional to the volume of distribution. So more the drug is bound to the plasma proteins, less will it be distributed to the tissues. Then there are barriers like blood-brain barrier, blood-placental barrier. So these are very strict, strong barriers, especially the blood-brain barrier is a very strong barrier. So the drugs, if it's because of this, they cannot cross into the central nervous system. All the drugs, they don't manage to cross in central nervous system. The distribution would be less there. While blood-placental barrier means from the mother to the fetus, this is not a very stringent or a tight barrier. So many drugs can pass from the mother to the fetus. Therefore, we restrict the use of drugs during pregnancy. Tissue storage of the drugs. So many drugs we have, there are certain drugs that are very, very high, very high volume of distribution, right? In thousands. So that means that the drug has gone and gotten stored somewhere in the tissues. Okay. Now certain diseases also, they influence the volume of distribution. So let's see them and see what are the important facts that you need to know about each of these points. So drugs with very high apparent volume of distribution. What can you say about these drugs? For example, I'll give you an example of a drug called as chloroquine, which has volume of distribution in thousands, so around like more than like 13,000 liters. So how do we explain this? Because we don't have that much of fluid in the body. So how do we explain so much of volume of distribution? So that means that this drug goes and gets stored in the various tissues, right? It gets stored in the liver and gets stored in the eye. So therefore, long-term use of this drug can lead to a side effect or an adverse effect, which is called as a bullseye retinopathy because of this. Bullseye retinopathy. Dialysis. Now, drugs which have very high volume of distribution, that means if you see here that these drugs, because dialysis is carried out in the blood, right? but the drugs which have very high volume of distribution, they are stored here in the tissues. They are no longer in the blood. So how will we remove the drug by dialysis? So drugs which have high volume of distribution, very high or high volume of distribution, cannot be removed by dialysis. That is number one. Second factor is the drugs which are highly plasma protein bound also. Plasma protein bound. They are also difficult to remove by dialysis. So they are also difficult to remove by dialysis. Why? Because they become a big molecule. So when they combine with the plasma protein like this, as compared to the single molecules, this is a big molecule. It is very difficult to remove such drugs by hemodialysis. So drugs have very high volume distribution which are not present only in the blood. They can't be removed by dialysis. While drugs which have high plasma protein bound also, they cannot be removed by dialysis. Now diseases. Certain liver diseases and in nephrotic syndrome, what happens? There is decrease in a plasma protein called as albumin. So albumin is a plasma protein which usually binds the acidic drugs, and alpha-1 glycoprotein binds the basic drugs here. So albumin is decreased. So when the plasma protein is decreased, that means the free form will increase. So there is increase in the free form of the drug, more free form of the drug. And when there is more free form of the drug, so that leads to toxicity, because free form is the one which is available for action or toxicity, that is the free form. While in the other diseases like myocardial infarction, inflammation, there is increase in the alpha-1 acid glycoprotein. When there is an increase in the plasma protein, that means there will be increase in the bound form of the drug. So when the bound form is more, that means the free form is less, so less effectiveness of the drug. So there will be decrease in the effect of the drug, right? Displacement reactions, for example, the drugs are highly plasma protein bound. So there are two drugs which are highly plasma protein bound. They bound to the similar plasma proteins. So warfarin is a drug which is 99% plasma protein bound, right? So if you give another drug like salicylates, which are also plasma protein bound, they can displace warfarin. So initially only 1% was free. So when they displace warfarin, let's say, then 2% becomes free after displacement. So what has happened? There is double the effect of warfarin, double warfarin effect. So more of warfarin effect, which is anticoagulant effect, will double. So patient can have bleeding tendencies here. Sulfonamides can displace bilirubin in neonates. So what happens? This bilirubin will go and it will enter into the central nervous system, brain of the baby, and it can lead to a dangerous condition called as 𝗙𝗃. So therefore, sulfonamides are not recommended in neonates. It can cause 𝗙𝗃. Alright. So let's do some examples of the drugs which are not removed by dialysis or where the dialysis is not effective. So remember, in mnemonic, avoid dialysis. Avoid dialysis. So this means amphetamines, 𝗲𝗏𝗡, opioids. Then we cannot give, imipramine, digoxin, and dialysis D stands for diazepam or other benzodiazepines, right? While dialysis can be done in MLAT, right? MLAT, which is methanol, right? It can be done for lithium overdose. It can be done for aspirin or alcohol overdose, and it can be done even in theophylline toxicity. So remember, the dialysis is not effective in avoid dialysis mnemonic, and dialysis is done in MLAT. So overall, what I want to make you understand or remember one fact is that apparent volume of distribution, always remember, is directly proportional to the lipid solubility. Always remember, but it is always inversely proportional to the plasma concentration, right, or plasma protein binding. Plasma concentration of the drug more, that means the drug is there in the plasma only, it has not entered into the tissue. So, it is there in the hemodynamic, in the systemic circulation only. While if the plasma concentration is less, that means the drug has gotten away or moved away from the blood into the various tissues and it has distributed. So, similarly, distribution would be high only if the drug is less in the blood and more into the tissues. Okay. So, moving on to the next concept, a female patient who's on oral contraceptive pills has been diagnosed with tuberculosis and started on the anti-tubercular therapy. She was advised to use an additional barrier method of contraception. What is the rationale behind this? Now, whether it is OCPs have teratogenic effects, ATT may become ineffective, rifampicin reduces the metabolism of OCPs, or rifampicin enhances the OCP metabolism, leading to contraceptive failure. Now, here comes an important concept for us, the CYP, or the metabolism that we should be knowing. So, let's do what it is. Now, cytochrome P450 enzymes are important enzymes responsible for metabolism of the phase 1 reactions mainly. So, you know that the metabolism occurs in the liver and there are two phases, phase 1 reaction and there is another phase 2 reaction. So, phase 1 reaction is mainly done by the cytochrome P450 enzymes. Phase 2 reactions is by the glucuronide transferase enzymes. So, the most common phase 1 reaction is oxidation and the most common phase 2 reaction will be glucuronidation. Alright, so moving on to this, which is the important, this cytochrome P450. The nomenclature, cytochrome P, this is the CYP, what is the other 3A4? So, there are different enzymes. So, one example I am taking is cytochrome P, 3A4. What does this mean? So, 3 means the family of the enzyme, A stands for the subfamily, 4 stands for the genes, exact the gene locus or the gene area. So, that is why C3A4, that is the rule here. Now, we have certain substrates for these cytochrome enzymes. There are few substrates that are important for you to remember for the examination point of view, they are asked. So, first is the CYP3A4 substrates. Remember the mnemonic CT scan. Now, these are important to know because many times questions are asked on this, that what is the important substrate for this and metabolite, which is the important metabolite or substrate inducers and inhibitors. So, all sorts of questions are there. So, let's do only the important one. CT scan is the mnemonic. C stand for CCBs. Then we have the estemizole, then tacrolimus, then we have terfenadine, statins, cisapride, amiodarone, and NAVIRs, the protease inhibitors. Remember, CYP3A4, it is very important isoenzyme because it is responsible for carrying out 50% of the metabolic reactions in the body. That's why it is one of the most important enzymes. Then we have CYP2C19. So, remember mnemonic OCD, omeprazole, clopidogrel and diazepam. So, here one of the very important questions it is asked here. So, clopidogrel is an antiplatelet drug. Clopidogrel is an antiplatelet drug and is given in cases of myocardial infarctions to the patient. But this is a prodrug and it gets activated in the body with the help of this enzyme CYP2C19 and it gets activated. Right. So, it is necessary, otherwise the action will not be produced. But if we give it with another drug, which is a proton pump inhibitor, that is omeprazole. So, omeprazole, it also inhibits this enzyme, CYP2C19. So, when you give omeprazole with this, clopidogrel is not going to get activated and therefore, it is not going to produce the response. There will be failure of therapy or unrepeated action by clopidogrel. So, this is a very important drug interactions that patients who are on clopidogrel, they should not be prescribed omeprazole. Then we have CYP2 D6, and here you can remember two Ds. One is DIL and the other is DIMARC. So drug, DIL means heart, DIMARC means brain, right? So the drugs which are used in heart and the brain. So tricyclic antidepressants, they are all the SSRIs, etc. They are there, and the heart drugs like antiarrhythmics, beta blockers. But antiarrhythmics except amiodarone, because amiodarone we did in CYP3A4, except amiodarone. Okay. Then we have CYP2C9. So war at 9, remember warfarin. So there is war at 9 p.m. Remember warfarin, very important example. Then CYP2E1. E1 means everyone. Everyone uses paracetamol. So paracetamol is a very important substrate for CYP2E1 that you have to know. Then moving on to the other important examples which are of the enzyme inducers and enzyme inhibitors. Enzyme inducers, remember a mnemonic GPRS cell phone. That is griseofulvin, phenytoin, rifampicin, smoking, carbamazepine, and another one you can remember with C is chronic alcohol intake and phenobarbital. Right? So these are the enzyme inducers. So whenever you give it with any other drug, they will increase the metabolism of the other drug. So for example, you use phenytoin with OCPs, oral contraceptive, or you use rifampicin with OCPs, oral contraceptives. What is going to happen is, if the female was taking an oral contraceptive without any of these drugs, so let's say that gets metabolized in 24 hours. So the patient takes one dose today, and after 24 hours the next day she will take another dose of oral contraceptive pills, because she knows that she's been protected for 24 hours. But when she is on another drug, another inducer like rifampicin, she develops tuberculosis, was prescribed rifampicin. So rifampicin is a enzyme inducer. It increases the metabolism of this particular OCP, and it will make it so fast that this OCP now it gets metabolized within 12 hours only. The rest 12 hours, the patient is unprotected, right? And so patient can get pregnant even while being on an OCP. So that leads to OCP failure. So what we prescribe or tell the patient that either you should use some other method of contraception, because alone OCPs will not be sufficient. So any inducer when you use with any other drug, and if the question comes there is a failure of therapy, so just make sure that you know this list, because this list is a very important list of drugs. Mostly the inducers are asked from this particular drugs only. So they are increasing or enhancing the metabolism of the other drug and causing failure of the therapy. While on the other hand, we have the other groups which are called as enzyme inhibitors. So another mnemonic to remember, pro-alcohol in coke. So this is pro means pro, valproate, right? Acute intake of alcohol. Chronic was inducer, acute intake is inhibition. Isoniazid. So exceptions are like most of the antiepileptics are usually enzyme inducers, the exception being valproate. Most of anti-TB drugs are enzyme inducers, exception being INH. C is for cimeridine, ciprofloxacin, O omeprazole, K ketoconazole, and E is erythromycin. So if you get an example, especially with these drugs, we get an antifungal drug or this drug, what you get is you are giving, let's say, ketoconazole, or you have given erythromycin with a drug which is, let's say, theophylline, and patient develops excessive toxicity with theophylline. So what is the reason? This is an enzyme inhibitor. It will decrease the metabolism. So theophylline, for example, again, it was first, let's say, getting metabolized in, let's say, about, again, I'll take hypothetical, 24 hours. So let's say I was giving 50 milligrams of theophylline 24 hours ke baad, again because it gets metabolized. So I will repeat 50 milligrams of theophylline here. But when you're giving erythromycin, because it is delaying the metabolism, so now theophylline may be getting completely metabolized. In 24 hours only 25 is getting metabolized. Another 24 hours may 25 is getting metabolized. So ideally At the end of 24 hours, 25 is still left. And if you don't have the knowledge, you're again giving 50 milligrams of the drug. So ultimately, how much drug we have? Here is 75, right? So what is happening here basically? There is already a drug present. Again, you're giving more drug, so it is increasing the toxicity of the drug. So toxic signs and symptoms will appear. So when a drug, another drug is being given with enzyme inhibitor, you need to decrease the dose of the drug. But with an inducer, you will have to increase the dose of the drug. This fundamental rule you should remember. So with this knowledge in our backhand or in back of the mind, now let's go back to the question which was asked here. So a female patient who's an oral contraceptive, right? So we did this example. She was started on anti-tubercular therapy. So what is the rationale behind this therapy? Basically, so most probably in the anti-tubercular therapy, because those are mostly enzyme inducers, they are talking about rifampicin. This is the action. So rifampicin, it enhances the metabolism of OCP and leads to contraceptive failure. It doesn't reduce the metabolism, right? It enhances the metabolism. So the OCP is metabolized faster and they cause failure of the therapy with this particular drug. Okay. Next we come to another important short topic, which are the different drugs which are metabolized by plasma esterase. So we have done cytochrome P450. Now there are certain drugs which get metabolized in the blood, in the plasma itself. And such drugs, they are very short acting drugs. They act quickly also. They have a very short half-life, short duration of action. So the important ones are procaine or cocaine, esmolol, remifentanil, remimazolam, 𝗙𝗵𝗃𝗃, succinylcholine. So all these drugs, they get metabolized by the plasma esterases. Therefore, they have a very, very short half-life. Another important concept is P-glycoprotein, which is also a very commonly asked question. So P-glycoprotein efflux mechanism, usually we say. There are other names. We have MDR, multi-drug resistance 1 pumps, same, or ATP binding cassettes, or ABC. So they are similar. So they are asked like what are the substrates? Now the substrates are also these are inhibitors. Digoxin, erythromycin, clarithromycin, verapamil, quinidine. And then we have inducers. Inducers, rifampicin, phenytoin, carbamazepine. So you'll see, just to give you a hint, is like the CYP inducers are also P-glycoprotein inducers, and the inhibitors over there are also similar. They are the P-glycoprotein inhibitors. So many a time the question has been asked on verapamil, then there is digoxin also involved, then quinidine. So inducers is easily to you can remember because they are similar. These are also the inducers for CYP. They are also the inducers for the P-glycoprotein. Now, what is important here? Let's see about the P-glycoproteins. So this P-glycoprotein efflux mechanism, this is important in certain areas like intestine, blood-brain barrier, liver, and kidneys. Right? So they are efflux pumps. As I told you, these are efflux pumps. So they will throw the drug outside. So like suppose here they are present and this is the cell here. So when the drug enters inside, so the efflux pump is going to throw, this P is going to throw the drug outside. Right? So this is the role of the efflux pump. So similar in the kidneys also it will be the same, in the intestine also it will be the same. So any drug which is going to inhibit this, for example, I have a drug and I am going to inhibit this pump. So what will happen? The drug will not be effluxed out. So many a times it can lead to toxicity of the drug. Inside the drug is there, so it can enhance the toxicity. So these efflux pump, if you give inhibitors, it can lead to increase in the drug toxicity. So there can be an example, for example, on the inhibitor, let's say erythromycin with digoxin. So it can inhibit the efflux pump. So there can be enhanced toxicity of digoxin, increased digoxin toxicity. So the question can be asked, what is the reason? Because it is a P-glycoprotein inhibitor. The efflux pump is working, so that can be there. Well, this is also responsible for causing resistance in certain anti-cancer drugs, because what will happen because of the pumps is that drug is no longer concentrated in the cell itself. It will be again thrown out of the cell. So it can be a cause of the resistance of this multi-drug resistance in cancer. That can be another, you can say, the point for P-glycoprotein. Moving on to the next concept, this is the plasma half-life. So what is plasma half-life? It is a time duration in which the plasma concentration of a drug is reduced to half of its original value, right? That is very important. 50% of its original value. The formula is important. T half is equal to 0.693 into volume of distribution divided by clearance. And it helps you decide about the dosing frequency of the drug, right? So that is important. Now, the thing is that plasma half-life, another important concept you should know, it takes 4 to 5 half-lives for the drug to reach its steady state or plateau or steady state concentration, which is usually the therapeutic concentration, steady state concentration. While similar half-lives are required by a drug to be eliminated. 97%. So 97% elimination of a drug is almost done in about 4 to 5 half-lives. So let's see with the help of an example. So we have a drug, let's say there is 100 milligram, 100% of the drug, let's say, and half-life is 1 hour. So every half-life, 50% of the drug is being eliminated. So in first half-life, it is 50% of the drug is being eliminated. And here I am going to say what is the remaining amount of drug, let's say here, and also we will see how much drug is eliminated. So we will make two comparisons, right? So here let's say remaining drug after every 1 hour, let's say 1 hour, which is a half-life, is 50%. So we can say out of 100, 50% of the drug is eliminated. Next, remaining is 25%. So how much drug is now gone out of this 25%? So total is 25 plus previous 50, 75% of the drug is eliminated. This is first half-life, second half-life. Third half-life, out of 12, it is 12.5. So how much has now gone? 75 plus 12.5, it is 87.5%. In the fourth half-life, half of it, 6.25. So here it is 93.75. Fifth half-life, 3.125%. So this is almost 96.8%, which is 97%. Okay, 97%. So in 4 to 5 half-lives, 97% of the drug has been eliminated. So this is what I'm trying to prove here. So in 4 to 5 half-lives, 97% of the drug gets eliminated. Next is order of kinetics. Like in the order of kinetics, first order versus zero order kinetics. First order kinetics, what is the difference? Here a constant fraction or a percentage of the drug is eliminated per unit time. In zero order kinetics, a constant amount of the drug is eliminated per unit time. That means here 50% of the drug is lost per or eliminated per unit time, and here a constant amount, let's say 50 milligrams of the drug, not percentage, 50 milligrams of the drug. Rate of elimination is directly proportional to the plasma concentration. So more the plasma concentration, more will be the rate of elimination, because 50% of that concentration is going to be eliminated. Let's say if it is 200, then 100 will be eliminated. If it is 100 milligrams, then only 50 will be eliminated. So more the plasma concentration, more will be the elimination. But that is not the case with zero order. The rate of elimination is independent. It stays constant. Whatever dose you give, it is only going to eliminate 50 milligrams per half-life, or let's say 1 hour if it's a half-life. So clearance here, it is at a constant rate, the clearance is there. Now the clearance is variable. So you will see with the help of an example, more is the plasma concentration, less will be the clearance, it's variable basically. And less would be the plasma concentration, then the clearance would be more. Half-life is constant. Here half-life is variable. So first order and zero order, it will be opposite. If it is constant, if one parameter is constant for first order, it will definitely not be there for the other. It will be variable in the other. If it is constant for zero order, it will be variable in the first order. So remember that. Plasma concentration will be doubled if the dose is doubled, but here there is a disproportionate increase in the plasma concentration. So first order is a good kinetics followed by almost all the drugs. So we don't have to remember the general rules, but we also always should remember the exceptions to the rule. So zero order kinetics is followed by a very few drugs. So zero order kinetics is followed by drugs like 0 watt power, you can remember. So 0 means zero order kinetics. W stands for warfarin. A stands for alcohol, right? T stands for 𝗏𝗏𝗏𝗏 and 𝗲𝗏𝗏𝗏𝗏. P stands for phenytoin. So these are the drugs which follow the zero order kinetics. So see here, let's take an example and understand. If I have 100 milligrams of a drug here, so 50% is going to be limited in every half-life. So let's say half-life is 1 hour. So after 100, it is going to be 50, 50% 25, 50% 12.5, 50% 6.25 and so on. But if I talk about the zero order kinetics, what is happening here? 100 milligrams, 1 hour ke baad almost only 50, because 50 milligram constant amount, and another 1 hour it is going to be 0. Now what if I increase the dose of a drug? Let's say I've increased the dose of a drug here to 200. Again after 1 hour, 50% is going to be out. So it is going to be this much. Again another hour, 50, and then it continues in a similar manner. So see here, half-life was how much? 1 hour. And what is the half-life here? Same, 1 hour, constant. But what happens if I increase the plasma concentration to 200 here? A constant amount is going to be eliminated. So in 1 hour, it is going to be 150. Another hour, it is going to be 100. Then it is going to be 50, and then it's going to be 0. So let's see the half-life here. 200, half of 200 is 100. How much time did it take for the level to go from 200 to 100? 1 plus 1, it is 2 hours. So half-life is not constant. So this is the difference between first order and zero order kinetics. So as you go and increase, so think of it, there's a club and there's a bouncer standing outside the gate of the club. If it's first order, there are two clubs. So one is first order, the other is zero order. In the first order club, the bouncer says that if there are 100 people inside, I will let out 50% in 1 hour. If there are 200 people inside, I will still let out 50%. So therefore, there is no, you can say, no chaos in the club and no over jam packing in the club. While in the other club, the bouncer says, I will let out only 50 people, even if there are 100, even if there are 200, even if there are 400. So let's say there are 100 people, he lets out 50, so there are 50 inside. There are 200, he will let out only 50 people in the 1 hour. So there are now how much? 150 inside. If there are 400, he will again let out only 50 people outside, and there are now 350 inside. So he'll jam the club will be packed with people. So that is so it will be, you can say, the saturated inside. So that is the concept of saturation kinetics in the zero order as compared to first order, which is it is percentage driven basically. All right. So the next MCQ which we had from the previous year, which of the following formulas is used to determine the dosing rate of the drug? So remember, what is dosing rate? Dosing rate, it means the maintenance dose. Maintenance dose. So whether it is clearance divided by the plasma concentration, clearance multiplied by the plasma concentration, clearance multiplied by the loading dose, or clearance divided by the loading. So remember the formula for the maintenance dose is equal to clearance into the plasma concentration. So these are very, very important formulas. So let's see what are the various important formulas for us. First important formula is volume of distribution. If case there's a numerical given, that is the amount of drug multiplied by bioavailability and divided by the plasma concentration. Half-life is 0.693 multiplied by volume of distribution divided by clearance, or it is 0.693 divided by elimination constant. Clearance is rate of elimination divided by the plasma concentration. Most important is the difference between these two, which is asked loading dose versus maintenance dose. Now, everything is the same in the formula except for this and this. They both have plasma concentration in the numerator and bioavailability in the denominator. The only difference is if it's a loading dose, it is multiplied by volume of distribution. If it's a maintenance dose, it is multiplied by the clearance. Right? Remember, this is the only difference. So, loading dose depends on the volume of distribution. Maintenance dose depends on the clearance. So, remember, loading dose has D in the spelling, right? So, D in the spelling, and volume of distribution also has D in the spelling. So, DD, volume of distribution, loading dose. All right. So, next is another MCQ. As a medical practitioner in India, what is the correct way to prescribe the alprazolam to a patient? So, the good prescription or ideal prescription guidelines that you have to follow. So, you have to see that whether it is 1 milligram OD before bedtime for 7 days, half milligram HS for 7 days, 0.5 milligrams BD for 7 days, or 0.5 milligram daily before bedtime for 7 days. So, first let's see the guidelines for prescription. So, one important thing, we should use generic names whenever possible. Avoid abbreviations because patients don't understand abbreviations. Clearly mention the dose, frequency, duration, legibility, check for instructions, and unnecessary polypharmacy. So, out of these rules, if you see here, the in thing here I can see in first three options is there is a use of abbreviation. OD once daily, HS before bedtime, BD that is twice daily. So patients don't understand. So the best way to prescribe is give clear instructions in the simple elaborate form. 0.5 milligrams daily before bedtime for 7 days, right? So the patient, we can also write tablet. Let's say the full form is written, then you can write tablet alprazolam. So it is said that generic, yes, but also write in all caps, because with all caps, it is difficult to make any mistake. So when you write in running hand, sometimes it is not comprehensible. It's very not legible. So we can write tablet alprazolam and 0.5 milligrams daily before bedtime for 7 days. That's the ideal way to write a prescription. All right. Hi, welcome to the NEET PG Core Revision Series, where I, Dr. Deepika Tikoo, will take you through the most important topics in pharmacology which are asked in the NEET PG examinations. So, moving on to the topic of pharmacodynamics. So, let's see what are the most important things that you must know from this topic. So, first we are going to talk about enzyme inhibition. Now, in the enzyme inhibition, you're often asked in the exams by they give you a graph. It can be an image-based question, and then you are asked to identify what type of enzyme inhibition is this, right? So, there can be two types of graphs. One which are parallel to each other, okay? And in the other, it can be a downward shift, right? So, in both the cases, what you have to do is you have to identify the type of antagonism. Now, we are talking about the enzyme inhibition here. So, in enzyme inhibition, you will be asked to identify the type, or maybe sometimes what is the Km and the Vmax. So, let's understand this first. In case of a competitive antagonism, if the graph shows this kind of parallel shift, right? So, this is a competitive antagonism. Competitive antagonism where there is a parallel shift or shift towards the right. So, here we say the maximum velocity Vmax in a competitive antagonism, it remains the same. So, Vmax in this case is going to be the same. while the Km, that is the substrate concentration which is required to achieve 50% or half of the Vmax, that is going to increase. So the Km, if you see, because of the rightward shift, the Km is going to increase. So in a competitive inhibition, in case of an enzymes, the Km going to increase, but the Vmax is going to remain the same, right? Now, in the non-competitive graph, there will be a downward shift, right? So this means that the Vmax has dropped down, right? So the Vmax is going to decrease. But the Km, which means the affinity, that is almost the same. So the Km remains the same. So make sure that we know this thing. In competitive enzyme inhibition, Vmax remains the same and the Km will increase, while in the non-competitive enzyme inhibition, the Vmax will decrease while the Km will remain the same. Now, there is another type of graph on this very concept which is called as the 𝗫𝗏𝗏𝗏 plots for enzyme inhibition. So here what is simply you need to know is you need to identify the types of inhibition, whether it is a competitive inhibition, whether it is an uncompetitive inhibition, or whether it is a non-competitive inhibition. You just need to identify this here, right? Alright, so let's see an easy trick to identify this. Now, if you see this kind of graph, the first one where you see a cross, they are crossing at points, so it's a cross, okay? Cross starts with C and C stands for competitive, right? So it is a competitive inhibition, right? This cross means that the Vmax, that remains the same because they're crossing at, this is 1 by V. So this crossing means that they are intersecting at the same point. So Vmax remains the same. And if you see this point, it is representing the Km. So when you give an inhibitor, the Km is going to increase, right? Let's talk about the second graph. In the second graph here, you see these two parallel lines. So you can make a U here, right? Just for your, as a trick to remember. So U stands for uncompetitive. So this graph is of an uncompetitive inhibition. So in uncompetitive inhibition, what happens? The Km is reduced and the Vmax is also reduced. You see here, the Km is reduced and the Vmax is also reduced. Then the one which is left in the V form, that is your non-competitive inhibition. So see, if you put N like this, you can make a V here. Remember, so this V is what? This V is your, this graph, right? It's a simple trick to remember. So this is a non-competitive inhibition, and in the non-competitive inhibition, what is happening? The Km here, that is remaining the same. The point is same, so it is unaffected, while the Vmax here, it is getting reduced. Okay. So this is another graph which can be asked in the exam, and you're just simply asked to identify. So this is the trick to identify. Cross means competitive, U means uncompetitive, and the V means V in the N, that means non-competitive, right? Okay. Moving on to the next question, which is again a graph-based question, again very high yield. So this is a graph which is shown of a response versus log dose response curve, and there are four graphs, like one curve is number 2, number 3, number 4. You're asked to identify. So let's see. Drug 1 represents an agonist and drug 2 represents an inverse agonist. Drug 3 represents an agonist, drug 4 represents an inverse agonist. Drug 1 represents an agonist and drug 4 represents an inverse agonist. Or drug 2 represents a partial agonist and drug 3 represents an inverse agonist. So let's see which of the following is the correct statement. So first, to identify what is wrong and what is right, we first need to have a basic understanding of these curves. What is 1, what is 2, what is 3, what is 4. So you see here curve 1, if you see, this is getting you the almost the maximal response, right? So we say this has a maximal response as compared to the others. Number 2, the response is there, but it is less than the first. Number 3, you don't see any response. And number 4, you see the opposite response, right? So what we do is here, so a graph which has the maximum response, it is a full agonist curve. right? So number 1 is your full agonist. The second curve, which is showing the response which is less than the full, it's a sub-maximal response, that is a partial agonist. Antagonist does not have any response of its own. It only has affinity without having any intrinsic activity. So this antagonist is represented by third line, and the fourth one states it's an inverse agonist, which means the action of this is opposite to that of the agonist. So 1, 2, 3, 4 represents full agonist, partial agonist, antagonist, inverse agonist. So let's see from the option which is the correct one. So if you see the first one, drug 1 represents an agonist, yes. 2, inverse agonist, no. So this is not the correct answer. B is drug 3 represents an agonist, no. It represents an antagonist, so again it is wrong. C, drug 1 represents an agonist, yes. And drug 4 represents an inverse agonist, absolutely correct. So this seems to be the correct answer, but still let's go on to the fourth option as well. Drug 2 represents a partial agonist, yes, and drug 3 represents an inverse agonist. Here it is wrong because the drug 3 is an antagonist. So therefore, option number 3 is correct here. Now let's just deep dive in a little more here. So agonist, antagonist, partial agonist, inverse agonist, we know I have defined them. Now they can be also defined in terms of, or they can be segregated in terms of affinity and intrinsic activities, how to differentiate them. So all of them are going to have affinity. Affinity means how much they love the receptor. So all of them, they have an affinity for the receptor, that's why they bind to the receptor. So all of them will have affinity, that's positive for all. But they differ in sense of their intrinsic activity, the response that is produced by them. So maximum intrinsic activity is said to be +1. So I said the maximum effect is seen with agonist. So they have intrinsic activity maximum +1. Now antagonist, it does not have any response or intrinsic activity. So its intrinsic activity is 0. Partial agonist, the response is sub-maximal. So it will be between 0 to 1. It won't be 1, but slightly less than 1. So it's 0 to 1. And inverse agonist, it works in the opposite direction. So therefore, it would be from 0 to minus, or -1 to 0, you can say. So if an agonist is increasing the heart rate, the inverse agonist is going to go in the opposite direction and cause decrease in the heart rate. So these are certain examples. If you see, muscarinic receptors, the agonist is pilocarpine, the antagonist would be atropine. Then a partial agonist example is pentazocine at mu receptors. You can also see here that if we talk about the agonist at the mu receptor, that would be for us morphine, right? Morphine is a full agonist, and antagonist would be naloxone, right? Partial agonist is pentazocine, and we don't have very many inverse agonists in clinical practice, so there are very few examples. So one of the examples is beta-carboline, which acts as an inverse agonist for benzodiazepine. So benzodiazepine receptor, the agonists are like diazepam and flurazepam, all the benzodiazepines. The antagonist at that receptor is flumazenil. There is an inverse agonist also at that receptor, which is your beta-carbolines. All right. So now moving on to the next important term, which is efficacy and potency. Now we discussed the Km and Vmax before. Now they are usually used when we talk about enzyme inhibition. But when we talk about drug receptor interactions, right? Drug receptor interactions, or then we talk about efficacy and potency, right? So drugs, two drugs, we compare that which is more efficacious than the other, or which is more potent than the other. So then we use the terms that efficacy and potency. Both of them more or less mean the same, but here the term used is efficacy and potency. Same graphs, if I make one graph here. So this is the graph, this is log dose, we plot here, and the response we plot here, okay. So we have three drugs. This is drug A, this is drug B, and I have another drug, drug C. So here I have to comment about potency and efficacy of 3 drugs and compare them, right? So let's see how we can compare this for us. Now, efficacy is what? Efficacy is the maximum effect that is produced by a drug, right? And this is determined by the height of the curve. Height of the curve. How tall the curve is in this graph. Okay. Potency is the amount of drug required to produce a certain response or a given effect or a response. And this is determined by the position or the log dose, on the log dose, right? So it is left to right, determined by left to right shift. So if a drug is more towards the left side, it is said to be more potent than if it is on the right side for the same response. So here we have 3 drugs, A, B and C. Now, if we want to compare the efficacy at a given response, so let's say our given response, this one, okay? This is a given response, and here I want to compare the efficacy of 3 drugs, right? Potency rather here, potency of the 3 drugs at a given response. So potency here, how can I say? For this particular response, which A, B and C have achieved, what is the dose which is required to produce a response? So if I comment on potency here, so I can say, see, the more left the drug is, more potent the drug is. So we can say A is more potent than C and it is more potent than, because A is more towards the left, then is C and then is B. As you go on towards the right, because the dose required to produce that response is going on increasing, so you can say that the potency will be decreased. So as you move towards left to right, the potency is going to decrease. So potency, if you have to compare, this is the comparison. A is more potent than C than B. Now let's compare the efficacy. What is efficacy? The maximum effect is produced by a drug. So we just have to see the height here. So here we compare the height. What you can say, that A and B, they have similar height. So we can say A is equally efficacious to B, but they are more efficacious than drugs. So this is a comparison here, right? So a simple mnemonic to remember, we can say a mnemonic of HELP, H-E-L-P. H is height. Height stands for efficacy. So more the height, more the efficacy. L is left. More towards the left, more drug would be potent. So remember this HELP mnemonic. Alright, so moving on to the another important topic, that is the receptor type. So sometimes we have exams make questions that you identify what is the type of transducer system or what is the type of receptors that they are. So we have the G protein coupled receptors, which are of 3 types mainly, S, I and GQ. So their transducer systems vary. So GS, there is increase in the adenylyl cycle, they stimulate the adenylyl cyclase, increase the cyclic GMP. GI is opposite to GS. GS is G stimulatory, GI is G inhibitory. So it will just do the opposite to what GS is doing. So it is going to decrease the or inhibit the adenylyl cyclase, and it is going to decrease the cyclic AMP. Also, it leads to potassium channel opening. GQ has a different transducer system. It activates phospholipase C and basically cause increase in the calcium concentration. Now, let's do the examples. Now, remember a trick here again. In GS system, most of the receptor on which there is which have a GS attached to them, so you will see that they bring about smooth muscle relaxations, not contractions, smooth muscle relaxation, right? Exception is there, but most of it will bring about smooth muscle relaxation. So if you're asked to identify the receptor which is a GS, you just see what is the action on those receptors. So for example, we have a receptor B2, beta 2. Beta 2, what does it cause? It causes bronchodilation. Beta 3, what does it cause? It causes uterus muscle relaxation. bladder. So urinary bladder. So urinary bladder relaxation, right? Detrusor relaxation of the uterus, urinary bladder relaxation. Then we have adenosine. 2, it causes vasodilatation, right? And glands, if they are present, they lead to increase in the secretions of the gland. That's also another important thing. So for H2 receptors, they increase the secretions of HCl. The only exception here to the rule is your beta 1 receptor. So beta 1, it is also GS, but here there is contraction. It causes increase the force of contraction. That is the only exception to the rule here, right? So it can be, you can be tricked into like they give you beta 1, but it causes contraction. But remember, it is a GS type of receptor, but exception is that it causes increase in the force of contraction. GI would be different in the sense that most of the GI, you will see that they cause decrease in the either neurotransmitter release, or they also cause decrease in the secretions, right? So let's see examples. For example, alpha 2, right? So alpha 2 is what it's going to cause. It is going to cause decrease in the noradrenaline secretion, right? Then we have M2, muscarinic. Again, it causes decrease in the heart rate, depressant effect. D2, it causes decrease in the prolactin levels, right? Then we have mu, kappa. They work as analgesics. How? Because they cause decrease in the substance P. Then there is somatostatin. They inhibit the growth hormone. So they are the inhibitory nature, or they decrease the neurotransmitter release. They are wherever they are going to inhibit something. Okay. GQ. Now GQ interesting. They cause increase in the calcium concentration. So definitely wherever they are going to bring about increase in the contraction. So they are going to cause contraction of the smooth muscles, right? So we have alpha 1, which causes vasoconstriction. M1, M3, they can cause bronchoconstriction or urinary bladder contraction. H1 causes bronchoconstriction. V1, it causes vasoconstriction. Oxytocin causes uterine contractions. So it's a very easy way or understandable way to mug up these receptors, because even if you don't remember, it's very difficult to then remember which of the one is GS, GI. But just if you know the way these receptors act, what is the mechanism, what do they ultimately do, you can easily identify that this is the kind of receptor these are. So this is a very good way of, when you understand this, you can easily identify what type of G protein coupled receptors there are. The others are easier to, comparatively easier to remember, because they have very distinct mechanism. You can easily, and there are very few examples. But for GS, GI, G protein, so there are so many receptors which are from G protein. It's very difficult sometimes to mug up all of them. So this is a easy, fun way to actually understand and mark the answer. All right, moving on to the ion channels. Now these ligand-gated ion channels, they have, when an agonist binds to these channels, they cause the movement of the ion. So either they can be positively charged ions, or they can be a negatively charged ion, or the ion can be moving from outside to inside or from inside to outside, right? So depending if it's a positively charged ion, so they are going to stimulate the cell. If it's a negatively charged ion going inside the cell, it is going to inhibit. So either it can be an inhibitory neurotransmitter or a excitatory neurotransmitter, or any of these things. So very, very good, or 3 classic examples which are asked is the nicotinic receptors. So these nicotinic receptors, you know, they have sodium ion channels in between. So when acetylcholine binds to this, for example, in the neuromuscular junction. We have the NM receptors. So when acetylcholine binds to this, what it does? It causes increase in the sodium ion, so the muscles will contract. So skeletal muscle contractions because of this. Then we have GABA receptors. GABA A in the brain, when GABA binds, or when, let's say, benzodiazepines bind, or GABA binds, which is the endogenous ligand here, what they do, they bring about the movement of the chloride ion. So that is inhibitory nature. That's why they are inhibitory neurotransmitters, or benzodiazepines. Therefore, it is used in cases of epileptic attacks because they inhibit the excessive firing of the neurons. Then we have the glutamate receptors. So glutamate receptors, when glutamate binds, it's an excitatory neurotransmitter, and there is movement of sodium and calcium, which is going to excite the neurons. So that's why it's an excitatory one. Then we have the enzyme-linked receptors in tyrosine kinase, JAK-STAT, cyclic GMP, all these kinds of enzymes. So in the tyrosine kinase is linked, while in JAK-STAT it is not linked, it is separate. So what are the important examples here that we should know about? One is insulin, one is prolactin, whereas all the cytokines are important, growth hormone, right? So these are the examples of the enzyme-linked receptors. Then we have the intracellular. So intracellular means inside the cell. So they can be present in the cytoplasm, or they can be present in the nucleus. Ultimately, the ones done in cytoplasm also, they have to enter the nucleus because they are involved in the protein synthesis. So remember, the fastest ones are the ion channels in milliseconds, and the slowest are the nuclear receptors because they require the formation of protein synthesis. So first we'll do the cytoplasmic ones. Remember the mnemonic SAD. S-A-D, SAD. So here we have steroids. Then we have androgens. And then we have vitamin D. The rest of the hormones, basically, they are in the nuclear ones. And it's, another one is vitamin A. So vitamin A, estrogen, progesterone, thyroxine. So they all are the nuclear type of receptors. Okay, so let's move on to the next important topic is the graded versus the quantile dose response curve. So dose response curve. So we have the first one in the graded dose response curve. What is the meaning of this is that this is the log dose and this is the response. So as you go on increasing the dose of the drug, the response is also going to go on increasing. So you go on increasing the dose of the drug, the response will also increase. That is the log dose response curve. So log dose response curve, ideally the shape is, what is the shape? We say it is a sigmoid shape. If it is a dose response curve only, then it's a hyperbola, the shape. But this is an S-shaped or a sigmoid curve. So this is in the response. This is in a single individual, right? The dose you give in a single individual, the response it produces. So it is in a single individual only, right? And what can you actually assess from this particular graph, such graph? You can comment on the efficacy of drug, right? You can comment on the potency that we did before, right? So two drugs can be compared. You can compare, comment on selectivity, how selective the drug is. For example, is a drug like a salbutamol. So we say that salbutamol at the dose of 100 micrograms produces bronchodilation, while at the dose of 600 microgram, it will also cause increase in the heart rate. Why? Because at 100 micrograms, it is more selective for the beta 2 receptors, but when you increase the dose, selectivity is lost. It also starts stimulating beta 1 receptors in the heart. But you have to go 6 times the dose, right? So we can say it is selective in action. Let's say there's another drug which acts on the beta 2 receptors at 100 micrograms, but if you increase the dose to 200 micrograms, then it stimulates beta 1 also. So then we say it is not very selective, right? So there should be a gap between the effect which is desired therapeutic and the adverse effect. So you can tell about the selectivity of a drug. then we can comment on the slope of a drug. So if a drug is like, slope is this, very steep, that means with smaller doses, there is an enhanced response. But if the dose is flat, that means it is a safer drug. Even if you're going increasing the dose of the drug, you won't have a dramatic change in the response. So all this can be made out from the graded dose response curve. But the quantile dose response curve, this is studied in a population. So that was in an individual, this is in a population. And it's usually there is a response, a binary response, yes or no response. So either the drug is producing this or the drug is not producing the effect. For example, sedation. So you will have a drug which produces sedation in 50% population, or it does not produce sedation 50% population. So that is the quantile dose response curve. Now here we have the important concepts here of two, which is therapeutic index and therapeutic window. So what is the important concept? Now this is therapeutic index here that we have shown. So this one here is the therapeutic window. Okay. Now in therapeutic index, it is actually indicating, or it's an indicator of safety. Very important. It is an indicator of safety that is asked in the exam. So what is therapeutic index? So therapeutic index is calculated by LD50 by ED50. Dose which produces the lethal effect in 50% of population over the dose which produces the effective or response in 50% of the population. But I want to tell you, this is not the population of humans that we're talking about. When we talk about death, LD is death. That we cannot do in a human population, right? So LD50 is a term which is used in animal studies only. While in humans, we replace this term LD50 as TD50, toxicity in 50% of the population. So this is a term we use in humans. Okay, now this is a mnemonic I put, TILE, tile. TI stands for therapeutic index, L stands for LD50, E stands for ED50. So how to calculate, if sometimes they ask you, can you calculate here? So if in this graph, if you are asked to calculate, what you have to do? You have to divide TD50 over ED50. So this is the 50% response. So you say the dose which is required to produce 50% response, toxic effect, is 35. So this would be 35 divided by here 15, right? So this is the answer here, right? So roughly about 2.3, or we can say roughly about 2, right? So what does it mean? That you have to, TD50 is equals to, let's say, around 2 times the ED50. So twice the effective dose. If you increase the dose by 2 times, the toxicity will appear. But let's say on another hand, we have a drug where the toxic dose appears at a much later rate. So let's say it is 125. The TD50 is 125 divided by this. So what will be happening here? So it is 5 times. 5 times you require the effective dose, and then it will be a toxic effect. So can we say the drug here? So the drug which requires 5 times its effective dose to produce the toxic effect is much safer than the drug which requires only twice its dose, effective dose, to be toxic to the population. So it is an indicator of safety. More is the therapeutic index, then higher would be the safety margin. So the more safe therapeutic index means more safe is the drug. Less would mean less safe is the drug. That is, therefore, it is called as the indicator for safety. But what is therapeutic window? Therapeutic window just means it is the window between the minimum effective dose and the minimum toxic dose, right? So this is called as therapeutic window, and clinically this is more important, right? So for clinical practice, this is more important, and we actually see this only. So what is the, if you go below the dose, the effectiveness will not be there. If you go above the dose, then there will be a lot of side effects which come into picture. So this is more important clinically, but you should know the difference between therapeutic index and therapeutic window. So these are the few drugs which have a very narrow therapeutic range or therapeutic window. So the importance is that if you have to be very careful while dosing these drugs, otherwise there can be toxicity or you can land into decreased effectiveness. So digoxin 0.5 to 1.4 nanograms per ml, and lithium for maintenance you require 0.5 to 0.8, but acute episode you require slightly higher dose and you should maintain it at the plasma levels of 0.8 to 1.2. Phenytoin is 10 to 20 milligrams per deciliter, theophylline 5 to 15 micrograms per ml, valproate 50 to 100 micrograms per ml. So such drugs which have a very narrow therapeutic window, they are actually a candidate for therapeutic drug monitoring. So we keep on monitoring the drug levels so that we know that we are dosing, whatever dose we are giving to the patient, it is falling within the therapeutic window or not. So with this comes another important question: which drugs, or give examples of drugs which require therapeutic drug monitoring? So we have a mnemonic for this: gentle digits having very low therapeutic index. So gentle digits having very low therapeutic index. So let's see them. What are these drugs? So we have gentamicin, 𝗔𝗔, so this is hydantoin. Hydantoin is a chemical name for phenytoin. Then we have vancomycin or valproate as well, lithium. This we have theophylline, right, and tricyclic antidepressants also. TCAs actually, they have a variability of response in the individuals, right? So no two individuals who might require the same dose of the drug. So that's why another we have to monitor this. I stands for immunosuppressive. Immunosuppressants. So these are the important examples of drugs which require therapeutic drug monitoring. Coming to the types of antagonism, what are the different types of antagonism which we see? One is physical antagonism. Now this is based upon the physical property of a drug. Based on physical property of a drug. For example, activated charcoal can adsorb alkaloids. Okay. Chemical antagonism means two drugs, they react chemically. Or a chemical agent, a drug with a chemical property will produce the effect which is of chemical nature, right? So for example, we have a chelating agent which will react with the poisons or the heavy metals. Iron will react with 𝗕𝗵𝗅𝑜xamine, right? So this is a chemical reaction that takes place. Then physiological antagonism. It's a very interesting antagonism that the two drugs, they act on different receptors, but they produce response in the opposite direction, right? So two drugs, they act on different receptors, but they produce opposite response. This is a very commonly asked antagonism, and a classic example here is adrenaline and histamine. See, why adrenaline is a drug of choice for anaphylactic shock? Anaphylactic shock, the main mediator is histamine, but we use adrenaline because the major issue, like histamine, it acts on the bronchial muscles and it causes constriction due to action on the H1 receptors. Now, adrenaline acts on the different set of receptors, but it causes bronchodilation. So, therefore, it's life-saving in case of anaphylactic shock. Similarly, we have glucagon and insulin. So, they have different set of receptors, but one produces increase in the blood glucose levels, the other produces decrease in the blood glucose levels. Then receptor site antagonism. Now, receptor site is simply that one drug blocks the receptor for its agonist. So, agonist is another drug and it acts on its receptor. So, this is a, let's say, the receptor. Normally, an agonist would come and bind. But what is the antagonist going to do? Antagonist is itself going to bind here, right? So, this is the antagonist, AN. So, this is called as a receptor site antagonism. What is the example here? Let's say the agonist is acetylcholine, right, on a muscarinic receptor, and the antagonist is, right? Alright, so this antagonism, again, this receptor site we have already done before again. So, this is the graph of two types of antagonism that can be seen. One is competitive and the other one is non-competitive. So, this is the graph which is only with the agonist. So, this is when you add a smaller dose of an antagonist and then you add a larger dose of antagonist. It's a competitive antagonist. Remember, for competitive antagonist, the graph will always shift to the right. So, again you see here the efficacy is the same here. If you're talking about the receptors, right? So, efficacy is same height. Help again, HELP. Height is same, efficacy is same. Now, let's see low, L is left and potency, which is more towards the left with agonist. So, as you go on giving the competitive antagonist, because more dose is now required of the agonist to produce the same response in presence of a competitive antagonist. So, you will see here that the potency goes on decreasing. So, there is decrease in the potency. But if you talk about non-competitive, what is happening here? This potency remains the same. But because the height is going on decreasing, so that means the efficacy is dropping. The maximal effect is dropping. So, decrease in the efficacy is there. Okay. Let's move on to another concept here, which is a hospital is conducting a multi-center study to evaluate the efficiency of statins. Each center includes 4 to 5 patients where half receive the drug and the other half receives a placebo. The drug is double-blinded. The study is double-blinded, meaning that neither the patient nor the clinicians know which drug is being administered. Which phase of the clinical trial best describes this scenario? Whether it is phase 1, phase 2, phase 3 and phase 4. Okay, before we answer, let's study these phases first and then we come back and answer the question. So, clinical trials. So, initially we have the preclinical studies. Preclinical studies, which is done in animal, right? Which is done in animals, or they call toxicity studies and all. And an investigational new drug application is filed. Then, if it is approved, it enters into the humans. Now, the mandatory phases start from phase 1, but there is a phase 0, which is not a mandatory phase, but some companies can choose to do this. It's on a very small group of people, healthy human volunteers, and there's no blinding required because they're not patients. No blinding is required. What is the aim basically? We use very, very small dose, less than 1/100th of dose. The aim is to obtain information about the pharmacokinetics. To obtain pharmacokinetic information, right? Because let's say if it is not a suitable pharmacokinetics, we don't want to go into the expensive trials, right? So if we find that it's not very suitable for human use, or the kinetics don't match, then, or it's very not bioavailable or something like that, then we won't want to go into the expensive trials. That's the main aim of this, but it's not a mandatory phase. Mandatory phase starts from phase 1. Now, phase 1, it's mostly dealing with the safety, pharmacological and safety. Again, these are healthy people, 20 to 80, no blinding is required. So, this actually just tests the safety. Most important thing is safety and what is the maximal tolerated dose. That we have to see from the, what are the dose ranges that you can, that ideal range you can identify from this. The second phase is the therapeutic exploratory and dose ranging studies also. Now here the patient, they will grow more patients for 2 to 4 centers. Now here actually the patient starts in phase 2. It can be blinded, can be open label. Blinded means either can be single, double blinded, or open label means when both the patient and the healthcare provider also knows what is being given to the patient. Now this is actually to know about the efficacy and the dose range. Now the third is to compare. So here now you have explored that it is therapeutic. Now it is therapeutic. Now you want to confirm. You confirm it against an already present active drug for that particular disease. Active comparator is there. So you are going to confirm whether it is as good as the previous drug, or it is less effective or more effective, less adverse effects. So what is it? It stands apart. Either it should be equally efficacious and maybe cheaper, or it should be better than the previous drug. So it involves a larger number of centers and more patients, and it is usually double blinded, randomized control or uncontrolled, but it is usually this is the way the trials are designed here. Now this actually is the best phase to confirm the efficacy. So it is the best phase to confirm the efficacy. And we can also tell about the safety of the drug. So when we have all the good reports or good data after phase 3, then the new drug application comes. It is submitted to CDSCO in India, and or rather to the FDA in US, if it is a US trial, if it's taking place, FDA US. So then they study this, and ultimately now the drug enters into the market. So that is where we do all the other studies like post-marketing surveillance, pharmacovigilance studies, etc. done. And now every person will start, all the healthcare providers are going to prescribe the drugs now to a whole lot of population. It's a huge population, obviously. So what is the aim here? Aim here is that you can even find out about the rarest of the ADRs. So the rare ADRs can be detected, rare ADRs. And you can also see the effects in the other population groups which is not done before, like in elderlies or in the pregnant females. So they can also be studied. So rare ADRs basically are done, or they are found here because of long-term ADRs, because you're giving the drug for long period of time. The long-term ADRs, they also can be found out. And this is the phase where you do the ADR monitoring. So it's post-marketing surveillance, or also called as pharmacovigilance studies. They're all done in this phase, right? So in this pharmacovigilance studies, what they do is that all the healthcare professionals, they are responsible. So they can collect the data. They have a form they can submit, and they can collect data, and they will further submit it to the ADR monitoring centers. Like it can be medical colleges, hospitals, and all. There are centers there. So they can give this information there. And then we have various zonal offices for CDSCO, which is in Ghaziabad, in the north, east Calcutta, south Chennai, west Mumbai. So they can submit there. And then at the national the whole information is sent at the National Coordinating Center, IPC Ghaziabad. So you have a form which is called a VigiFlow. That's the software through which the forms can be filled. And then it is sent to the CDSCO headquarters in New Delhi. Then to the main center Uppsala Center, which is in Sweden. And that is how it is communicated. And they then further send it to the FDA and they review it. And if there is a black box warnings and all, they can come into picture if they find that there's a lot of data regarding a particular kind of ADR on a particular drug, then either they can be withdrawn. They have the power to withdraw the drug, to issue black box warnings, whatever is there, that can be done. So this is how it is practiced. It's a very, very important thing to do. All right. Now we go to the answering of this question here. The question was that which of the clinical trial best describes. So you see, you have each center. So it's a multi-centric study, right? So multi-centric study is there where there is a double-blind study, right? And where do you think it is possible? So if it's a multi-centric study, you see here double-blinding study. So this study should be phase 3 because this is a multi-centric study. So the answer here should be phase 3. If they ask you which is the best phase to study or confirm the efficacy, then also it is phase 3. So now next move on to this question is match the following teratogenic drugs with their associated teratogenic effects. So lithium, chloramphenicol, warfarin, thalidomide compared with phocomelia, depressed nasal bridge, gray baby syndrome, Epstein anomaly. So here you see lithium can cause Epstein anomaly, cardiac defect. Chloramphenicol causes gray baby syndrome. Warfarin causes depressed nasal bridge. Thalidomide causes phocomelia. So what is the correct answer here? 1D. So let's see 1D. We have C and D as the options. 2 should be C. So this would be the answer. 2C, 3B, 4A. So let's do some of the important teratogenic effects of various drugs which are contraindicated in pregnancy therefore. So ACE inhibitors or ARBs absolute contraindications because in the fetus they can cause renal defects. Right? So they can cause renal defects, they can cause pulmonary hypoplasias. Warfarin can cause depressed nasal bridge and brachydactyly. Small these digits. So this is a typical depressed nasal bridge seen with warfarin. Phenytoin causes cleft lip or palate. It can cause microcephaly and it can cause hypoplasia of phalanges which are not well developed. Right? So typically you can see here cleft lip that is seen with phenytoin. It's called as fetal hydantoin syndrome and this is called as fetal warfarin syndrome. Valproate. Now valproate, one of the most toxic teratogenic drugs. It can cause neural tube defect and spina bifida. Lithium can cause, it is rare but it can cause cardiac anomaly, like it can cause Epstein's anomaly. Carbimazole, methimazole, this can cause choanal atresia, can cause esophageal atresia, it can cause fetal hypothyroidism or goiter, and it can cause aplasia. Thalidomide, we all know it causes the phocomelia or seal-like limbs, right? So here this is the thalidomide phocomelia and this is the aplasia cutis, which means there is absence of skin on that area, right? Aplasia cutis. Then tetracyclines, they can cause bone defects and yellow deformity. Aminoglycosides can cause fetal ototoxicity. Fluoroquinolones can cause cartilage defects and tendon damage. So these are the most important teratogenic effects, and what are the teratogenic effects that the organ damage that they cause. Now in the pregnancy drug categories, we should not confuse it with the schedules. Don't confuse this. These categories, they are from A to X. A, B, C, D and X. So D and X, these are the teratogenic drugs. Both D and X are teratogenic drugs. But D, we will see if the benefit is more, then we might use them. For example, we have valproate in them. But X, they are absolutely contraindicated. The risk is more than the benefit. So they are absolutely contraindicated. So like thalidomide, warfarin. Now A, B, C, they are safer drugs, and this is the safest out of the lot. So this is what you should know about this. So what are the safe drugs which can be used in pregnancy in various conditions? So for example, there is hypertension, which antihypertensives we can use. So we have labetalol, we have methyl-dopa, we have nifedipine, sustained release, and then we have hydralazine. So for hyperthyroidism, first trimester, we use propyl-thiouracil, and then second and third trimester, we can use carbimazole or methimazole, because propyl-thiouracil is hepatotoxic, can't use them for long term. Methimazole. Epilepsy, we have lamotrigine and levetiracetam. Bipolar disorder, atypical antipsychotics. Anticoagulant, we can use low molecular weight heparin, or heparin can be used. Antimicrobials, beta-lactams like penicillins, they are safer, and erythromycin. Or antimalarials, the best drug is chloroquine, that is safer. So these are the drugs which can be used in pregnancy. Then drug schedules, important. What is the meaning of each schedule? Schedule H. H means hum. Hum in Hindi means us. That means we can prescribe. So these are the drugs which require prescription. So they are sold under prescriptions. G means guidance. So they need supervision, right? Or guidance for administration. Schedule X. X is danger. So these are your psychotropic drugs. Psychotropic drugs, which are kept under lock and key usually. Then schedule Y. Why do you need? Answer the question. So these are the clinical guidelines for clinical trials. Clinical trials. So now we have the new drugs and clinical trial rules 2019. So now we don't use the term schedule Y, we use new drugs and clinical trial rules 2019. Schedule P, P means period, so it tells about the expiry period of a drug. Expiry period of the drug, or the shelf life or expiry period of the drug. W means worldwide. So all over the world, you can only, these drugs, they can be marketed under the generic name only. So these are drugs marketed under generic name. Z. It was a recent question, and this is regarding the veterinary medication. Okay, so these are the important triads and how you can remember by associating them, right? Then few examples of pharmacogenetics which are asked, because this certain population, a population, we are different and we have different enzymes, the way the enzymes function, that some have a fast acting enzyme, some might have a slow acting enzyme. So they can actually change the way a drug behaves in different individuals, right? Some of the important examples you're going to do. First is, there's a drug for tuberculosis which is called as isoniazid. Now, isoniazid is metabolized by acetylation. So, some population, they are slow acetylators which metabolize them slowly, or others are fast acetylators. So, the difference will be, in them, that some will have hepatotoxicity more, some will have the neurotoxicity more. That will depend. So, INH, acetylator status, can be slow or can be fast. This is how the effect can vary in population. The other drugs which are metabolized by acetylation, so these are your shipped drugs, SHIPD, shipped drugs. So we have sulfonamides, hydralazine, INH, procainamide, and dapsone. So they all will have the same problem. Acetylator status is there. So the effects can be different for different population. Then in some population, we give succinylcholine when we give, it's a neuromuscular blocking agent, and it gets metabolized by an enzyme, pseudocholinesterase. But in some population, they have a pseudocholinesterase. Pseudocholinesterase. So what happens in them is that they metabolize the drug very slow. So in such people, there can be succinylcholine apnea. Then people who are G6PD deficient, they can have hemolysis if you give certain drugs. Which are the drugs which can cause hemolysis in this? For example, dapsone, antimalarials, especially primaquine. Primaquine, more than chloroquine and more than quinine or quinidine or quinine. Then INH, then sulfonamides, right? So then we have methylene blue, methylene blue or methylene blue. Okay, so these are the important examples. Then enzyme 𝗕𝗵MT. In people where there is deficiency of this 𝗕𝗵MT enzyme, what will happen? Drugs like azathioprine, which is metabolized by this, or 6-mercaptopurine, because they require 𝗕𝗵MT for metabolism. So they will not be metabolized. So this will lead to increase in the bone marrow toxicity with these drugs. We have CYP enzyme deformity or deficiency or abnormality, right? Abnormality. Certain drugs are activated by these CYP enzymes, they will not be activated, right? So we have CYP2D6. So codeine, it gets activated to morphine with this. Now if this is deficiency, then codeine will not get converted. It's a prodrug. It has to get converted into morphine. So it will no longer be converted into morphine. So it will not have any analgesic action, right? So for warfarin, CYP2C9, for warfarin, it will not be activated properly. So again, it will not behave in the similar manner in the patients. It have a different variable response in different cases. All right, so these are the important examples for pharmacogenetics. Let's move on to another PYQ and then we'll understand what are the different these names or what are the different information that we need to know about this. A pharmaceutical company labels a drug as containing 500 milligrams. So the company labels a drug which contains 500 milligrams of paracetamol, but when you analyze this, we see that drug only contains 200 milligrams of paracetamol. What is this type of drug classified as? So this strip says 500 milligrams paracetamol, but actually there is only 200 milligrams of paracetamol. So what kind of drug is it? What kind of a counterfeit drug is it? So let's see the different definitions here, and then we come back to the answer. So first we go on what is a spurious drug. Spurious drug is a drug where you have a wrong product, or which is substituted partly or completely by another drug, or it can be an imitation of another drug, manufactured under a name which belongs to another drug. So let's say one company like Cipla is very famous, and there's a local manufacturing unit or company which is making, it is selling the drugs by copying the Cipla, the whole thing. It's writing Cipla only on its strip, which is illegal because it doesn't contain the same product as Cipla. So this is called as a spurious drug, right? Misbranded drugs are the drugs which are not labeled in the prescribed manner, and they're made to appear better, or they have false claims. So just like this drug, it is not labeled properly, or there is a false claim, claims that it has a 500 milligrams of a drug, but actually it contains only 200. So it's a false claim. Adulterated drug, which means it is prepared, packed, or stored in insanitary conditions, contains harmful substances or filthy substances. For example, there is a manufacturing unit which was making calcium tablets, and without cleaning up properly the machine, they also started making paracetamol tablets. So in the paracetamol, there is some amount of calcium also present. So this is called as an adulterated drug. So it can happen. Then orphan drugs are drugs which are made for the rare diseases, right? Very rare diseases in India, which affects 1 in 5,000 population. So for example, bortezomib for multiple myeloma, eculizumab for PNH, desferrioxamine for iron poisoning, etc. So these are the orphan drugs, right? That is the important thing here. So out of all these, if you go back to this question, so can you tell me that which is the correct answer here? As I said, it is making a false claim, that is 500 milligrams paracetamol, but actually it's containing 200. So this is called as a misbranded drug. Okay. Then, so this is actually a tablet or a strip showing you what all information should be contained. So it's a name of the drug should be there, the composition should be there, the various temperature it should be there, the name of the company, caution, everything, all should be mentioned as such, right? The expiry and all. So this is the complete information that an ideally a drug strip or a drug, that brand, it should contain. So essential, EDL is essential drug list. What is essential drug list? Is a list which can differ from country to country because it satisfies the healthcare need. The healthcare need for the majority of population. For the majority of population. Right? So it will contain the medications which are most important for that particular area or this region or the country, because more people are suffering from that. So it is more, actually you can say it's more relevant to that particular country. So usually the essential drug list, they have drugs which are cheaper, right? They are in single, they're not combinations, or single drugs. Mostly they're cheaper, they are single drugs, and many favor even the generic drugs. So they should be cheaper, they should be easily available, they should be mostly single drugs, generic form, and that is how the essential drug list is made. So these are the various important concepts, or you can say the various definitions when we talk about different drugs. So these are the drug storage temperatures. What it means that you store the drug at room temperature. What it means that the temperature should be between 15 to 25 degrees centigrade. If they say that cool and dry, it should be between 8 and 15 degrees. Refrigerate means between 2 to 8 degrees. And defreezing means it should be minus 15 degrees centigrade. So sometimes the MCQ asks you what is the meaning of the temperature range for room temperature, cool, dry, refrigerate, or defreeze. So with this, we come to the end of this topic of pharmacodynamics. So let's start with the autonomic nervous system today. So, autonomic nervous system, or the ANS in short, it is divided, we know, into two parts. One is the parasympathetic nervous system and the other is the sympathetic nervous system. Now, the neurotransmitter in the parasympathetic nervous system is acetylcholine, while in the parasympathetic nervous system, mostly it is noradrenaline with a few exceptions. So, we should always know the exceptions. So, exceptions in sweat glands and adrenals here, we have acetylcholine in the sweat glands especially, and adrenals, the ganglion actually relays on the adrenal gland. Then renal blood vessels, we have dopamine. The receptors for parasympathetic system is nicotinic and muscarinic. So, nicotine NN in the autonomic ganglion and NM on the neuromuscular junction. Muscarinic we have M1 mainly, M2 and M3. So, these three are the main receptors, M1, M2 and M3. They are M4, M5 as such till 7 actually, but we are usually concerned with these three are the most important. Then sympathetic nervous system, alpha 1, alpha 2 and beta 1, beta 2, beta 3. So, these are the important receptors. Moving on to the cholinergic transmission here. So, in the cholinergic transmission, please remember the rate limiting step here is the uptake of the choline, right? And the choline uptake by the presynaptic neuron, and it is blocked by a drug called as hemicholine. Okay, so choline and cholinium. Remember that ways. Then once the acetylcholine is formed inside, it needs to get stored in the storage vesicle here, right? So the drug which can inhibit the storage of acetylcholine in the storage vesicle is called as 𝗲𝗍𝗃. Vesa means vesicle. So remember like that, 𝗲𝗍𝗃 inhibits the storage into the vesicle. Third and very important drug, which is your botulinum toxin, it works by inhibiting the release of the acetylcholine, right? So, it is asked in the exam the mechanism by which the botulinum toxin works, and that is by inhibiting the release of the acetylcholine. So, here we have drugs like prabotulinum toxin A, which inhibits the release and it is used for glabellar Botulinum toxin A is used for treatment of strabismus, blepharospasm, and botulinum toxin, if you remember, it is used in case of prophylaxis of severe cases of migraine. Botulinum toxin. Okay. So, moving on to the effects of these parasympathetic versus the parasympathetolytic, or the mainly cholinergic versus the anticholinergic mainly. So, what are the effects on different organ system? Let's do them one by one. The first organ system or first organ we are going to talk about is the eye. Very, very important is the eye. So, in the eye, let's take in the pupil. So, there are two types of muscles here, and one we have these are the circular muscles, and we have the radial muscles. Okay. So, when circular muscles contract, they are going to cause meiosis. When the radial muscles contract, they are going to cause mydriasis. On the radial muscles, the receptors we have are alpha 1, and on the circular muscles, the receptor we have is M3. So, contraction of the M3 receptors is going to cause active meiosis or stimulation of the M3 receptors rather, and alpha 1 stimulation is going to cause the mydriasis, but active mydriasis. But if you block M3 receptors, then there is going to be unopposed action of alpha 1, but that is called as passive mydriasis, right? And if you block alpha 1, there is unopposed action of M3, then that is called as passive meiosis, right? So, that is the difference between active and passive effects. So, use here, let's do the uses here. So, use in case of parasympathomimetic, we have a drug called as pilocarpine. Pilocarpine, which is the drug of choice for closed angle glaucoma. Closed angle glaucoma, right? Mydriasis, which is caused by parasympatholytic, it becomes a contraindication. So, these drugs are contraindicated in glaucoma because mydriasis is not required. So, uses where we have drugs like atropine, we have tropicamide, we have homatropine. So these drugs are used for fundus examination, for testing the refractory errors, right? And number 3, in case of various inflammatory conditions like uveitis, iridocyclitis, basically they break the adhesions. How do they break the adhesions? What you do, you alternate them with the meiotic. So there is meiosis, mydriasis. Meiosis, mydriasis leads to breakage of the adhesions. Moving on to the central nervous system, where the parasympathomimetic drugs, they are going to enhance the memory and cognition. So they are used in case of Alzheimer's disease. So drug of choice here, we have a drug donepezil, we have rivastigmine. So remember, rivastigmine is also available as a transdermal patch. And we have galantamine. Okay. Now, on the other hand, parasympatholytic effect leads to mild sedation and delirium. So drugs like scopolamine, it was initially used for narco analysis. So because in patients, when you treat like from criminals, when you want to extract the tooth from them, so when you give them this drug, they are sedated and they have delirium. They can't lie actually. So it's like a lie detector test in them you use. Then respiratory system, M3 receptor is a predominant receptor here, and stimulation of this M3 receptors causes bronchoconstriction and enhancement of the secretions. So we don't have a use in this case. While on the other hand, the parasympatholytic effect is bronchodilation and reduced tracheobronchial secretion. So here we use them. So this is used in conditions like bronchial asthma and COPD. So COPD, the drug of choice, we have tiotropium. Then we have other drugs like ipratropium bromide and umeclidinium. This is the ultra long acting muscarinic antagonist, right? And this is the short acting muscarinic antagonist. And this is the ultra long acting muscarinic antagonist. Okay. Now, on the heart, M2 receptor, when it is stimulated, it leads to, you can say, depression of the heart. So there is decreased heart rate, conduction, force of contractions. Again, here we don't have a use for this part, but increase in heart rate and conduction can be put to use. And what is the use here? This can be used in case of bradycardia or AV block. Okay. And which is the drug of choice here? We have atropine. So atropine is used 1 milligrams. So that is the use here. On the GIT, there is M3 receptors present and it leads to contractions and increase in the gastric secretions. So initially we use a drug called as bethanacol for post-op ileus. But here we use it rarely now, but yes, it was used because in post-op ileus there is decrease in the contraction, so we can use these drugs. So to decrease the contraction or decrease the gastric secretions. So for decreasing the contraction, so we have the antispasmodic action. So you can use them as an antispasmodic. So antispasmodic action by a drug which is we mainly uses dicyclomine. So decrease the gastric secretions, we use drugs like pyrenzapine, tilenzapine for peptic ulcers. Then on the blood vessels, now M3 receptors, they cause vasodilatation by release of nitric oxide or EDRF. right? Otherwise, the predominant blood receptors in the blood vessels are the sympathetic, alpha and beta. But this, whenever they are stimulated, or then they cause vasodilatation by NO. There's no use as such, and this can be blocked by giving acetylcholine. Now, moving on to another important organ, which is your bladder, and again they have M3 receptors, which is predominant here. So, M3 receptors here, because they will cause bladder contraction. Bladder contraction. That is the important role here. So, bethanechol, the more important use here of bethanechol is to use in post-op urinary retention. Post-op urinary retention, or in case of neurogenic bladder. While on the other hand, the parasympathetic effect would be relaxation. Bladder relaxation. So we have important drugs here. So we can remember 5 dots as a mnemonic. 5 dots. So we take the F of the 5 and the dots. So F here is flavoxate, darifenacin, oxybutinin, trospium and tolterodine, solifenacin. So where do we use these drugs? So they can be used in case of overactive bladder. Overactive bladder or urinary incontinence, there they can be used. Right? Now, important things are, they ask you that most of these drugs, they can also lead to some memory deficits or dementia, because they can also block the M1 receptors in the brain. So which of these drugs are safer in that regard? So darifenacin, solifenacin and this trospium. So they are safer in this regard. So they have less chances of dementia. So they are preferred. And overall, currently we prefer mirabegron for overactive bladder because it has less of these side effects. So otherwise, out of these, we prefer darifenacin, solifenacin and trospium. Alright. The next organ system that we have is the skeletal muscle, that is NM, neuromuscular junction. So contractions are definitely important because of the presence of NM receptors. So what is the use here? Let's say we have a drug called as neostigmine. So neostigmine is a acetylcholinesterase inhibitor which leads to increase in the cholinergic level, acetylcholine levels, which can further act on the NM receptors to cause the contraction of the muscle. So where is it used? So neostigmine can be used in myasthenia gravis, but remember the drug of choice, actually we have pyridostigmine. Again the same class of drugs, but we don't use physostigmine because physostigmine is a tertiary compound. It crosses the blood-brain barrier and we can have side effects. We don't want the effects on the central nervous system, only the peripheral effects. So here we prefer the quaternary compound like neostigmine or the pyridostigmine. So it can be used in myasthenia gravis. It can be used in cobra bite, neurotoxic cobra bite. Then it can be used in for reversal of neuromuscular blocking agents. So in a surgery, we are using neuromuscular blockers. So to reverse the effects, we can use them in this case as well, right? So in these cases, basically, we always combine the drug with atropine. Why? Because all these effects are desired due to their action on the NM receptors. But when you increase the level of acetylcholine, they will also going to, because it's a non-selective drug, a non-selective parasympathetic neurotransmitter. So it is going to act on the muscarinic as well on the nicotinic receptors. But acting on the muscarinic receptors are going to bring a side effect which you do not want. So to prevent that, we initially first give atropine, which is going to block the muscarinic receptors, and then you give neostigmine, because then the only effect would be observed on the neuromuscular junction, right? Okay. So another drug here we have is edrophonium. Now, edrophonium is a very short acting drug. So, if you give this drug, we can use it for diagnosis. Wherever you are doubting, so it can be used for diagnosis of myasthenia gravis. So, if you give this drug, a little bit of the drug, there will be improvement in the patient. So, you know it is myasthenia gravis, and then you can start the treatment. But let's say there is worsening of the symptoms if you give edrophonium. That means it is a case of cholinergic crisis. So, there is over treatment with cholinergic drugs, cholinergic crisis. So, this to diagnose the myasthenia gravis, this is called as the tensilon test. So, what is the benefit to us? So, if you know that myasthenia gravis is there, we'll add on the treatments, or if it is improvement in the case of that person, that means you need to increase the dose of the drug. But if there is worsening of the condition, if there is a weakening of the muscles is because of over treatment with the cholinergic drugs, then the thing is that you need to decrease the dose of these drugs. So, that's how you can evaluate the patient. So, this was for the contraction. Then parasympathetic effect is the drugs which are neuromuscular blocking agents like succinylcholine, matracurium, etc. They are going to cause relaxation. So, they are used in case of surgeries, right? In surgery, we use them along with the anesthetics. Then glands. Glands also have M3. So, all the glands like salivary, lacrime, etc. So, cholinergic system or parasympathetic system stimulation leads to increase in all these secretions. So, we have drugs like pilocarpine and 𝗍𝗪𝗟𝑙𝒻. 𝗍𝗪𝗟𝑙𝒻 is a new drug, but both of them, they are used for treatment of dry eyes, or what we call that a dry eyes and mouth. So, dry eyes and mouth, it is called as xerostomia, where it is a part of a Sjogren syndrome. So, there is dry eyes, dry mouth. So, these drugs are going to enhance the secretion. Decrease secretion use is where it is used preoperative as a part of pre-anesthetic medication. So, we are used drugs like glycopyrrolate. So, glycopyrrolate is going to decrease the secretions. So, this is going to prevent any cases of aspiration during the operation. So, we prefer to use glycopyrrolate because it does not cross the blood-brain barrier. Instead, like in contrast to atropine crosses the blood-brain barrier, but glycopyrrolate, it does not cross the blood-brain barrier. Then in the autonomic ganglion, we have these parasympathetic system is going to stimulate, while the blockers, the ganglion blockers we have are trimethophan, hexamethonium and mecamylamine. So, here trimethophan is used in cases of hypertensive emergencies, but not a very popular drug as such. So, an important topic is organophosphate poisoning or OP poisoning. So, what is organophosphate poisoning? See, the enzyme acetylcholinesterase. So, we have this enzyme acetylcholinesterase, and this enzyme has two important sites. One is the anionic site and other is the esteratic site. So, what usually happens? This acetylcholine, it binds to the anionic site with the help of the N positive. So, this is a negative charge here. So, this electrostatic attraction is there, and then it gets hydrolyzed by action on the esteratic site, right. So this happens in milliseconds. It gets metabolized. But what happens in cases of poisoning? So in case of poisoning like organophosphate poisoning, so these are acetylcholinesterase inhibitors, but they are irreversible inhibitors. So what this drug does is, or this poison does, organophosphate poisoning, the drug binds to the esteratic site. So here this is the organophosphate. It has bound to the esteratic site. So when it binds to the esteratic site, this hydrolysis of acetylcholine does not take place. So when this hydrolysis does not take place, that means acetylcholine gets on accumulating in the body, right? So increase in the acetylcholine levels are going to lead to exaggeration of all the parasympathetic stimulatory signs and symptoms. So you can remember them by the mnemonic, that is dumbbells. Right? So all these symptoms can be seen. So there's going to be diarrhea, increase all the secretions, urination, there's going to be meiosis, there is going to be bradycardia, there is going to be bronchospasm or bronchoconstriction, there is going to be emesis, there's going to be lacrimation, and there is going to be salivation. Right? So all these things are you're going to see in an exaggerated form. So typically meiosis, you want to suspect what poisoning is there. If there is increase in the secretions, it is organophosphate poisoning. If there is respiratory depression, you suspect the opioid poisoning, right? So this is because of the esteratic site. Now, what is going to drug of choice, how you treat it? Because acetylcholine is going to act on the muscarinic as well as the nicotinic receptors. So you want to, these are the life-threatening signs basically are because of the muscarinic activation receptor stimulation. So you want to block the muscarinic receptors first. So therefore your drug of choice here becomes atropine, which is an anti-muscarinic drug. So you give it by the IV route. 2 milligram by the IV route, you give it every 10 minutes till the signs of atropinization come. That means the atropine is slightly going to show its symptoms. The most common you can see is the mydriasis. The pupils will start dilating. So you know that atropine is going to show its effect. Then this is going to take care of the muscarinic symptoms. The most specific drug, we have the oxymes, like pralidoxime, right? So what are oxymes going to do? Now oxymes are going to bind to the anionic site. So let's say we take here the oxyme, and oxyme, it binds to the anionic site. So when the oxyme, it binds to the anionic site, it is going to form a phosphorylate this organophosphate, and it is going to pull it out from here and again free the enzyme. So this is important that it binds to the anionic site. But remember, this whole process needs to take place before the process of aging. What is aging? So this needs to be before aging. Otherwise, this is going to be ineffective. So aging, in aging, the organophosphate bond is going to become very, very strong, and this oxyme is not able to remove it from the site. So it is very time dependent. So within the first few hours, if you get the patient, oxymes are going to work. Otherwise, oxymes are going to fail. So oxymes used here, but remember one thing, there's another poisoning which can be seen with the carbamates. What is the difference between the carbamate poisoning and the OP poisoning? In the OP poisoning, the organophosphate was just attaching to the esteratic site, but carbamates, they bind to both the sides. So they bind to both sides. So you see here that oxymes do not have a site to bind. So in this case, therefore, oxymes are ineffective. So oxymes are ineffective. So they are contraindicated in this case. Okay. So just like this, we have other antidotes which we should be very well aware of, because Antidotes are very favorite. It's a favorite question in the NEET PG exams or the FMG or NICT. So everywhere they ask at least 1 or 2 antidotes. So let's do these antidotes, and we should be very thorough with these antidotes. Very scoring. So let's not miss these. So in organophosphate or carbamide, I told you that first drug of choice in both, it will be atropine. And then we can use the oximes, but not in carbamide poisoning. Remember. Datura, belladonna, atropine. So whether it is atropine poisoning, belladonna, datura, same thing. You give physostigmine, a tertiary compound, not a quaternary compound here. Digoxin, we have digibind or digiFab. Beta blockers, glucagon. Benzodiazepines, flumazenil. Morphine, naloxone. Methanol or ethylene glycol poisoning, we have 𝗕𝗵𝗔𝗀 and we have ethanol. Tricyclic antidepressant and salicylate. So these are acidic drugs. So we need to give an alkaline agent here, sodium bicarbonate. Paracetamol, N-acetyl cysteine. Here the culprit is naphthalene. Heparin, protamine sulfate. Warfarin, vitamin K. Apixaban, XA, 10A antagonist. Rivaroxaban, 10A antagonist. So we have Andexanet alpha. So again 10A, no 10A. So Andexanet alpha. Dabigatran, 𝗙𝗏𝗃𝗏𝗏, right? So dabigatran, 𝗙𝗏𝗃𝗏𝗏. Cyanide poisoning, hydroxycobalamin. We can also use nitrite plus sodium thiosulfate. Methotrexate, folinic acid, or citrovorum factor, or leucovorin. So these are the name of the same compound. So these are the drugs which we can use for the various poisonings. Alright. So important topic is myasthenia gravis, which is asked. So what is myasthenia gravis? Myasthenia gravis occurs when the NM receptors, so these are the NM receptors which are present on the neuromuscular junction. So autoantibodies, they are formed. So they destroy the nicotinic receptors, NM receptors. Then very few receptors will be left for acetylcholine to produce the effect, right? So what can be done here is, the best thing is the whatever, because you know acetylcholine gets metabolized also very fast. So whatever time the acetylcholine is there, at least that time can be increased, so that whatever left receptors we have, acetylcholine gets time to act on those receptors. So we need to increase the stay of acetylcholine here or decrease its metabolism. So therefore we use drugs which increase the levels of acetylcholine or make it stay there for a long period of time. But there are certain drugs which should not be given in such cases, which already there is a weakness of this skeletal muscle. So other drugs which are also causing the weakness of the skeletal muscles, we will not give these drugs. So for example, neuromuscular blockers, right? So they should not be given in case of myasthenia gravis. Aminoglycosides. So aminoglycosides are the protein synthesis inhibitor, but it inhibits the calcium. It inhibits the calcium entry into the neuron. So here calcium entry is important. because then only the acetylcholine is going to go out. But when this calcium entry is blocked by aminoglycoside, the acetylcholine doesn't come out, or it is not released from the presynaptic neuron. So therefore, it is not to be given here. Then we have drugs like calcium channel blockers, or we have morphine. What does morphine do? Morphine causes respiratory depression. So it can, then in such cases already the muscles are not working properly, so it can aggravate the condition. Then magnesium. Magnesium works opposite to that of calcium. It causes relaxation. It is going to also inhibit the release of acetylcholine. So all these drugs should be contraindicated in case of myasthenia gravis. So I told you the tensilon test, it is done with edrophonium. So we use edrophonium 2 milligram IV route, and we diagnose whether this patient has myasthenia or not. Why or how can we diagnose? Because the patient, as soon as you give this drug, will start showing improvement in it. So once the patient is diagnosed, then you move on to the treatment. And the treatment here we have pyridostigmine, that is the drug of choice, along with atropine. Then we have corticosteroids like prednisolone. Then we can use because they are autoantibodies, so we use immunosuppressants like azathioprine and cyclosporin, right? So we can also do thymectomy, we can do plasmapheresis, etc. But these are the drugs that you can use. Then drugs for smoking cessation. So to quit smoking, we have drugs which can be used, and you can remember it by NVB, mnemonic, nicotine very bad, right? So nicotine replacement therapy. So it can be in form of various dosage forms, like we can give patches, we can give lozenges, we can give gums, chewing gums, and we have nasal sprays. And this is a very, very fast method. Then we have varenicline, which is a partial agonist at the nicotinic alpha-4 beta-2 receptors. So what it does, it just maintains a very moderate level of nicotine. The high is not there. So it maintains moderate nicotine levels, right? And also because of this, there is moderate level of dopamine. So when this is stimulated, it's a partial agonist, so there is moderate dopaminergic or the reward system which is activated. So not very high as compared to when the cigarette is smoked. So this is one of the most effective drugs. Most effective. Then bupropion, it is actually an antidepressant drug. It is given as a sustained release formulation and is contraindicated in case of seizures. Now, another important topic here is atropine poisoning, which is asked. So in atropine poisoning, what you will see, all the opposite effects to the dumbbells basically, but what are the significant things that you should note in this is that patient will have mydriasis, patient will have dryness of mouth, there will be tachycardia, there will be hyperthermia, right? So you see these things in the exam question, you immediately come to know that it is atropine poisoning. And what is the drug of choice? We did the antidote for atropine poisoning, that is physostigmine. That is the drug of choice. Remember, because of this problem of hyperthermia, this atropine is contraindicated in children. Okay, this is because of this, it is contraindicated in children, because in children you won't be able to make out, they won't be able to complain. So they'll high fever, And why is this hypothermia occurring actually? Because it causes decrease in the sweating. So it is contraindicated in children, but in children you will see that we use atropine in the eye for children because they are very high tone, so they need cycloplegia. So atropine is used in children, but what is the dosage form in children which is preferred? We use atropine in the ointment form. We don't use the drops because the drops would go through the nasolacrimal duct and they will enter into the systemic circulation and they can have this side effect. So therefore, atropine ointment, this is preferred in children. Preferred in children. Okay. So these are the important points from the parasympathetic nervous system. Going to discuss in this series the autonomic system, nervous system, the sympathetic nervous system part. So let's discuss the effects of sympathomimetic versus sympatholytic drugs on different organ systems. So first, it is the eye, and in the eye, we should know that the receptors which are present in the eye, in the radial muscles, we have the alpha 1 receptors. Radial muscles, okay. So in the radial muscles, we have the alpha 1 receptors, and when you stimulate these receptors, there is going to be mydriasis, which is called as active mydriasis. But on the other hand, on the circular muscles, we have M3 receptors. So in case you block the alpha 1 receptors, there's going to be unopposed action of M3 receptor, which is going to cause meiosis. But that meiosis is called as passive meiosis. Alright, so active mydriasis, which are the drugs which can cause this and we are using them therapeutically? So we have phenylephrine. Phenylephrine, okay. So this phenylephrine is going to cause mydriasis. So we can use this in fundus examination for the testing of the refractory errors. And we are going to then alternate that with the meiotic. So alternate with meiotic for uveitis. So alternating with a uveitis, with meiotic for uveitis. So these are the various uses of phenylephrine. And remember that any mydriatic drug should not be used in people who have glaucoma. So contraindicated in glaucoma patients. On the other hand, the sympatholytic effect like meiosis, we don't have any particular use here for these drugs. On the respiratory system, we have the beta 2 receptors. These are very, very important. So when they are stimulated, they lead to bronchodilation, while the opposite, when you oppose them or when you block these receptors, they lead to bronchoconstriction. So in bronchodilation, we have beta 2 agonists. We have specific beta 2 agonists here. So we have short acting beta agonists. For example, we have salbutamol, we have terbutaline. Then we have long acting beta 2 agonists like formoterol and salmeterol. Then we have very long acting beta 2 agonists like 𝗤𝗚𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏 acting, long acting, very long acting. So remember one of these drugs, which is formoterol. What is the advantage of this drug? It has become the beta 2 agonist of choice during the acute attack. Why? Because not only it is long acting, but in contrast to salmeterol, this also has a quick onset of action. So it has a quick onset of action. So both these things are good for us. Quick onset of action and it has a long duration as well, so we don't have to repeat it again and again, right? So these are the important beta 2 agonists. Bronchoconstriction definitely is not a desired thing, so we have no use here. Then on the heart, we have beta 1 receptors. So when beta 1 receptors, they are stimulated, they will lead to increase in the heart rate, in the force of contraction, as well as the conduction. So here we have a drug which is called as adrenaline. So adrenaline is a drug which we use for this purpose in case of cardiac arrest, right? So in cardiac arrest, and this can be given in 1:10,000 concentration IV in the jugular vein. Decrease in the force of contraction would be the opposite effect when we block them. So decrease in the heart rate, force of contraction, as well as the conduction. So what is the use here? We use beta blockers, right? So beta blockers are very important drugs in cardiovascular system. So we use effect, you want to decrease the heart rate or you want to decrease the conduction velocity. Where do you think that will be good for us? In case of fibrillations, especially AFib, atrial fibrillations or atrial flutter, because we don't want these conductions to be passed on to the ventricles, so we want to prevent the ventricular fibrillations. Then number 2, this is used in case of chronic heart failure, but not in acute heart failure or in chronic heart failure. And you can also say this is compensated, or in other words, we can say it's a compensated heart failure. In low doses we use here. Then it can be used in hypertrophic obstructive cardiomyopathy. Then it is used in case of aortic dissection. So these are the uses of beta blockers according to on the heart, on the organ system. On the blood vessels, we know blood vessels are predominantly dominated by the sympathetic tone, right? So we have alpha or the beta receptors here. So remember a trick here. So this is your blood vessel. So we have either alpha 1 or stimulation would be beta 2. So beta 2 stimulation leads to vasodilatation, alpha 1 stimulation leads to vasoconstriction, right? So remember the simple rule A, B, C and D. That means when you stimulate the alpha receptors, it causes constriction. When you stimulate the beta receptors, it causes dilatation. Simple trick to remember. So beta 2 receptors, actually they are more sensitive. So when you have a smaller dose of the drug, of the sympathomimetic like adrenaline given a smaller dose, then mostly this beta 2 effect will be seen. So even in the body, as says endogenously, the beta 2 effect is always more predominant. But when you give a high dose of adrenaline, then even alpha 2 receptors, they are stimulated. And the predominant action would be because of alpha 1, that is vasoconstriction, right? Alright, so let's see the uses of this. Now, first drug here I want to tell you about is phenylephrine. So let's talk about the drug which is phenylephrine. Phenylephrine is a drug which only acts on the alpha 1 receptor. It has no beta action, yeah? So on the alpha 1, when it is stimulated, there is going to be vasoconstriction. So where do you think we can use it? It is used in case of hypotension due to spinal anesthesia. So postural hypotension due to spinal anesthesia. Similarly, we have another drug that is called as metodrine. So this is the drug of choice for postural hypotension. Postural hypotension. The third drug we have is norepinephrine or noradrenaline. Now this is the drug of choice for neurogenic shock, for cardiogenic shock and for septic shock. Alright, now then we have adrenaline or the epinephrine. So it is the drug of choice. Where is epinephrine the drug of choice? Yes, it is the drug of choice for anaphylactic shock. So it is used in anaphylactic shock, where it has both the beneficial effects due to alpha 1 also as well as due to beta 2. Right? So, alpha 1 action will bring about vasoconstriction. It will increase the blood pressure. It is also helpful in case of to decrease the laryngeal edema. Okay? And beta 2 effects is going to bring about bronchodilation. Alright. Moving on to the other end, which is the sympatholytic effect. So, where do you think can we use the sympatholytic drugs here? So, for example, first we'll start with the blockers. Here we have very important drug which is called as phenoxybenzamine. Now, phenoxybenzamine is an irreversible alpha blocker and it is a non-selective blocker. Okay. So, irreversible alpha blocker, it has a very long duration of action because of this. So, where do you think we can use this? This is used to bring down the blood pressure when we have put a patient up. Pheochromocytoma is a tumor and we want to resect the tumor. But before we do the resection, the surgery, we have to bring down the high blood pressure. So, to bring down preoperatively that high blood pressure, we give phenoxybenzamine. It has a long duration of action, that's why. So, preoperative treatment of hypertension in pheochromocytoma, right? Alright, number 2, we have another drug, phentolamine, which is also an alpha blocker like phenoxybenzamine, non-selective, but it is a reversible blocker. It is short duration, it doesn't have a long duration, short acting. So, here we can use during the surgery of when we are doing the surgery for pheochromocytoma in case of spillage of the catecholamine, when there can be a risk of high blood pressure again rising. So, what we do during the surgery to manage the intraoperative hypertension, we can give this drug. So, this is for treatment of intraoperative hypertension in pheochromocytoma. Pheochromocytoma. Okay. Number 3, or let's say another use of phentolamine can be during the hypertensive emergencies, like in case of clonidine withdrawal or in case of cheese reaction. Alright. Number 3, we have selective alpha blocker like prazosin. It can be used in case when there is benign hypertrophy of prostate along with hypertension. If there is only benign hypertrophy of prostate, then you will give selective drugs like tamsulosin or silodosin. But if there is hypertension also alongside, then we would prefer to give a drug like prazosin because it acts on both alpha 1A and alpha 1B. So, alpha 1B is the area where it takes care for hypertension. Only if you want to treat the BPH part, then only this alpha 1A would be sufficient. So, for this we have drugs like tamsulosin. Okay. So, only alpha 1A we have here for tamsulosin. Alright, moving on to the next, we have beta blockers also. Again, they can be used in management of hypertension, right? So, the beta blockers. So, these are the important uses when we talk about the blood vessels as a target. Then skeletal muscles. Now, skeletal muscles, they have beta 2 receptors, and when you stimulate these receptors, they bring about tremors, right? Because of the contraction. So, tremors is an important adverse effect with especially beta 2A, one of the most common and important adverse effect beta 2 agonists, because they are going to stimulate this. So, sympathetic is blocking the contraction. So, when you give beta blockers, they can treat the tremors. Okay, they can treat the tremors. Then smooth muscles on the uterus or on the bladder. So, they bring about relaxation of the muscles, whether it's beta 2, beta 3, right? So, the bladder sphincter contraction is because of alpha. That's why I told you when we use an alpha 1 blocker, they can be used in case of the benign hypertrophy of prostate here. So first let's do the sympathomimetic effect. So we have beta 2 agonists. So we have beta 2 agonists like 𝗨𝗏𝗏. So this drug especially, not very common, but yes, it can be used in case of to delay premature labor. Premature labor, because it will relax the uterine muscle. So to delay the premature labor. Then we have beta 3 agonists, very important drug group like 𝗲𝗏𝗏𝗏. So this is used because it brings about relaxation. So in case of overactive bladder, we can use them. So use is overactive bladder. So it is very preferred these days for overactive bladder. The other drugs we use for overactive bladder are your anticholinergics also, like the 5-DOTs if you remember. But this is a preferred drug because it doesn't have a side effect like causing dementia by crossing the blood-brain barrier. Alright, so this is the use here. Now in the blocker section, you can say the alpha 1 blocker, right? Like tamsulosin or silodosin. So these are specific alpha 1A blocker. Silodosin. So they can be used in benign hypertrophy of prostate. But as I told you already, alpha 1A plus alpha 1B blocker. This is your prazosin, doxazosin, etc. This is used when we have to treat benign hypertrophy of prostate along with hypertension. Moving on to the next very important graph. So this is a graph which shows you the effect of these various sympathomimetic drugs or catecholamines on the blood pressure. So effect on the blood pressure and heart rate, rather the reflex heart rate I'm talking about here, okay? So moving on to the first drug that we have is norepinephrine. So you can be asked to identify the graph which catecholamine is showing this effect. So norepinephrine, you know that, always remember, this norepinephrine acts on alpha 1, alpha 2, beta 1, and it has no effect on the beta 2. So there is no beta 2 effect. And epinephrine, or the other name is adrenaline, right? Adrenaline. Remember, adrenaline starts with an A. So A means all. It acts on all the receptors. Alpha 1, alpha 2, beta 1, beta 2, beta 3. And noradrenaline means Na. That means it doesn't act on all the receptors. Therefore, beta 2 is excluded. Isoproterenol is only active on the beta, acts only on the beta receptors. No alpha action here. No alpha action. So, norepinephrine, by acting on the beta 1 receptors on the heart, it's going to increase the systolic blood pressure. So, this is the systolic blood pressure. So this is due to the effect on the blood vessels. Remember, ABCD rule. Whenever alpha receptors are stimulated, what do they cause? They cause vasoconstriction, right? So we are going to see an increase in the diastolic blood pressure because it had no effect on the beta 2. So only we see the increase in the diastolic blood pressure. So what will happen to the mean arterial pressure or the MAP? It is going to rise. So there is an increase in the mean arterial pressure. Now always remember, whenever you see the diastolic blood pressure, whether it is falling or rising. So whenever in the systemic circulation there is fall in the BP, so there is going to be a reflex action on the heart. And always a trick to remember is this heart rate, the reflex heart rate will always be opposite to the diastolic blood pressure. So if the diastolic blood pressure is rising, the reflex heart rate would definitely go down. So that's why there is reflex bradycardia. Okay, so moving on to the epinephrine. Now epinephrine, similar effect because of the action on the beta 1 receptors. But on the blood vessels, it has action on both beta 2 as well as the alpha 1. But I told you that endogenously, when we are not giving it from outside, when it's in normal concentration in the body, it acts on the beta 2 more as compared to the alpha 1 because beta 2 receptors are more sensitive. So the predominant effect is going to be of the beta 2 receptors. And when beta 2 is stimulated, A, B, C, D, it is going to lead to vasodilatation, which means fall in the blood pressure. So the diastolic blood pressure is going to fall. So when we find out the mean, the rise in BP is more as compared to the fall in the BP. So ultimately, the mean blood pressure does rise, but not as much as is seen with noradrenaline. Now, what happens to the reflex heart rate? We only have to see the diastolic blood pressure. The diastolic blood pressure is falling, so reflex heart rate automatically will go up. So there is reflex tachycardia. Okay. Now, coming to isoproterenol. Again, same thing. Here, beta 1 receptors, there is increase in the systolic. But diastolic, you see, there is no alpha 1 action. Right? So there's only beta 2 action. So beta 2 is going to lead to drastic fall in the blood pressure. So the diastolic blood pressure is falling here. And again, the heart rate, we have to see it should be opposite, because the fall is so much that there is a tremendous increase in the reflex tachycardia. So if you're talking about the heart rate, the maximum heart rate is increase is seen by the isoproterenol. Then there is the effect of the epinephrine. While if I talk about norepinephrine, there is going to be a fall. So this is norepinephrine, it is epinephrine, and this is isoproterenol, right? Okay, now there's another very important endogenous catecholamine, that is dopamine. So what happens to dopamine? Now dopamine, we'll be doing ahead. It has an effect on beta 1 receptors, dopamine, alpha 1. But on the heart rate, actually, it has very little effect. So you won't see much effect on the heart rate. Remember, for the dopamine, not much changes there. Okay, so now from this graph to another graph, very important, it is like the biphasic response and the vasomotor reversal of Dale phenomena that occurs. So what is first the biphasic response, and then we go on to the vasomotor reversal of Dale. Now, this biphasic response is seen when you give high dose of adrenaline, okay, not the normal, high dose of adrenaline by the IV route. So you directly inject it into the vessel. So what your graph you will see is something like this. So there is a rise in blood pressure and there is a small fall in the blood pressure. The rise in blood pressure is because of action on the alpha 1. Remember the blood vessel we drew here. So alpha 1 and beta 2. Now when you give high dose, both alpha and beta 2 get stimulated, but the predominant effect which is seen is because of the alpha 1. So there is a vasoconstriction. So rise in what? So as now this is a maximum response till here that we see, and after this what is happening is, because you've injected adrenaline now, so now it is getting distributed, metabolized, and it is going to be excreted from the body. So slowly what is happening is the levels of adrenaline are coming down. So as the level of adrenaline is coming down, so you will see the effect on alpha 1 is also lost. So when very less amount of adrenaline is present, the only receptor which is most sensitive is beta 2. So the only effect that you see is because of the beta 2, and beta 2 causes fall in the blood pressure, and ultimately then it will go back to its normal level. So this is called as the biphasic, 2 phases biphasic response. Now let's say this response is here. So again I'll draw this response here. Now after this you give a alpha blocker. So I am now going to inject an alpha blocker here. So let's say I am giving phentolamine, or I can give phenoxybenzamine. So I am giving an alpha blocker. So when I give phentolamine, wait for some time, and again I inject epinephrine. So let's say, so this is the blood pressure here, and now here at this point again I give adrenaline. So what do you think the response will be? So the graph that we get after this is somewhat like this, right? So only what is visible to us here is fall in the blood pressure. So there is fall in BP. There is no rise in BP. Why there is no rise in BP? Because your alpha receptors are blocked by the alpha blocker. So this reversal of the effect of this adrenaline after giving an alpha blocker This is called as vasomotor reversal of Dale. This was seen by Sir Henry Dale. That's why the name Dale, vasomotor reversal of Dale. So it is seen when you give or adrenaline after you have given a alpha blocker. So here one of the previous year MCQ was that identify the drug which is showing this response. So see here, the SPP is rising because of effect on the beta 1. The DPP is also rising. So probably the effect is mainly here alpha 1, otherwise it won't be there. So mean BP is rising, and I told you this would be the opposite to the DPP, though there is reflex bradycardia. So which drug which we just did showed these similar effects? Yes, it was norepinephrine. So this is any graph out of them can be given and you are supposed to identify from that. Now moving on to the important uses of adrenaline. So if you have to do the important uses of adrenaline, just remember this simple mnemonic A, B, C, D, E, K. So A stands for, very important, it is a life-saving drug for anaphylactic shock. Anaphylactic shock. So we use adrenaline in 1:1000 concentration by intramuscular route, and you give 0.5 ml of this, right? You will keep on repeating till the patient improves. So this is the very important, the route of choice is intramuscular, 1:1000 and 0.5 ml. Now, as I told you, the effect is both because of alpha 1 and because of beta 2. So alpha 1 will cause increase in the blood pressure in this patient. It will also improve the laryngeal edema, while beta 2 will bring about bronchodilation. The patient will be able to breathe here, right? Very important. Now in anaphylactic shock, the main mediator is histamine, but histamine acts on the H1 receptors while adrenaline is acting on the alpha 1 and beta 2 receptors. So the effects that we see of both of them are opposite to each other. So this special type of antagonism is called as physiological antagonism, when the two drugs, they are working on different receptors but they are producing the response, the physiological response, in the opposite direction. So we say that adrenaline is a physiological antagonist of histamine. Okay, very important. Okay, moving on to the next use with the B is bronchial asthma. So not now, but epinephrine, not in the regular one, we use that, but epinephrine, it is used in treatment of brittle asthma. C, it stands for cardiac arrest. Okay, cardiac arrest. Again, we use epinephrine, but we use it in the strength of 1:10,000, and that is how we use it by IV route and jugular vein. Because if you use the same strength, 1:1000, the patient will develop tachycardia, 𝗕𝗵𝗔𝗍, ventricular fibrillation, patient will die. So we never use the same concentration, always dilute it further. Alright, then we have D. D stands for duration of action prolonged. Of whose? Of local anesthetic. So it prolongs the duration of action of local anesthetic because we use adrenaline with them, which works as a vasoconstrictor. So it will decrease the, you can say, the systemic absorption of local anesthetic from the site where it is given. So increase the duration of action at that particular area. So it can be given in strength of 1:2 lakhs to 1:80,000. Then it is E. E is epistaxis. So we give compresses of adrenaline. Again, we can use 1:10,000. That is the ratio or the concentration in compression. And K stands for kalemia. So hyperkalemia. So it is also used in management of hyperkalemia. What are the other drugs here? The question is other drugs which can be used for management of hyperkalemia? Yes, we can use insulin and we can use beta-2 agonists like salbutamol. So they can also be used for management of hyperkalemia. So these are the important uses of adrenaline. So moving on to next, dopamine, another very important drug which is asked in the exam. So because dopamine has a dose dependent effect. So all these dose dependent effects are important. Dose dependent effects. So when you give it as a lower dose, less than 2 micrograms per kg per minute, it acts on the D1 receptors and it leads to vasodilatation, especially of the renal blood vessels. So vasodilatation, especially kidneys in the renal blood vessels. So therefore, it will improve the renal blood flow. It can help patients who are oliguric. Then if you use at the dose of 2 to 10 micrograms per kg per minute, then it also will affect the beta-1 receptors on the heart. It will increase the force of contraction of the heart. It will increase the cardiac output. More than 10, then alpha-1 receptor is also stimulated, and because of this, there can be increase in the blood pressure. So mostly for therapeutic purpose, we don't go beyond this 10. Okay. Then similar sounding drugs we have which can confuse students. Let's do them also. One is 𝗕𝗵𝗶𝗃, and the other is phenoldiazepam. So 𝗕𝗵𝗶𝗃, please remember, it has a predominant effect on the beta-1 receptor, less effect on the other beta-2 and all, mostly predominantly beta-1. So for this purpose, it will be very good drug. It is used in congestive heart failure as well, right? And it is also used in case of cardiogenic shock, without hypotension. While dopamine is used in case of cardiogenic shock with oliguria. Otherwise, if there is hypotension, we'll use norepinephrine, right? So therefore we can. So dobutamine has this property. Then phenoldiazepam, it acts on the D1 receptors. This was a recent question, and it is used in case of hypertensive emergencies. Side effects of beta-2 agonists, another high-yield question. So what are the different side effects of beta-2 agonists? Remember 3 T's and 3 H. So first 3 very important side effect we have discussed already. This is tremors, most common. Then the second T, if you give a higher dose of beta-2 agonists, they lose their selectivity, and there are some receptors of present. What happens therefore is they can cause tachycardia. Now in heart, predominantly the receptors are beta-1. There is some amount of beta-2 present, but that is one of the reasons. The other reason is when you give high doses of these drugs, then the selectivity gets lost. So they can also act on the beta-1 receptor. So that is tachycardia. Then the third one is that when you give it for a long period of time, then the patient will develop tolerance to this. H stands for, one is hypokalemia. That's why this is used in case of hyperkalemic periodic paralysis. Then it can also cause hyperglycemia, and beta-2 agonists can lead to hypotension. So these are the important side effects that you must know for the beta-2 agonists. Coming to the beta blockers here, very important are the cardioselective. You should know the names, which are the cardioselective beta blockers. So remember again a mnemonic, mean CAB. So we have metoprolol, esmolol. It is the shortest acting beta blocker. And the longest acting also. Let's do longest acting beta blocker. We have nadolol. Okay. A is for atenolol. Nebivolol N, it releases nitric oxide. They can lead to vasodilatation. Then we have celiprolol, we have 𝗚𝗡𝗏𝗧, bitoxolol, bisoprolol. Bitoxolol is used in case of glaucoma, right? Bitoxolol. Then beta blockers with intrinsic sympathomimetic activity. So they have a partial agonistic activity. So we have a mnemonic 𝗘𝗃. That means co-partial agonistic activity. So we have drugs like celiprolol, oxprenolol, pindolol, and 𝗚𝗫𝒡olol. This 𝗚𝗫𝒡olol, you'll see it is coming in all the classifications. So celiprolol, oxprenolol, pindolol, and 𝗚𝗫𝒡olol. Then we have alpha and beta blockers, drugs which have both the alpha blocking as well as the beta blocking action. The most common we have is 𝗵𝗵𝗏, and the other one is 𝗘𝗅𝗵𝗏. This is one of the most common. So because of the alpha blocking action, so they can have a vasodilatory effect as well. Antioxidant beta blocker, we have 𝗘𝗅𝗵𝗏. Then beta blockers with membrane stabilizing action. So can we have another mnemonic here? Yes, we can have lab map of the lab. So what is lab here? That is 𝗵𝗵𝗏. Then we have metoprolol. Then we have, as I said, ACE is very common, 𝗚𝗫𝒡olol. Then we have pindolol and propranolol. So remember these few drugs with examples. So for MSA, we remember lab map. For ISA, remember 𝗘𝗃, and mean cap for drugs which are cardioselective beta blockers. Uses of beta blockers, important, they are very important group of drugs for pharmacology. So for migraine prophylaxis, for thyroid storm, because they inhibit the peripheral conversion, and also they decrease the sympathetic overactivity. The arrhythmia that we are really dreadful about, that they take care of, decrease the sympathetic overactivity. So all this is taken care of beta blockers. Essential tremors because of the beta 2 agonist, and hypertension with migraine because they are very effective in prophylaxis of migraine, for hypertension migraine. So for all these group of drugs, we have most important is that is the propranolol. So propranolol is the one drug which can be used for all of this. Then moving on to the next one, which is hypertrophic obstructive cardiomyopathy. So in the hypertrophic obstructive cardiomyopathy, what is important is to know that there is increase in the contractility, right? So there is increase or hypercontractility, increased contractility of the heart. Increased contractility of the heart. So beta blockers, which is the drug that we use, is metoprolol. So it will decrease the contractions and therefore it will be helpful in this case. Another drug, a new drug for this, we have, it is called as 𝗪𝗪𝗏. 𝗪𝗪𝗏. So what is 𝗪𝗪𝗏? It is selective cardiac myosin inhibitor. So it will inhibit the actin-myosin reactions, right? So it is helpful, right? So remember, for the first four we have propranolol as the drug, and for HOCM we use metoprolol. Aortic dissection emergency condition, fast acting drug esmolol. Glaucoma we have two drugs, one is temolol and the other is, we just now did the cardioselective one, betaxolol. So temolol is non-selective, betaxolol is selective for B1. But because temolol being non-selective, it is contraindicated in patients of asthma. So we can use betaxolol, but if a patient is of asthmatic patient, we do not prefer to use beta blockers. Though betaxolol is cardioselective, less tendency to cause asthma or aggravate asthma, but still we don't prefer beta blockers. But timolol is absolutely contraindicated because it is acting on both beta 1 and beta 2 receptors, because on beta 2 it will lead to bronchoconstriction. Then let's do the uses of alpha blockers. So for the alpha blocker uses, if it is benign hypertrophy of prostate with hypertension, I told you prazosin would be the preferred drug. Prazosin. Scorpion sting, again the drug of choice is prazosin. It will take care of the laryngeal edema also because of this. Then pulmonary edema. Then pheochromocytoma, always remember for pheochromocytoma, we give alpha blocker followed by a beta blocker. So we can give drugs like phenoxybenzamine or phentolamine and then beta blocker, because if you give beta blocker beforehand, there will be alpha 1 left and it will be unopposed action of the catecholamines on the alpha receptors. So there will be further increase in the blood pressure. That is very dangerous and detrimental for the patient already, right? So already there is dangerous blood pressure. So we give alpha blocker followed by beta blocker. Then in the cheese reaction, clonidine withdrawal, we use phentolamine. So here we can take example of phenoxybenzamine. Okay, so these are the important uses of the alpha blockers also. Contraindications to the use of beta blocker, they are equally important. So let's do the contraindications. We have A, remember, B, C and D. So A is asthma and angina. Angina, which one? Variant angina. B is bradycardia block, AV block. Okay. C is, actually you can say, the congestive heart failure, which is acute in nature. We always give in compensated, never in decompensated. And then C can stand for constricted vessels, like in the peripheral vascular disease. D is diabetes mellitus. So it can lead to loss of the signs of the hypoglycemic symptoms and signs in these patients. So these are the important contraindications to the use of beta blockers. Let's do another important topic here, drugs for glaucoma. So drugs for glaucoma, remember, we have open angle and we have the narrow angle glaucoma or the acute congestive glaucoma. For the open angle glaucoma, prostaglandin F2 alpha analogs, these are the drug of choice. So open angle glaucoma, these are the drugs of choice. So these are your prosts. So we have latanoprost, bimatoprost, then we have travoprost. So what they do, they increase the uveoscleral outflow of these drugs. The important side effects or adverse effects we need to remember is increase in the growth of the eyelashes, which we call as hypertrichosis. Then the C is the brownish pigmentation of the iris, called as heterochromia iridis. Then it can also lead to macular edema. So therefore it is contraindicated in case of diabetes mellitus. Remember, we do not use this drug if there is some case of inflammation like uveitis, iridocyclitis. Why? Because these prostaglandin analogs, these are pro-inflammatory. No? So therefore they will aggravate this condition. So never to be used in case of any kind of inflammation. Then the next group of drugs we have pilocarpine, physostigmine, 𝗏𝗏. All of these drugs, they are going to increase the trabecular outflow, right? So pilocarpine and physostigmine, they are going to work via the M3 receptors. Pilocarpine is a direct miotic, it will cause meiosis. Physostigmine is going to increase the levels of acetylcholine, which will also act on M3 to cause meiosis. So they will increase the trabecular outflow. Now, nitarsodil is a Rho kinase inhibitor, right? And this is going to relax the trabecular meshwork. Trabecular meshwork. Again, it is going to increase the outflow through the trabecular mesh, right? So, these miotics like pilocarpine, physostigmine, so they can lead to brow aches and headaches. They can also lead to follicular conjunctivitis. Then, because of the ciliary contraction, they can cause retinal detachment. Now, nitarsodil can lead to conjunctival hyperemia. Okay, so then we have the next group of drugs which decrease the aqueous formation, and here we have the first group here are the carbonic anhydrase inhibitors. So we have the topical drugs like brinzolamide and dorzolamide. Okay, then IV acetazolamide. This is the drug of choice for acute congestive glaucoma. Now this is given along with mannitol. Then next we have apracnidine, brimonidine, which are the alpha 2 agonists, and 𝗕𝗵𝗡, which is a prodrug for epinephrine or for epinephrine. Right. So these are the alpha 2 agonists. Now important here to know is that brimonidine, it is contraindicated in children less than 2 years of age because it leads to apnea of the newborn. Okay. And it also causes lid retraction. Okay. Then we have beta blockers. Number third, beta blockers like timolol, betaxolol, levobenol and cartiolol. And fourth, we have the osmotic diuretics. Here we have mannitol that we give. Mannitol IV 20%. So we start this mannitol in acute congestive glaucoma, and alongside we also start acetazolamide. So all these drugs together you can remember with the mnemonic A, B, C, D. So A can be the which are the drugs which can act by the alpha 2 agonist. So alpha 2 agonist is A, B is beta blockers, C is carbonic anhydrase inhibitors, D is the diuretic. So this is another way in which you can remember these drugs. So these are the important drugs which are used for the management of glaucoma. So we are going to do today the drugs for cough and bronchial asthma. So starting with what are the important drugs that you should know about the anti-cough drugs, right? So we have, the cough can be two types, either it is productive or if it is dry. So remember, for a productive cough, we are always, our aim is to, so that you can spit out or excrete out whatever the secretions are there. Because if you keep them inside, then, or if you do not, or if you try to suppress them, that will increase the chances of infection. So you want to cough out the secretions. But dry cough usually is very irritating, and we try to just suppress that dry cough. So let's do the drugs for productive cough. So we have two types. One is expectorant, and we have mucolytics. So in expectorants we have guaifenesin, and in mucolytics we have N-acetylcysteine, number 1, and number 2 we have bromhexine and we have Ambroxol. So what is N-acetylcysteine going to do for us? N-acetylcysteine is going to break the disulfide bonds in the mucoproteins. And when it does this, it is going to decrease the viscosity or the thickness of the secretions. Viscosity of the secretion. So what is going to happen? It is easy to cough it out. Then bromhexine, what it does is that bromhexine tries to, or it does, depolymerize the mucopolysaccharides. Mucopolysaccharide fibers, and this also decreases the viscosity. So it makes the secretions less viscous to cough out. Decrease the viscosity of the secretions. Now Ambroxol, actually it is a metabolite of bromhexine. So it does what bromhexine does, plus additionally it also increases the clearance of these secretions. So it increases the mucociliary clearance. So this is the main role of the drugs which are used in cases of productive cough. Moving on to the drugs which are used for dry cough. So here we have basically the drugs which are going to target the cough center. So they inhibit the medullary center and they are going to suppress the cough reflex. So these are your antitussive drugs. So they are called as antitussive drugs. So they can be, number 1, opioids like codeine, pholcodone, hydrocodone. Okay. Then we have non-opioids, because opioids have a problem of addiction. Addiction potential is there. So these non-opioids are free from that addiction potential. So non-opioids which are more preferred: noscapine, dextromethorphan. So dextromethorphan, what is the mechanism? It inhibits the NMDA receptor. Third, we have antihistamines. Allergic cough can be there. So antihistamines like diphenhydramine, promethazine. And then we also have, apart from this, we have peripheral or peripherally acting drugs. So they act at the peripheral level. They suppress the cough impulses at the peripheral level. So peripherally acting drugs. So here we have a drug, 𝗲𝗏𝗏𝗡. So these are the drugs which are used for the management of cough, and many a time it can happen that the cough is because of bronchoconstriction. So we need to add a bronchodilator. So various syrups that we have, cough syrups, they also sometimes contain the bronchodilators like salbutamol. That can take care of the feature of the cough if it is because of bronchoconstriction. Now moving on to the drugs for bronchial asthma. So we are first going to classify them. So What happens when there is bronchoconstriction in bronchial asthma? So there is increase in the hyperreactivity and there is constriction leading to cough, difficulty in breathing. So first and foremost, we need bronchodilators there, right? So bronchodilators, number one, we have the specific beta 2 agonist. So specific beta 2 agonist, we have short acting, long acting, and also we have a very long acting beta agonists. So in the short acting ones, we have salbutamol, terbutaline, and pirbuterol, LABA. So wherever there is metro, formoterol, salmeterol, and bambuterol, so where there is a longer name, formoterol, so there these are the longer acting ones. Then we have very long acting ones. So in very long acting ones, we have olodaterol and indacaterol, even longer. So these are the specific beta 2 agonists. Then we have methyl xanthines like theophylline, doxyphylline, aminophylline, anticholinergics, ipratropium, tiotropium, magnesium sulfate. Then the other group we have mast cell stabilizers and stabilizer mast cells like sodium chromoglycate and ketotifen. Then we have leukotriene antagonists like montelukast, zafirlukast, corticosteroids, hydrocortisone, prednisolone, anti-immunoglobulin E antibody, which is omalizumab, and this is usually we give for persistent asthma. Now remember, we have certain newer drugs also, monoclonal antibodies against these specific interleukins 5 and 4. So interleukin 5, remember, it is associated with the the eosinophils. It is associated with it triggers the eosinophils. Or activates the eosinophils mainly. And interleukin 4 is responsible for IgE antibody production. So therefore, they play a role in this asthma. So these three groups of drugs, they are used for treatment of severe eosinophilic asthma, right? Severe eosinophilic asthma. Now, the first is anti-IL, interleukin 5 antibody, which is mepolizumab and reslizumab, right? So remember, Li means interleukins here, you can see Li, Li, Li. So these are interleukins, you can remember. So they are against a particular interleukin. So there are two interleukins. One is interleukin 5 and the other is interleukin 4. Now, interleukin 5 is the main interleukin which is concerned with eosinophils here. So this Li means interleukin. Now which interleukin? So pollen, also you can say POL rhymes with pollen. So pollen, you know that allergy is because of the eosinophils, and eosinophilic interleukin is interleukin 5. Res, you can say that there is, there is rash. Res will rhyme with rash. There is rash. Rash is there in allergy. Allergy again, eosinophils you can see, and again interleukin 5. So this way you can make an association. So mepolizumab has a pollen in this, so it will be against interleukin 5. Then reslizumab with RES, you remember rash. So rash is there because of the allergy, and that is also again associated with interleukin 5, that is eosinophil. Then we have benralizumab. Now here interestingly, so this is Li is interleukin and R is you consider as receptor. So this is benrali. Okay? So Li, this is interleukin, R you consider as a receptor, and Ben, remember we have a character called as Ben 10. So half of this is 5. So Ben 10, half of this is 5. So this is an interleukin 5 receptor antibody. This was interleukin 5, the ligand. This is against the receptor. So benralizumab, interleukin, R is receptor. So remember Ben 10 is like half of 10 is 5. So interleukin 5 receptor antibody, right? So this is how you can remember. Then we have anti-interleukin 4 receptor antibody. So here we have Dupilumab. So dupilumab, you can remember, dupi is duplicate or duplicate of 2. Du is duo, 2. So when we duplicate 2, it becomes 4. So this is against the interleukin 4. So this is a way of remembering and associating how to remember, because there are so many monoclonal antibodies out there. Very difficult to remember a lot of them, but few we can remember if we put similar associations with them. So here, mepolizumab, breslizumab, benralizumab, dupilumab. Now this benralizumab was a previous year question as well. So that's why this is how you can associate and remember them. Alright, so moving on to these drugs, number 1 is the, what are the drugs that we can give if there is acute asthma, and which drugs are given in case of chronic asthma. So remember, whenever there is an acute attack of asthma, the first thing we need to do is we take care of the bronchodilation, because that will relieve the patient immediately. So here we use bronchodilators. So bronchodilators of choice we have selective beta-2 agonists, right? Beta-2 agonists, other bronchodilators we have are your anticholinergics. Then we have methylxanthines, and we have magnesium sulfate. So all these are given to take care of the acute attack of asthma. Remember, currently along with the beta-2 agonists, we also start now inhalational corticosteroids, because they are going to decrease the inflammation and enhance the effect of beta-2 agonists. So otherwise, chronically, we give corticosteroids as such. We start it, but also it is given for some time. So chronic asthma, we have corticosteroids. Now mast cell stabilizer. So once there is an attack of asthma, then these drugs don't work, because once your mast cell, they have released the mediators, then there is no fun of giving mast cell stabilizers, because an attack has already occurred. So you can prevent the attack of asthma by giving a mast cell stabilizer beforehand, when the months are approaching, or those particular season is approaching, when there is more pollen and the patient is, the patient usually has that kind of an attack. So you can preventively start 1 month before by giving mast cell stabilizers. Similarly, leukotriene antagonists, because in asthma, there is release of leukotrienes and they act on the receptors, leukotriene receptors. So you give a leukotriene receptor antagonist beforehand, so that even if the leukotrienes are released, they will not be able to act on their receptors. But once the attack is there, again these kind of drugs, they will not be of any value to us. Then lipooxygenase inhibitors. Remember, when we did that arachidonic acid, it has 2 pathways. One is the COX, metabolism of arachidonic acid occurs by COX pathway, and the other is the LOX pathway. So COX pathway is associated with formation of prostaglandins, thromboxane A2, and the LOX pathway, it leads to formation of leukotrienes B4 and all rest. So this is the pathway which is responsible for the asthma attack, right? So leukotrienes are going to lead to the asthma. So either you inhibit this like lipooxygenase, so leukotrienes are not formed, or even if the leukotrienes are formed, you need to give receptor antagonist so that these leukotrienes don't go and bind to this receptor. So any of this will work, but again these are preventive methods. Then monoclonal antibodies. So all these monoclonal antibodies, because they take a time to act, so again these are also used for chronic cases of asthma, right? So this is, we have a picture in mind that which drugs will be effective in acute and which drugs are going to work in chronic asthma. So moving on to the first group, we have sympathomimetics here. So sympathomimetics, beta-2 agonists. Most important are beta-2 agonists. So we have short-acting beta-2 agonists like we did sal, butamol, butylene, etc. So they work, or they last for around 4 to 6 hours. The action will last for around 4 to 6 hours. Then long-acting beta agonists like formoterol and salmeterol. Now remember that these drugs, they will produce the effect for about 12 hours, but their onset is also very late. So you cannot give for immediate, when you want to immediately acute attack needs to be suppressed, but yes, for nocturnal prophylaxis or for nocturnal asthma, there you can give. But here the exception to the rule is formoterol. So this formoterol is FF means fast. So its onset of action also is quick. So currently for acute asthma, the drug of choice for us is formoterol because it is solving two problems. Number one, it is acting quickly. Number two, it will last for a long period of time. So we do not need to give the shorter acting ones because we have to repeat them after every 4 to 6 hours. So here the mechanism of action is such that it works for about 12 hours. So formoterol we usually we can start for the acute attack, and along with this we give inhalational corticosteroids, right? Then very long acting, definitely these are only you can say reserved for prophylaxis, not for immediate attack. So we have olodaterol and indacaterol. So they work for around 24 hours, right? So we use them mostly. They are used in not alone but in combination with inhalational corticosteroids. So these drugs are used in combination with inhalational corticosteroids. So there was a drug initially, clenbuterol, but now it is no longer used. Why? Because of it was abused because of its anabolic action. Anabolic action, it got banned because of it. Then the next bronchodilator we have are your anticholinergics because they block the M3 receptors. Now these anticholinergic drugs are the drug of choice for COPD because there the cholinergic tone is very high, or in people who are on beta blockers. Their beta 2 agonist won't work, or people who are on beta blockers. So we have short acting drugs like tiotropium and ipratropium, right? So tiotropium and ipratropium. Then we have long acting drugs like eclidinium. Now this is the longest acting, and umeclidinium, right? So these drugs are longer acting ones. So remember there was a question asked in the previous year that what is the paradoxical bronchoconstriction which is seen with these drugs, the short acting ones, especially the ipratropium. So ipratropium bromide, it can cause paradoxical bronchoconstriction. These are bronchodilators, but it causes paradoxical bronchoconstriction. Why? Now what happens here is that, so this is the innervation or innervating the nerve that is releasing the acetylcholine, right? So here we have the lungs and we have the receptors, the muscarinic receptors here. So here also we have a receptor on the presynaptic neuron and we have a receptor on the effector organ as such. So here the receptor is M3 and here we have the M2 receptor. We know that the receptor which are actually present where on the presynaptic neuron, they're always, whenever they are stimulated, they are going to decrease the release of neurotransmitter because they are brakes. Whenever you stimulate them, they apply brake and acetylcholine will not able to release. So when you give drugs like ipratropium, because it is not very selective for M3, it also acts on M2. So because it acts on M2, it will cause a transient increase. M2, you are blocking the M2 now, so you are releasing the brake. So there is going to be a transient increase in the acetylcholine. This acetylcholine is responsible for the brief bronchoconstriction. Then later on it is going to act on M3 and then it is causing bronchodilation. But this transient bronchoconstriction is because of the action on the M2 receptors. Now this is not seen with tiotropium. Why? Because tiotropium is selective for M3. So this is mostly seen with ipratropium bromide. Moving on to theophylline, another very, very important drug for examination point of view, very often asked. So theophylline, it has a narrow therapeutic index, so the range should be between 5 to 20 microgram per ml, right? It follows zero order kinetics or the enzyme saturation kinetics. Example of that. Now, how it works? Now, theophylline has a bronchodilator property also, and it has an anti-inflammatory action also. So, bronchodilator property is by number 1, it is a phosphodiesterase 3 inhibitor. It inhibits mostly phosphodiesterase 3 as compared to phosphodiesterase 4 mainly. That is one way of causing bronchodilation. Number 2, it also inhibits the adenosine 1 receptor, because adenosine receptor is associated with bronchoconstriction. So, when you block this receptor, there is bronchodilation. Now, how is the anti-inflammatory action coming about? This is because of increase in the histone deacetylase in the airway inflammatory cells. Inflammatory cells. So, this is the way how the anti-inflammatory action comes into picture. So, two actions. Now, another very important question which is asked usually are the ADRs of aminophylline or theophylline. Now, it shows certain ADRs because of phosphodiesterase inhibition, certain ADRs because of A1 inhibition, and certain ADRs are because of combination of the both. So, what ADRs are there because of the phosphodiesterase inhibition? So, remember P and D. So, let's see. P, you remember for pet. Pet in Hindi means the stomach. So, the pet in Hindi means the stomach, right? And in the stomach, it causes nausea and vomiting. D means damag. So, remember damag means brain. So, it causes headache. So, this is how you associate. So, P and D, pet and damag, stomach and the brain, nausea, vomiting, headache because of this. What is left with us is that it can cause diuresis and it can cause seizures. Okay, diuresis and seizures. You can also remember here SAD. Seizures, A1 and diuresis. Then, due to both, it can cause arrhythmia. Right? So, this is how you can remember the various side effects which is associated with various receptors. Then leukotriene antagonist, they are going to be used, as I told you, prophylactically only. Prophylaxis for chronic persistent asthma. The main ADRs we should be worried about is hepatotoxicity and 𝗔𝗫 syndrome. Okay. Mast cell stabilizers like ketotifen and sodium chromoglycate. So, what are they going to do? They are going to stabilize the mast cell so that the mediators, they don't release. That is the role of mast cell stabilizers. Okay, and even one more is nidochromil. Okay, then moving on to the steroids. Now, steroids that we mostly use are the inhalational corticosteroids. Until and unless there is refractory asthma, we prefer to give inhalational corticosteroids because one, they will directly target the organ site and they will have less of systemic side effects are less. So, we have beclomethasone and budesonide. So, these are your drug of choice for the asthma which is persistent, right? And they are used along with formoterol in case of acute attack of the asthma, right? Now, fluticasone is one of the most potent drug here. Then we have triamcinolone and cyclisinide. Remember, for cyclisinide, this is a soft steroid. Soft steroid means it is a steroid. It's actually a prodrug and it changes into the active form, in the lung, right? It is activated only in the lung. Therefore, it has less tendency to cause the oral thrush. So, therefore, there is no oral thrush seen with this. Okay. The oral steroids like prednisolone, this is given only in case of refractory asthma. Otherwise, we give inhalational steroids. This is only in case of refractory asthma. IV steroid is hydrocortisone. So, we give IV hydrocortisone 100 milligrams. Now, this is given in case of status asthmaticus, right? Status asthmaticus. Now, ADRs of steroids, especially the inhalation which are more common, what is this? Number one, it leads to oral thrush or oral candidiasis, right? So, to prevent this, what we tell the patient is that every time they take an inhaler or the puff, they need to rinse their mouth, and secondly, they can use spacers. So, you can decrease the way or decrease the occurrence of oral candidiasis. But if it occurs, what is the treatment? You give the antifungal nystatin, or you can give 𝗘𝗅𝗰𝗶𝗏, right? So, these are the antifungals which can be given topically. Number two, the most common ADR that we can see with this is hoarseness of voice. That's the most common. So, these two, oral candidiasis, hoarseness of voice, you must know the ADRs for this. So, management of asthma as such, if we talk about, is that for acute attack, please remember, we give formoterol and we start concurrently inhalational corticosteroids. For prophylaxis or chronic asthma, what we do? We add on drugs like leukotriene receptor antagonists, or we can add on 𝗙𝗵𝗄𝗏, because if it is not getting controlled. So, these are the important drugs that you must know from the topic of cough and drugs for bronchial asthma. So, today we are going to discuss about anti-diabetic drugs. So, first we are going to do the classification. So, what are the different anti-diabetic drugs that we have? So, we have the oral anti-diabetic drugs. Here, the drugs which are going to enhance the insulin secretions. Here we have number one, the drugs which act on the ATP sensitive potassium channels, or they are going to block them, which are sulfonylureas and meglitinides. Then we have drugs which are going to inhibit the DPP, the enzyme which is responsible for metabolism of GLP. So, these are your gliptins, DPP4 inhibitors, sitagliptin, vildagliptin, etc. Then we have drugs which are going to overcome the resistance. These are bigonides, which is metformin, thiazolidinedione, that is pioglitazone. Then drugs which inhibit or retard the absorption of carbohydrates from the intestine, which are your alpha glucosidase inhibitors like acarbose, voglibose, miglitol, and very, very important drugs which promote the excretion of glucose, right? So, these are your glucose SGLT2 inhibitors. So, these are your gliflozins, very, very important for the examination point of view. So, now we are going to first do this MCQ which was asked in the previous year paper. Which of the following drugs is least likely to be associated with pleural complications? Metformin, methiazide, bleomycin, nitrofurantoin. So, out of them, Metformin is the correct answer. It has nothing to do with the pulmonary, very least likely to be associated with pulmonary complications, while the others like methisogire, bleomycin, nitrofurantoin, all can lead to your pulmonary complications like fibrosis, etc. Okay, so this was one of the previous year questions from this chapter. All right, moving on to the various drug groups and very, very important features for each one of them we are going to highlight. So first one is sulfonylurea. Now sulfonylureas, they actually have two generations. The previous one, which is no longer available or no longer used, we have the first generation sulfonylureas and the second generation, the newer ones that we are using in the currently. So glimepiride, gliclazide, glibenclamide, all of these actually are your second generation drugs. Second generation sulfonylureas. So what is the mechanism of action of second generation or sulfonylureas as such is, so sulfonylurea, so this is actually a beta cell of the pancreas, right? So beta cell of the pancreas, you know that it causes release of insulin whenever there is glucose when it comes in, so that triggers the release of insulin. So in your diet, when you eat any diet or food which consists of carbs and the glucose is released, so by GLUT2 it gets transported inside the beta cell of the pancreas and it leads to release of insulin. Now, what happens in case of when you're going to give it to the diabetic patients, you want to enhance the insulin release here. So, we give a sulfonylurea. This is sulfonylurea drug. Now, on this beta cell of the pancreas, there are channels which are called as ATP sensitive potassium channels. So, when sulfonylurea is given, it acts on its receptor, which is called sulfonylurea receptor. So this receptor is present on this channel. So when sulfonylureas bind to this, they are going to cause the closure of this channel. So they are going to close this ATP sensitive potassium channel. You know, these potassium channels, the potassium normally moves from inside the cell to outside of the cell. So when this channel is now blocked, this potassium ion will be accumulated inside, and when this potassium ions accumulate inside, there's going to be increase in the positive charge, right? So this causes depolarization of the membrane. It leads to triggering or of the stimulation of the voltage gated calcium channels and leads to entry of calcium inside a cell. This calcium entry inside the cell, it leads to release of the stored insulin, and that is how insulin is released. So they are insulin releasers. That's how we call them. They are insulin releasers. And they block the ATP sensitive potassium channels. Now this insulin release is independent. This is independent of the glucose, blood glucose, independent of blood glucose. What it means is, even when blood glucose is there or not, it doesn't depend. That's why the chance of hypoglycemia is really, really high with this group of drugs. So therefore, there is increase in the risk of hypoglycemia. Okay, so this is one of the major adverse effects. So any drug which is going to cause the release of insulin, mostly you will see their side effect. One main side effect is hypoglycemia, and secondly, because insulin is an anabolic hormone, it can lead to increase in the weight. So it causes increase in the weight. So weight gain is there because of insulin being a anabolic hormone. So these two are the important side effects we need to be very, very careful with: hypoglycemia and weight gain. So therefore, if the patient is already obese, you would not like to give this drug. Now, just a one line about the first generation drugs, which are now no longer used now. So the first generation sulfonylureas were tolbutamide and chlorpropamide. So only thing I would want you to know about this is that this 𝗘𝗅𝗵𝗏 is responsible for SiADH and it can lead to disulfiram-like reaction. And 𝗏𝗏𝗏𝗏𝗏𝗏, it follows zero order kinetics. So these are the important things that you need to know about this. Now moving on to the second group of drugs, we have meglitinides. So meglitinide, they work by similar mechanism just like sulfonylureas. So they also block ATP sensitive potassium channels, but their receptor site is different. Otherwise, do the same thing, right? Now, what is the difference from sulfonylureas? Sulfonylureas are slower acting, while these are rapid acting. These are rapid acting and they have a short duration of action. So, therefore, they are used for treatment of post-meal or postprandial hyperglycemia. So, it needs to be given before the meals, right? So, given before meals. And if the meal is skipped, suppose the person is not going to have the meal, then you are going to skip this drug as well. Otherwise, similar problem, the adverse effect it can cause is, major problem is hypoglycemia, especially if you combine with the drug, another drug. Then we have GLP-1 agonists. Now remember, GLP-1 agonists. So what is GLP? GLP is endogenous in our body, and GLP-1, the role of GLP is to increase the glucose dependent, right? Remember, it is not independent, glucose dependent insulin secretion. That is number one. Number two, GLP-1 also decreases the gastric emptying. So the patient will be feeling full for some time, right? For a long period of time. Also, it increases the satiety by acting on the hypothalamus, which means that patient has a feeling of fullness. So GLP-1 agonist means they are going to mimic this action. So they are going to mimic the endogenous GLP-1, right? So endogenous GLP-1. So this is how they are going to act. This is their mechanism of action. Now, these group of drugs, they have a low chance of, they have low incidence of hypoglycemia. All these drugs are given by the subcutaneous route except semaglutide, which also is given by the oral route. So what are the ADRs associated? So GIT ADRs like nausea, vomiting, pancreatitis, weight loss, and this weight loss has been put into use now. So these drugs, because of this weight loss feature, they are also used now, approved for use for obesity. Okay. Contraindication to the use is like if the patient has a history of or has thyroid cancer or family history of medullary carcinoma, MEN2 syndrome, then we don't recommend this drug. So contraindicated in thyroid cancer. Okay. All right. The next we are going to do about one or two drugs important, just to know the names and their uses. GLP-2 analog. So they were GLP-1, the GLP-2 analog, we have a drug called as 𝗕𝗵𝗔𝗚. So this is a GLP-2 analog and it increases the intestinal mucus growth. Sorry, mucosa, not mucus, intestinal mucosa growth. Therefore, it is used for short bowel syndrome. It is not used for as an anti-diabetic. It is used for short bowel syndrome. So remember this about teduglutide. Then we have a drug which has a dual action, acts on GLP-1 and GIP-2. Similar actions to both, so there is doubling of the action because we know what is the action of GLP-1. GIP also causes increase in the insulin secretion. It increases the fat metabolism and it also increases the insulin sensitivity. So this is because of GIP. So it is combining the effect of both GLP-1 and GIP. So it has a very stronger action as compared to alone GLP-1. So their use is for diabetes with obesity. So they are anti-diabetic, and if the patient is obese, they help in the weight loss of the patient also. So this is a important use of your GLP-1 and GIP analog. Oh, the drug, yes, the drug which is important here is 𝗕𝗫𝗃𝗏. Okay, 𝗕𝗫𝗃𝗏 is a drug which is GLP-1 and GIP analog. Remember, it's an important drug to know. Then we have DPP-4 inhibitors. Now, what is DPP actually? So DPP is an enzyme which metabolizes GLP-1 and GIP. So if you want to increase the level of GLP-1 and GIP, you give an inhibitor of this enzyme DPP-4. So when we give these drugs, they are going to inhibit this enzyme, right? And therefore the level of GIP and GLP-1 will automatically be there for a longer period of time. So that's what they mostly, that's how they work. So the drugs are also called as gliptins, right? Because the suffix is gliptin for all these drugs. Sitagliptin, saxagliptin, linagliptin, vildagliptin and allogliptins, right? Okay, so remember saxagliptin, it is not used because or it has a higher tendency to cause heart failure. Vildagliptin banned because it was hepatotoxic. All of these drugs also will have to be monitored for their liver function tests. Therefore, while the patient is on these any of this drug, right? So, what they do, we have increased the GLP-1 and GIP. So, they definitely they also increase the glucose dependent insulin secretion, right? So, that's their mechanism of action. So, what are the adverse effects? So, the most common adverse effect linked to them is nasopharyngitis because of the substance P accumulation, and this is the most common. Then rare is there, but pancreatitis they can cause, though it is rare. I told you all of them, we have to monitor them for hepatotoxic potential as well. So, hepatotoxicity, and they can have a tendency to increase the risk of heart failure. So, we have to be careful in them. Now, remember that these drugs, they are weight neutral drugs. So, there is no increase or decrease in the weight. So, these are weight neutral drugs, right? Very important to know. All are contraindicated in kidney disease except linagliptin and another is tenagliptin. So, all are contraindicated in kidney disease or renal disease except linagliptin and tenagliptin. Becomes an MCQ question. Exceptions you have to know which of them is not contraindicated or it is safer to be used in renal disease. So, other drugs which are safe or anti-diabetic drugs which are safe in the kidney or renal disease or renal failure, yeah, these two we've done, teneligliptin, linagliptin, then albiglutide, semaglutide, dulaglutide and pioglitazone. These are other antidiabetics safely which we can give in the renal failure. Moving on to the next important drug, which is an insulin sensitizer, that is metformin. So they belong to the group of drugs called as bigonides. Initially, before metformin, we had fenformin, but that was withdrawn because of the risk of lactic acidosis. Now, metformin, it is an insulin sensitizer and it is called as an anchor drug. What is the meaning of an anchor drug? That this forms the base, and or we keep on adding the other drugs around this base. So that's why it's called for the anchor. So mostly used with most combination therapies. Used with most combination therapies. Now it is a drug of choice for type 2 diabetes mellitus until unless there is a contraindication. Now, it is also used for other conditions like PCOD, okay, polycystic ovarian disease, where it leads to decrease in the insulin sensitivity. Then, non-alcoholic fatty liver disease. Again, it can disease the insulin sensitivity. Then, in typical antipsychotic induced metabolic syndrome, where there is weight gain or there is increase in the blood glucose levels, there also these can be used. Now, how they work exactly is by stimulating an enzyme, AMP kinase, and this is going to cause inhibition of the gluconeogenesis. Also, they increase the peripheral glucose utilization, and it also decreases the absorption of glucose from intestine. So these are the main roles of metformin, how they work, how this works actually. Adverse effect, the most common adverse effects seen with metformin are the GIT-ADRs, like that is the diarrhea, most common. Others, because it decreases the absorption of not only glucose from the intestine, but also the vitamin B12. So it can lead to megaloblastic anemia because of decrease in the absorption of vitamin B12. Now, in an otherwise healthy patient, this lactic acidosis is not seen with metformin, but in case there are certain group of patients or there are certain diseases which are in the patient, then the risk of lactic acidosis will go high. So, it can cause lactic acidosis if the patient has any kind of hepatic or renal disease. If the patient is of COPD, smoker patient also, patient is in shock, alcoholics like CHF. So in all these, if there is diabetes with any of these conditions, then metformin is not a safe drug here because it can increase the incidence of lactic acidosis and such. You'll have to stop giving the drug here and look for some other alternative. Moving on to the next group, which is your thiazolidinediones, and the other name is glitazones, because all of these drugs, they end with the word glitazones. We have pioglitazone. This is the only drug available in India, right? Troglitazone was there, but no longer because it is hepatotoxic. Rosiglitazone in India is not used because it has increased risk of myocardial infarction. So only drug here we have is pioglitazone. And what is the mechanism of action of pioglitazone or thiazolidinediones? That they stimulate the PPAR gamma receptor. PPAR gamma receptor, which is actually a nuclear receptor. And this is present in the adipose tissue, on the muscle and on the liver as well, but mainly on the adipose tissue and the muscle. So what it does is, it will increase the peripheral utilization of glucose in these tissues, increases the peripheral utilization or uptake, what do you call it? Peripheral utilization or uptake of glucose in these tissues. Therefore, it will increase the, what you call that, insulin sensitivity, increases the insulin sensitivity. All right. So this is the role of these drugs. Now we have a drug which not only is an agonist on the PPAR gamma but also an agonist on the PPAR alpha. So the drug name is 𝗤𝗪𝗡𝗪. 𝗤𝗪𝗡𝗪. 𝗤𝗪 means Sara. It both alpha as well as gamma agonist, right? 𝗤𝗪𝗡𝗪. Another we have 𝗪𝗪𝗡𝗪. 𝗪 means all. In English, Sara means all. So Saro and 𝗪 both, they are going to block both PPAR alpha and gamma. They are going to stimulate both receptors. Now gamma function, we know that it stimulates when the PPAR gamma is stimulated. It leads to increase in the insulin sensitivity. But what about alpha? So this alpha, it is PPAR alpha. They are going to stimulate an enzyme called as lipoprotein lipase. And this is involved in the breakdown of triglycerides. So they cause breakdown of triglycerides. So it is going to be helpful therefore in case of dyslipidemia. So diabetic dyslipidemia, this is the drug we can give because it takes care of the diabetes as well as the dyslipidemia. So the use is diabetic dyslipidemia. Okay. Now, what is this major adverse drug reaction with this? So, ADRs, they lead to sodium and water retention. So, they cause sodium and water retention. So, because of this, they can cause weight gain. Number one, because of this, it can precipitate congestive heart failure. So, absolutely contraindicated in patients who have already there is a history of heart failure. Then in post-menopausal females, it can increase the risk of fractures, bone fractures. Then hepatotoxicity. Pioglitazone, if we use them for a long period of time, like more than 2 years, there is associated increase in the risk of bladder cancer. More than 1 year use of pioglitazone. So these are the important adverse effects which you need to know about thiazolidinediones. Coming on to the next important and very, very popular group these days, that is gliflozins or SGLT2 inhibitors. So these are canagliflozin, dapagliflozin, empagliflozin, and ertugliflozin, sotagliflozin. Now remember this SGLT2. What is the role of SGLT2 here? Basically is on the kidneys. There is this transporter, SGLT2. Now SGLT2 transporter, it can lead to transport of sodium and glucose inside, right? Now what these inhibitors do, they are going to inhibit the transporter. So whatever sodium and glucose is there, it is going to then be excreted out. Sodium, right, and glucose. It's going to be excreted out. So there will be increase in the level of sodium and glucose in the urine, but it is not going to be transported back into the body. So this is how they work. right? Now, because of this, less sodium, less glucose in the body. So, they are going to enhance the excretion of glucose, right? By inhibiting SGLT2 in kidneys. Now, SGLT2 is present in the kidneys, yes, but SGLT1 is also present in the intestine. So, SGLT1 in the intestine, it will lead to decrease in the reabsorption, or you can say the absorption of glucose in the intestine. So, this drug, 𝗪𝗪𝗡𝗪𝗪𝗔, it is going to inhibit both SGLT1, which is present in the intestine, and SGLT2, which is present in the kidneys. So, what it does, यहाँ पे in the intestine, it inhibits the reabsorption of glucose, or rather I say absorption of the glucose, in the intestine, while in the kidneys, it is inhibiting the transport back into the body. So, both these effects are going to enhance the glucose or level. It is going to go out and decrease the levels of glucose in the blood. That is the role of this. Now, because of this mechanism, not only is it excreting the glucose, if you see, they're also excreting sodium ions. So, this is a very, very good drug if patient is of diabetes mellitus type 2, along with heart failure with reduced ejection fraction. Okay? So, this is heart failure with reduced ejection fraction. Your drug of choice or the best drugs available are your gliflozin. So, not only are they taking care of the diabetes mellitus, but they're also taking care of the heart failure. So, one of the very, very good drugs. It decreases mortality in the heart failure patients. ADRs. Now, because most of the glucose is going to go into the urine, so there is a risk of having urinary tract infection. There can be risk of, in females, there can be risk of vaginal infections. Now, it can also, because sodium is being lost, it can lead to hypotension. Very rare, but yes, it can lead to diabetic ketoacidosis. Ketoacidosis, though it is a rare thing. Then, long-term use can increase the fracture risk. Now, it's not gender-based here, so it will just increase the fracture risk and weight loss. So, all these things are to be kept in mind when we are studying about the SGLT2 inhibitors. Other drugs which are there, like alpha glucosidase inhibitors. So, basically what they're going to do, they're going to inhibit the breakdown of complex carbs into simple carbs. So, therefore, there is no absorption. So, it's not going to be absorbed easily into simple carbs. Main adverse effect because of this, which is very common, disturbing, is flatulence. It's the most common. Also, there can be diarrhea because of this and pain abdomen. That's why it is not, patient don't really tend to take it that often because of flatulence and this. Amylin analog, which is pramlintide, it will help in decreasing the blood glucose levels, blood glucose levels. And it also delays gastric emptying. Now, this is one drug which is approved for both type 1 and 2 diabetes mellitus. Most of the other drugs, because they are mostly approved for type 2, why? Because their insulin dependent actions are there. In type 1, the insulin is deficient. So, therefore, this is the drug which is approved for type 1 as well as type 2 reactions. So, the major adverse effect will be like nausea, vomiting. It can also cause weight loss because of delayed gastric emptying. Then bile acid sequestrin, cholecalciferol, they are going to inhibit the absorption of glucose from the gut, decrease glucose absorption from the gut. Dopamine 2 receptor agonist, the new one here is bromocriptine, which is also this newer use has come up. Why? Because it takes care of the circadian rhythm, right? So it takes care of the circadian rhythm. It sets the circadian rhythm. Newer drug group is glimins, which is imiglinin. Now, it has a very unique mechanism of action that they act on the mitochondrial level, mitochondria, and therefore improves the beta cell function of the pancreas, and it increases the peripheral utilization also, peripheral glucose utilization. So, it's a newer drug group with a distinctive mechanism, so how likely that it can be asked in future examination. Acts on the mitochondria, improves the beta cell function, and also increases the peripheral glucose utilization. Can cause nausea, vomiting, and fatigue. So, of all the ADRs you've done before, so let's see if we can solve this MCQ. Which of the following anti-diabetic drugs is linked to an increased risk of fracture? Now remember that we have done it with glitazones also, we have done it with gliflozin also. But if it is not specifically gender, the gender is not there given, so we would like to mark gliflozins until as especially female predisposition is asked. Then we will mark the pioglitazone mostly, or the glitazones as such. So out of this, the confusion will mostly be in glitazone or canagliflozin. We will mark canagliflozin because there's no particular ask in the question, no females have not been mentioned here. Now we come to the next drug which can be given apart from the drugs is apart from the anti-diabetic drugs as we have insulin. Now insulin is the drug of choice for type 1 diabetes mellitus, but it's an add-on to the type 2 diabetes mellitus when the drugs are no longer sufficient to take care of the blood glucose levels, or if there's an emergency like diabetic ketoacidosis. In pregnancy also we give this. So that is where we use them. Now let's do the insulin, classify the insulin. It is classified into rapid acting, it is classified into short acting, intermediate acting, and long acting. So rapid acting insulin, these are three. So you can remember GAL, rapid GAL, glulysin, lisproaspart, and these are usually given just before meals, the 15 minutes before meals. Very, very rapid acting and have a short duration of action. 15 minutes before the meals you give them, and given by the subcutaneous route. And major drawback with insulin would always remain with insulin as such. It is hypoglycemia, and insulin also causes hypokalemia. Therefore, insulin can be used in the treatment of hyperkalemia. Remember, this is common for all. Okay. Then we have short acting insulin, regular insulin. So it needs to be given an hour before the meals. Remember, this is the only insulin which can be given by IV route for diabetic ketoacidosis. Otherwise, most others are only suitable for the subcutaneous route. Then we have the intermediate acting insulin. Now, the first two, the rapid and the short acting, they mainly take care of the post-meal hyperglycemia, right? Postprandial hyperglycemia. So that is, you can take what you call is at the bolus regime, just before the meals. The intermediate and the slower acting drugs, they take care of the basal levels of insulin. So that's called the basal regime they take care of. So we have a basal bolus regime, right? So what is a basal bolus regime? Where we combine a short acting or a rapid acting drug with an intermediate or long acting drug. So one takes care of the post-meal hyperglycemia, the other takes care of the basal hyperglycemia, glucose levels. So in the intermediate levels, we have NPH, neutral protamine inhibitor, also called as isophane insulin, and we have a lente insulin, which is combination of two, 70% ultra lente, 30% semi lente. This NPH, it is a cloudy white preparation. Okay. Now, this long acting insulins, all of them, they are also called as peakless insulin. They don't have a peak because they have a sustained and uniform action. So they are peakless insulins. So the action is somehow like there's no peak. While the ones which we talked about before, the bolus ones, they do like this. So you give them before every meal, right? So it is the breakfast, lunch and dinner. This is the graph you get. So this is a peak here, and this is the bolus, which takes basal, which takes care of the throughout the day levels of your glucose. So we have here insulin detemmer, glargine and degludec. Degludec is the longest acting. The action can last for about 42 hours. So just give once a day, or that is enough in most of the cases. Now glargine, important thing you have to remember is this cannot be mixed with any other insulin. Right? So it, because it is acidic in nature, pH is 4, can't be mixed with any other insulin because it will crystallize. Okay. Complications of insulin therapy, apart from main, it is hypoglycemia and yes, it was hypokalemia. So what is actually advised to the patient is, because it is applied subcutaneously, that the patient will regularly change the site where the injection is even applied. Otherwise, it can lead to this condition which is called as lipodystrophy. So lipodystrophy is there. Now the sites of insulin injection, there are many sites, like you can apply it in the abdominal area, on the upper outer arm, on the buttocks or upper outer thigh. So these are the various sites where you can give injection. Now remember, the absorption occurs best in the abdominal area, followed by the arm, followed by buttocks, followed by the outer thigh. So remember, this is the way. So preferably our abdomen, otherwise arm, buttocks and then the thigh. So these are the important take home points from the anti-diabetic drugs. So today we are going to study drugs for osteoporosis and anti-thyroid drugs. So first, let's do the drugs for osteoporosis, and we need to know that what drugs that we are using in osteoporosis work on the osteoclasts or what work on the osteoblasts. So there are certain drugs which will inhibit the resorption. That is why, because they are going to inhibit the osteoclasts, which are going to cause the resorption, and because they inhibit the osteoclasts and inhibit the resorption, they lead to hypocalcemia, because that calcium is no longer withdrawn from the bone and it enters into the blood vessels. It doesn't enter into the blood. That's how. Okay. So which are these main drugs here? The first most important drug, that is your bisphosphonates. Bisphosphonates. Then we have selective estrogen receptor modulators like raloxifene. Then we have calcitonin, then cinacalcet, and a monoclonal antibody, denosumab. Then we have drugs, the anabolic drugs, which are going to stimulate the formation of the bone by promoting the osteoblast. So very important drug here is teriparatide. Then we have calcium, vitamin D and fluorides. Certain drugs they are going to do both the functions, that is, they are going to inhibit the osteoclast and they are going to promote the osteoblasts. So here we have strontium granulate and another monoclonal antibody, romosozumab. It inhibits sclerostin, and because it inhibits sclerostin, they are going to have dual action of stimulating the osteoblasts and inhibiting the osteoclasts, right? So this is how we classify these drugs. So moving on to the MCQ which was asked in the previous years, which of the following is considered as the first line treatment for post-menopausal osteoporosis? Estrogen, bisphosphonates, loxapine, combined oral contraceptives. So whatever the cause is of osteoporosis, the first drug or drug of choice is always your bisphosphonates. So they remain the most important drugs that you should be knowing out of this particular topic. So moving on to what are bisphosphonates. So bisphosphonates, these drugs, we have actually they are older generation, the first generation, and then as we go down, they are the new third generation. So first to new third generations, the difference is in the potency of the drug. So the first generation ones, they were less potent, and as we move on higher up in the generations, the potency is going to go up. So we can say it is a zoledronate. It's a very potent drug. So etidronate, tildronate, they belong to the first generation, but they are no longer used now because now better drugs are available. Okay. Then we have alendronate, ibandronate, pamidronate, risidronate, zoledronate. So all have dronates at towards the end. So few drugs, they are given by the oral route. So remember mnemonic air. So air, we breathe air. So oral route air. A is your alendronate, I is abandonate, and R is risidronate. Then for the IV route, you can remember zip, right? Zip, zoledronate, ibandronate. So ibandronate is given by both oral as well as the IV route, and P is pamidronate. So remember oral and IV drugs. Now zoledronate is a very, very potent drug, and you can give IV infusion only once a year. So it will accumulate in the bone and gradually it produces its effect. So that is how potent this drug is. Okay. Now, important, what is the mechanism of action of these drugs? So they block the farnesyl pyrophosphate synthase. So let's do actually what it does is, so we have, this is the bone here, and this is your osteoclast, which has the ruffled surface, and these are multinucleate cells, right? So what does bisphosphonate do? Bisphosphonate drugs, bisphosphonates, they bind to the hydroxy apatite of bone, right? So somewhere in the bone, these drugs will be there. They bind to this. And osteoclasts, they are going to take up this bisphosphonate while they are doing their action on the bone. So osteoclast take them up through the bone. Okay. So when the bisphosphonate enters into the osteoclast, what it does is, number one, it is going to disrupt the cytoskeleton of the osteoclast, and it is going to cause the apoptosis. It is going to cause or kill these or destroy these cells, apoptosis. Number two, they are going to damage the ruffled border. The ruffled border. So this ruffled border is actually responsible for causing the osteoclastic activity or causing the resorption of the bone. So they will damage this ruffled border. So when this ruffled border is damaged, they are not able to actually take out or do the resorptive process. This is how they are going to decrease the resorption. Number three, this is also going to inhibit the cholesterol synthesis. Cholesterol synthesis. Why? Because they block the mevalonate pathway. And this is important for the, for the work or the functioning of the osteoclast. So these are the three main ways by which they act. So they disrupt the cytoskeleton, cause apoptosis, they damage the ruffle surface, and they are going to block the mevalonate pathway. So where are these bisphosphonates mainly indicated? So they are drug of choice for any kind of osteoporosis. So whether it is postmenopausal or it is steroid induced osteoporosis, any type, they are used. Then they are given in drug of choice in Paget's disease and in case of hypercalcemia of malignancy, because they cause hypocalcemia. So they can be given in hypercalcemia malignancy. So for post-menopausal induced or steroid-induced osteoporosis, you give them by the oral route. For these two, you give them by the intravenous route. Okay. Now moving on to the important adverse effects of these drugs. So these are toxic drugs in the sense you have to very carefully explain to the patient that they have a tendency to cause erosive gastritis or esophagitis. So what to do is that patients should take them. So this is especially true with the oral drugs. So patients should take them empty stomach with a glass of water. And patient should not lie down for at least 30 minutes after taking the drug, because if it lies down, then the drug can go back into the esophagus and cause irritation. That's why. So this is a very, very important instruction to be given to the patient. Then it can cause renal toxicity, especially with highly potent drugs like zoledronate, more common. Osteonecrosis of jaw. Again, it is seen with very, very potent drugs like zoledronate. Stress fractures or chalk stick fractures of femur. Why? Because when you give these drugs for long period of time, they are going to cause decrease in the bone resorption, right? So you know that for new bone or the for the what you call that remodeling of the bone, it is important that resorption takes place and then new bone is formed by the osteoblast. So both the functions are equally important. But now what is happening is they're not leading to the resorption of the bone. So that bone remodeling, it does not take place. The bone turnover is not taking place. So the bones become very brittle and easy to break. So that's why they are called as stress fractures. So because of the decrease in the bone resorption, there is a decrease in the bone turnover as well. Okay. So because of that, there is stress fractures. So mostly this occurs on long-term use of bisphosphonates. Osteomalacia, because of the etidronate, it is more prevalent. That's why it is no longer used, not used anymore because of this problem. Now remember that these bisphosphonates should not be given for more than 5 years. So we can write here not given for more than 5 years, because the side effects, the risk of adverse effects are going to increase because of this. Okay, now the next important drug we have is the teriparatide and abaloparatide. So both of these, they are anabolic drugs. They are going to increase the formation of the bone. So they are anabolic in nature, but they're only used for 2 years, right? Not more than 2 years. So main role, or they are the drug of choice, their major role is in case of bisphosphonate induced fractures, because they will help in increasing the formation of the bone. And if patient cannot tolerate bisphosphonate, then we give it in case of the osteoporosis, but we prefer to give bisphosphonates first. So what is this teriparatide? It's a recombinant parathyroid hormone. Parathyroid hormone, if you give it, then they are going to cause increase in the resorption. But recombinant parathyroid hormone, it is leading to bone formation. It consists of the amino acids 1 to 34 from the parathyroid hormone. Whenever parathyroid hormone is given in low dose and in intermittent fashion, it always leads to increase in the formation of the bone. But whenever you give this drug in continuous fashion, then it is going to cause increase in resorption. So here we are giving it intermittently also, and the first 34 amino acids only are taken from the parathyroid hormone. Major adverse effects is they can lead to, because they are going to cause increase in the bone formation, they can lead to nephrolithiasis. Then it can cause hypercalcemia, okay, and osteosarcoma. This is a very, very important drawback. Cancer, osteosarcoma. So there is growth in the bone. You can see this is osteosarcoma. That's why we cannot recommend for this to be given for more than 2 years. Contraindication, if already there is hypercalcemia, right, and in case of Paget's disease. In both these conditions, we cannot give them. Other drugs that we have is cinacalcet, and in cinacalcet, basically what it does, it acts on the calcium sensing receptor. This is present on the parathyroid gland. So this is, let's say, your parathyroid gland, and there is a calcium sensing receptor present over here, and it is basically used to sense the level of calcium in the blood, right? So it senses the level of calcium in the blood, and when it senses the level of calcium in the blood, it will trigger the release of parathyroid hormone, because parathyroid hormone ultimately it's going to cause resorption. So if there is hypocalcemia, then it will trigger the release of parathyroid hormone. But here we do not want resorption basically. So what it does is the cinacalcet, it acts on this receptor. This is the calcium sensing receptor, and it will tell it that the calcium levels are fine, you don't need to go anywhere. So it is going to inhibit the release of parathyroid hormone. Because of this, there is going to be decrease in the bone resorption. Remember, parathyroid hormone, the main aim is to increase the serum calcium levels. So if it is causing resorption of bone, then only it can increase the serum calcium levels. So here we are going to prevent this. The major adverse effects, the most common here actually with this is diarrhea. Now because it causes decrease in the bone resorption, so calcium will not be there in the blood, so there will be hypocalcemia. So there can be tetany-like features, paresthesia, etc. also alongside. Denosumab. Now, denosumab, what is the role? So, this is the osteoclast precursor, and on the osteoclast precursor, we have a receptor which is called as rank. Now, for this receptor, there is a ligand as well which needs to bind. So, this is called as rank ligand. Rank ligand. So, when rank ligand binds to this rank receptor, it leads to activation of this osteoclast precursor, and it leads to formation of the osteoclast. So what denosumab does is, denosumab is going to inhibit, it is going to bind to rank L, and it is going to inhibit its attachment to rank ligand. So denosumab, it binds to rank L and therefore prevents the activation of osteoclast precursor, because it will not bind to the rank receptor. That's the role of this particular drug. Now, this drug is also used in these cases whenever it is, serious cases of osteoporosis as such. And the major adverse effects are that it can again cause fractures of the femur, stress fractures, and it can also lead to osteonecrosis of the jaw. Okay. Calcitonin. Now, calcitonin, it is one of the fastest acting drug out of the lot, but it is not used. Now, calcitonin, the main role of calcitonin is to inhibit the bone resorption. That's the main role, and it is used in Paget's disease. Right? So, adverse effect can cause nausea, flu-like symptoms, etc. So, these are the important drugs for the osteoporosis. Moving on to the next topic is your anti-thyroid drugs. So, these drugs are given in cases of hyperthyroidism. So, we have these various thyroid inhibitors. The first group of drugs are the drugs inhibiting the trapping of the iodide, and they inhibit a special type of transporter, which is sodium iodide sympathetic. These are thiocyanates and perchlorates. So, remember here we have, this is the thyroid follicular cell, and thyroid hormones, they are formed in the follicular cells in the colloid here. So, first we need to take up the iodine from the diet. So, this iodine from the diet is trapped inside the thyroid follicle with the help of the sympathetic, which is the NIS, right? So, this is the NIS sympathetic, which is sodium ions and the iodide ions, they are moving inside. So, this step is blocked by the first group of drug, right? That is the trapping. Now, these drugs are very toxic drugs and they are not used. Second, drugs. Now, after the iodide has come inside, it needs to enter into the colloid, and in the colloid there is an enzyme called as TPO. This TPO is thyroid peroxidase. This is important because it causes iodination, coupling, oxidation of these iodines, and basically it leads to formation. So, this is, we have the thyroglobulin molecule, and this thyroglobulin molecule consists of tyrosine residues where these iodides, this iodine is going to bind, right? So, it is inhibited by TPO because this is now going to lead to the formation of T3 and T4, right? And when this T3 and T4 is formed, so these three steps are very, very important, performed by the TPO. Second group of drugs inhibits this TPO, propylthiouracil, methimazole, carbimazole. So it is going to inhibit the synthesis of the newer hormones, but the original ones which are present in the body, they are not going to be affected. Then after these thyroid hormones are formed, they go inside the follicular cell again, and then they are released into the circulation. So, T4 is more than T3, and ultimately T4 also gets converted to T3, and T3 is released as such. So, this is the point which is called as the release. So, the third group is the drug which is going to inhibit the release of these thyroid hormones. These are your iodides, sodium iodide, potassium iodide, glucose iodine. Then we have drugs which are going to destroy the thyroid gland. So, you give these drugs, radioactive iodine, it is going to destroy this thyroid tissue as such. Then drugs which are going to inhibit the peripheral conversion. What is the peripheral conversion step here? If you see this step of T4 being converted into T3. Now, why is this important? Because this T3 is actually the active form. T4 is not the active form. T3 is the active form which is going to produce all the actions of thyroid hormones. So, released T4 is also released, rather it is released more as compared to T3, but actually actions performed by T3, right? So, this is the important point here. So, this is called as the peripheral conversion, and this is very, very important step here. So, there are drugs to inhibit the peripheral conversion, propylthiouracil, propranolol, amiodarone, even we have prednisolone like steroids. They can also block this step, right? So, these are the various drugs inhibiting. Now, let's do some important points here. So, which is a drug of choice for hyperthyroidism? So, out of all these drugs, the drug of choice for hyperthyroidism are the second group, the ones inhibiting the TPO, they're also called as the antithyroid drugs, and out of that we have 𝗘𝗵𝗂𝗡 and methimazole. This is the drug of choice. Propylthiouracil on long-term use, it can lead to hepatotoxicity. Therefore, it is not recommended for long-term use. Right? So, long-term we have these two drugs. Then important thing is about iodides. Now, iodides, they like sodium and potassium iodide, so they are given preoperatively in case of hyperthyroidism, so that we bring down the thyroid levels, that is before surgery. And what they do, they make the gland firm and less vascular. So what is, they cause shrinkage of the gland, so that it's easy to perform the surgery. Less bleeding is going to be there, less complications are going to be there. Radioactive iodine, this is an alternative to surgery, right? So it is used in elderly because they may not be fit for surgery. So it is an alternative to surgery, right? So one of the basic issues, they can cause irreversible. The major side effect is irreversible hypothyroidism. The other drugs are reversible. You stop giving the drug, the effects are reversed. But they cause irreversible hypothyroidism. So they are also used in thyroid cancers. But this is contraindicated in pregnancy. Radioactive iodine. Now, some important one-liners here. Antithyroid drug of choice in thyroid storm. Thyroid storm is an emergency where there is increased levels of thyroid hormones, and what we worried about mainly is because they can cause tachyarrhythmias. They can ventricular fibrillation can occur in these patients, because what do thyroid hormones do? They sensitize the catecholamine receptors to the effect of catecholamines. So especially in the heart, your beta receptors are there, so more effect of the catecholamines on that. So there can be increase in the heart rate leading to dangerous ventricular fibrillation. That's why we are very, very worried about that. So first thing what you do, the antithyroid drug of choice in the thyroid storm. Antithyroid. Remember, if it is antithyroid drug of choice, then that is propylthiouracil. Why? Because it prevents the conversion of T4 to T3. So T4 to T3 is blocked. That is why we are worried about this. The action on the thyroid peroxidase enzyme, which it does, it is not a quick action. It will take some time to produce the effect, because the hormones are already present in the body. They are going to do the effect. So it won't be effective against the already produced in the hormones. Only it is going to inhibit the synthesis of the newer hormone. Then, if the question is asked the drug of choice in thyroid storm, then your answer should be a beta blocker, propranolol. Because propranolol also inhibits the T4 conversion to T3, and it will also have a sympatholytic effect. So on the beta 1 receptors, it will block those receptors and it will not allow the arrhythmias to occur. It's a very, very important point here. So drug of choice for hyperthyroidism in first trimester. Remember, first trimester, we cannot use carbimazole, methimazole, because they have a teratogenic effect. So in first trimester, your drug of choice is propylthiouracil. Then in second and third trimester, you can go back to carbimazole or methimazole. Okay. So what are the teratogenic effects of carbimazole and methimazole? Remember, mnemonic called as 𝗱. 𝗱 is F, fetal hypothyroidism. A, this is called as 𝗕𝗵𝗄𝗅 cutis. This is choanal atresia. esophageal atresia. Aplasia cutis means missing skin here. So these are the teratogenic effects seen with the carbimazole, methimazole. That's why they're not used in the first trimester. Then we have drugs inhibiting the peripheral conversion that we've already done that in the classification. That is again to revise propylthiouracil, propranolol. Another P is prednisolone. Then we have a drug antiarrhythmic, amiodarone. So all these drugs are going to inhibit the peripheral conversion. So what are the drugs which are used for thyroid storm? So drugs which are used for thyroid storm, first is propranolol. Then we can give propylthiouracil. We can give iodides, right? Because they all prevent the peripheral conversion of this. Then we give prednisolone. And in case arrhythmia is not handled properly by propranolol, you can add a CCB like diltiazem. Okay. Now, so this was about the hyperthyroid. So what about if patient has hypothyroidism, which is more common? In the hypothyroidism, we have two hormones. One is T4 and the other one is T3. T4 is levothyroxine. So this is preferred for daily use. Why? Because it has a long half-life. So it has a more sustained action. And it has less chance of atrial fibrillation or arrhythmias, because T3 is the active form, very quick or short acting, it has more chance to cause the atrial fibrillation. So this drug, it is given by oral route, right? That is levothyroxine. And yes, in emergency like in myxedema, we can also give it by the IV route, especially myxedema, coma. Not regularly we can give it by oral route, but coma, emergency, we give it by the IV route. Now T3 can also be given by the IV route only in emergency like mixed edema coma, not for regular use because there is a risk of atrial fibrillation. That is the most important thing that we need to be worried about here. So T4 is preferred, right? And another important thing, because they have nuclear receptors, so these are nuclear receptors, the effect will not be seen immediately. So there we need 4 to 6 weeks for the effects to be shown. That is very important for these drugs. Alright, so with this we come to the end of this topic, drugs for osteoporosis and antithyroid drugs. So we are going today do anti-epileptic drugs. So first, a question from the previous year: which of the following drugs acts on sodium channels and enhances slow sodium inactivation? Phenytoin, lamotrigine, lacosamide, topiramate. So this question is to tell you that they can ask you about the various mechanisms of anti-epileptic drugs. So you need to be very thorough with that. Okay. So here the correct answer is lacosamide. So we are now going to do all the important mechanisms and whatever important things about each of the anti-epileptic that you must know. So moving on to these anti-epileptic drugs, the first drug is phenytoin or hydantoin. If the chemical name is hydantoin. Now, what does this drug do? It prolongs the fast sodium inactivation, not the slow, but the fast sodium inactivation. So the rapidly firing neurons, the sodium channels in those neurons are affected. Other important things to know about this drug is that it follows zero order kinetics. Okay, so it follows zero order kinetics. Important uses of phenytoin: it is used as one of the first line drugs in generalized tonic-clonic seizures. It is also used in focal seizures. Remember, now we don't call partial, we call it focal seizures. Then it is used in digitalis induced arrhythmias. But remember that this drug is contraindicated in case of absent seizures and in case of myoclonic seizures. Okay. Moving on to the various adverse effects of this drug, very important. So remember a mnemonic here. We have High-Yield. So H stands for hypersensitivity reactions and H stands also for hemorrhage. Hemorrhage in newborns. So therefore you need to give vitamin K injection. So there's a risk of hemorrhage in the newborns. I stands for increase in the vitamin D metabolism. Because of this, there can be osteomalacia, or there is interference in folic acid metabolism or absorption rather, folic acid absorption, and the patient can have megaloblastic anemia. G stands for gum hypertrophy or gum hyperplasia. H, hirsutism, and another H stands for hyperglycemia. High-Yield stands for fetal High-Yield syndrome. The hallmark is here cleft palate or cleft lip. So these are the important points about phenytoin. Moving on to the next drug is valproate. Now valproate is a broad spectrum antiepileptic. What do we mean by that? It inhibits number 1, the sodium channels, number 2, the calcium channels, the T-type calcium channels, also inhibits the enzyme GABA transaminase. Now GABA transaminase is involved in the metabolism of GABA. So therefore, it will inhibit the metabolism of GABA and increase the GABA levels. Okay. Now this drug, important thing, most of the anti-epileptic drugs are enzyme inducers, but this is an exception to the rule. This is an enzyme inhibitor. Then valproate is a drug of choice for various conditions. For example, in generalized tonic-clonic seizures, in myoclonic seizures, atonic seizures, absent seizures, and Lennox-Gastaut syndrome. It's a mixture of many seizures. It's a resistant type of epilepsy, right? So these are the important uses of valproate. Now, what are the important adverse effects of valproate? Very, very important as well. So remember another mnemonic here. Simply you have to remember valproate. V stands for vomiting. So it can cause vomiting as well as nausea. A stands for alopecia. L stands for liver toxicity. It's a hepatotoxic drug. That's why it is not recommended for children less than 2 years of age. P stands for in pregnancy. It is contraindicated because it is one of the most teratogenic drugs. So what it leads to? It can lead to neural tube defects and spina bifida. R stands for rashes. O stands for obesity. So there is increase in weight which is seen with this particular drug. I stands for increase in the tremors. and C stands for curling of hair. Now, remember all these adverse effects, they are seen in therapeutic doses, right? When you give them in therapeutic doses over a prolonged period of time, these are the adverse effects seen. What will you see in case of overdose? So, if patient takes multiple tablets together, so there is risk of overdose. So, overdose toxicity, it will look like patient will have ataxia, patient can have diplopia, and patient can have nystagmus. So, these are seen because of overdose toxicity. Now, valproate toxicity, if it is associated with hepatotoxicity and hyperammonia. So, if there is hyperammonia condition, then the treatment or the antidote is L-carnitine. Now, in some cases, if there is no increase in the ammonia levels, but if the patient has CNS depression, though it is not the antidote, but the drug naloxone has been found to be effective. It's a non-opioid mechanism by which it works, but it can bring down the central nervous system depression in these patients. So, if it is hyperammonia, then your drug of choice antidote remains L-carnitine. But if there is no hyperammonia, then L-carnitine is of no use there, right? So, what you do there is basically you give for CNS depression, the trial of drug naloxone was given and it was seen that patients can benefit from giving this particular drug, okay? Moving on to the next drug, it is lacosamide, the one in the question. So, it enhances the slow sodium inactivation. So, always see the question, it is the slow sodium inactivation. They would have mentioned this, right? So, what does it do? Slow sodium inactivation. So, it will stabilize the neuron which are in the depolarized phase, right? That they are going to do. So, they have less effect on the normal neurons, right? So, what to do here? Example or one important thing that we have to take care of, the same sodium channels are present in the heart as well. So, because they block these sodium channels in heart, so they can decrease the AV conduction, right? So, patient has a risk of developing AV block. So, we have to be careful in cardiac patients. Topiramate, another broad spectrum drug, and this topiramate, it blocks the voltage gated sodium channels. It will enhance the GABA A channel, so GABA A activity, and it will block the AMPA receptors as well. So, what are the adverse effects seen with topiramate? Adverse effects, it will cause weight loss, it can cause renal stones, and it can cause metabolic acidosis. Now, what are the uses of topiramate? Because it causes weight loss, this drug has been approved for treatment of obesity. It has some other uses as well apart from being an anti. So, these are the other uses apart from being an anti-epileptic drug. It is also used for migraine prophylaxis. It is used for reducing the alcohol craving. It is also used in bipolar disorder. Next drug we have is zonisamide. It blocks the fast sodium channels and also the T type of calcium channel. So, this drug will be effective even in case of absence seizures, right? So the major adverse effect where you need to know about this drug is that it can cause renal stones, just like topiramate, because it's also it's similar in that has a sulfonamide derivative also, so hypersensitive reactions can also be seen with this particular drug. Then carbamazepine. Now carbamazepine prolongs the fast sodium inactivation, and important thing here you should know that this drug has a property of autoinduction. It will induce its own metabolism. So gradually you will have to go on increasing the dose of this particular drug. Now this carbamazepine is a drug of choice in focal seizures. It can be used in trigeminal, rather drug of choice in trigeminal neuralgia, and it is also used in diabetes insipidus. Okay, so what are the adverse effects with carbamazepine? So remember a mnemonic dash D A S H. So D, diplopia and ataxia. A, it can cause agranulocytosis. Okay, and as I told you, another thing you can remember, it's an auto-inducer. S stands for SIADH. It can cause SIA, syndrome of inappropriate ADH secretion, because it enhances the ADH secretion or release. Because of this, it can land a patient into a condition called as dilutional hyponatremia, and this is more often or more common in case of elderly patients. So one has to be very careful while giving carbamazepine to an elderly patient. All right, then H stands for, it also is hepatotoxic and can cause hypersensitivity reactions. Okay, so that is carbamazepine. Now, another the newer congener or modified congener of carbamazepine is oxcarbazepine. Now, everything is similar to carbamazepine. The difference is, what is the advantage of this? Number one, it has decreased chances of induction. So, it is a less potent inducer, but it has increased tendency to cause hyponatremia. So the other side effects are comparatively less. Exception is that it has an increased tendency even than carbamazepine to cause hyponatremia. Then we have lamotrigine. Now lamotrigine blocks again the fast sodium channels. It is a drug of choice for focal seizures, especially in the elderly, because in elderly carbamazepine we are scared to give because of the dilution hyponatremia. So we can prefer lamotrigine instead in cases of elderly. Now this drug is one of the drug which is safe in pregnancy. You can give it in pregnancy. Major side effect with this is the kind of rash it develops. So rash can be from mild and it can be increased in intensity to Stevens-Johnson syndrome or toxic epidermal necrolysis. So always start with a lower dose and then you gradually escalate. Otherwise, if the patient, you give a high dose, the patient can land into severe rash. Then we have retigabine or ezogabine. So it's the same name. So in US it is called or in the European, that is the difference. In Europe and in US the names are different, the same drug is same. So either retigabine or ezogabine. It's a potassium channel opener. So potassium channel opener it is used, and this is drug which is meant for focal seizures. For focal seizures. The adverse effects, it can cause urinary retention, it cause blue-green skin pigmentation, and it can cause retinal toxicity. So R for reticabine, R for retina. Okay, so we can, at least this side effect you should know. Next is 𝗙𝗪𝗏, which is an NMDA receptor. NMDA is the receptor for glutamate. So it is a glutamate antagonist. We know that in epilepsy, there is increased glutamate transmission and decreased GABA transmission. So all the drugs indirectly or directly, they are going to either increase the GABA or inhibitory transmission, or they are going to decrease the glutamate transmission. That's the major rule to follow here. So adverse effects with this drug, so the main ADRs, it is not much used here because it has a strong hepatotoxic potential. So it is a hepatotoxic drug and it can cause aplastic anemia. Vigabatrin inhibits the GABA transaminase, so definitely it is going to enhance the GABA levels, right? That is it going to do. Then vigabatrin with V is also causing the visual field defect. So need to keep on checking for the vision in this. So vision tests need to be done. Tiagabine is a drug which inhibits the GAT1. What is GAT1? It is a transporter for GABA. So this GABA, which is released into the presynaptic or into the synaptic cleft, it gets taken back with the help of GAT1 into the presynaptic neuron. So if you block this GAT here, there is increase in the level of GABA and it can act on the receptors for a longer period of time. So that is the role here. It inhibits the reuptake of GABA. Okay, that is important here. Then perampanel, another drug which is an AMPA blocker. Again, AMPA is a receptor for glutamate. So they will decrease the action or the effect of glutamate. Glutamate receptor, NMDA is also a glutamate receptor, AMPA is also a glutamate receptor. Then drug is tiripentol, which is a positive allosteric modulator of the GABA A receptor. So it enhances the effect on the GABA A receptor, and this drug is used for Dravet syndrome. It is used for Dravet syndrome. Then the new drug cenobamate, it inhibits the sodium channels and enhances the GABA activity. So when the neurons, the ones which are repetitively firing, it will inhibit the sodium channels there. So the action potential will go down and they will stop firing, and also they are going to enhance the GABA activity. So this is a newer drug for focal seizures. For focal seizures. Major adverse effect with this is hypersensitivity reaction. Hypersensitivity reaction. So called as the DRESS syndrome. And it can also lead to QT shortening. Next, few one-liners here. Anti-epileptic, which is contraindicated in absence seizures. So which anti-epileptics should not be used in absence seizures? Number one, we have phenytoin, and we have carbamazepine. Anti-epileptic drug contraindicated in porphyria. So barbiturates are absolutely contraindicated in porphyria. So phenobarbital. Anti-epileptic causing weight gain, we just now did valproate, is associated with weight gain. Anti-epileptic drug preferred in pregnancy. So we have two drugs. One is levetiracetam and the other is lamotrigine. So we first prefer levetiracetam and then lamotrigine. They have a least toxic effects on the fetus. Now remember, if female patient who's already an epileptic patient, but she is on valproate and she gets pregnant, then what to do? Should you stop valproate? because what will happen when you stop valproate, there are risk of seizures, and that risk of seizures is more detrimental to the health of the mother. She can die, and we are more concerned about saving the life of mother that time, not the baby. So that risk is more, so we don't take that risk. What we do, we continue with the dose of the valproate. You will fix it at the best possible dose, and what you do, you will add more folic acid. So about 4,000 microgram per day you will give. To whom? To pregnant female on valproate. That's the best you can do, because this might help and decrease the incidence or the severity of the spina bifida. On the other hand, there is an epileptic female who is planning to get pregnant. So there you have time. You can first switch or change over to a safer anti-epileptic like levetiracetam, lamotrigine, and when the patient is stabilized, then she can move ahead and go ahead with the pregnancy. That's a different condition. But here, she is already pregnant, and we do not suggest that you stop the drug and change over in between. Okay, so what are the other non-epileptic uses of anti-epileptic drugs? So they are used in neuropathic pain like diabetic neuropathy, etc. Neuropathic pain. So we use pregabalin, right? We use gabapentin. Then in case of obesity, we use 𝗘𝗵𝗏. Other uses of 𝗘𝗵𝗏 already discussed with you. It can be used in case of bipolar disorder to decrease the alcohol craving. Okay, so it can be used in these conditions. Migraine prophylaxis. Migraine prophylaxis. Right? Other drugs in bipolar disorder. So other drugs, anti-epileptics in bipolar disorder, we can also use valproate and we can use carbamazepine. Then in mania, especially the one who are rapid cyclers, more than 4 attacks per year, rapid cyclers, valproate is the best choice there. So these are the non-epileptic uses of anti-epileptic drugs. Now moving on to the drugs of choice or first line drugs in various type of seizures. So the first we have here is generalized tonic-clonic seizure, also called as the grand mal seizures. So we have valproate, we have lamotrigine, and we have phenytoin. Partial or focal seizures, that with its main name is focal seizures here. Drug of choice, we have carbamazepine. Then we can also use lamotrigine. Lamotrigine especially in case of elderly patients, drug of choice. Absence seizures, also called as Pett-and-Moll seizures. The hallmark on EEG is 3 Hz spike and wave pattern, and these seizures are because of the special T channels, T-type calcium channels. T-type calcium channels because of the overfiring there. So, any drug which blocks these T-type calcium channels are used in the treatment of absence seizures. So, all the drugs are not used. There are only few drugs which are effective in absence seizures. So, drug of choice remains valproate. Now, in small children lesson 2, we don't give this because of the risk of paratoxicity. So, there we give ethosuximide. Now, another drug we can also give effective is zonisamide. Atonic seizures, myoclonic seizures, juvenile myoclonic seizure, epilepsy, Lennox-Gastaut syndrome, Dravet syndrome. Everywhere the drug of choice here is valproate. That's the important here. Now, infantile spasm or Salam seizures, or called as the West syndrome, the drug of choice is ACTH. But if this infantile spasm is with tuberous sclerosis, we use the drug 𝗙𝗑𝗪𝒑. Febrile seizures in children because of high grade fever. Usually these are benign seizures and they become okay on their own. But if not, then what you can give injection 𝗍𝗍𝗑 by rectal route. Or we can give midazolam. That is by the intranasal route. Status epilepticus in emergency condition, right, where there is continuous epileptic seizures, the drug of choice is lorazepam by the IV route. If not available, then we move on to diazepam. Simultaneously, we start with fosphenytoin, which is a water-soluble form of phenytoin. Fosphenytoin. So, lorazepam IV, start with fosphenytoin IV. If there is resistance, then you give phenobarbital. If there is still resistance, it is no refractory rather. So, this is a refractory. Then you can shift to the general anesthetics. The GAs you can start off with. For alcohol withdrawal, again IV lorazepam is the drug of choice. So, these are the important points from the anti-epileptic drugs. Today we are going to discuss the topics in psychopharmacology. So, let's first go and understand the important questions from the topic of antidepressants. So, the antidepressants, the first group that we're going to do is SSRIs or selective serotonin reuptake inhibitors. So, you know what they do? The mechanism is that they inhibit the 5-HT transporter. That's how they're going to increase the level of serotonin in the synaptic cleft. But you know this is a slower action. The response will take about 4 weeks. So, response takes about 4 weeks. Right? So, these are the drug of choice for depression these days. Depression, and they're also used for obsessive compulsive disorder and generalized anxiety disorders. Which of the SSRIs is the longest acting and hence has the least withdrawal phenomena? So, we have the drug that is fluoxetine. Shortest acting, teratogenic and with maximum withdrawal reaction, we have paroxetine. Preferred in pregnancy, we have sertraline and escitalopram. For premature ejaculation, we give the drug 𝗕𝗵𝗄𝑥etine, right? 𝗕𝗵𝗄𝑥etine. In the adverse drug reactions, the most common adverse effect which we see with this is nausea, and this is due to 5-HT3 receptor stimulation. Due to the stimulation or because it is increasing the serotonin levels, so therefore is acting on the various serotonergic receptors. So, because of 5-HT4 receptors in GIT, you know, this is involved in the prokinetic action. So, it is going to cause loose stools. Now, due to 5-HT2 stimulation in the brain, it can cause anxiety and it can lead to insomnia. Now, due to 5-HT2 stimulation in the spinal cord, this is associated with sexual dysfunction, right? And it can also lead to delayed ejaculation. Serotonin syndrome, it is a syndrome when there is increased level of serotonin, and this can occur when you give this kind of drug with other groups of drugs which also increases levels of serotonin. So, which are those? For example, tricyclic antidepressants. They also are going to increase the level of serotonin. Then monoamine oxidase inhibitors. They are going to inhibit the metabolism. Then we have a drug called as antibiotic. We have linezolid. that also increases the serotonin levels. Then we have triptans, right? These are the agonists at the receptors. Then we have tramadol. It also increases the levels of serotonin, right? So these are the drugs with which we can see serotonin syndrome. And what is the treatment of serotonin syndrome? Obviously, you have to stop giving the drug. But what else can you do? So you stop the drug, and you can give a serotonergic antagonist. So we can give cyproheptadine, right? All right. Moving on to the next group of drugs we have is tricyclic antidepressants. Now, these drugs, their response varies from individuals. Therefore, this is a group which is a candidate for therapeutic drug monitoring. So, we have a drug here, clomipramine, and another is imipramine. So, clomipramine is given in OCDs. Imipramine is given in nocturnal enuresis. Now, tricyclic antidepressants, their role is to inhibit the reuptake of 5-HT as well as the norepinephrine. But not only that, it also leads or it acts on the various other receptors and blocks them. So the side effects are basically because of the blockage of those receptors. So for example, if it blocks the cholinergic receptors, muscarinic receptor, it has anticholinergic side effects. So it can lead to dry mouth, it can lead to constipation, it can lead to urinary retention. So because of this, it is contraindicated in patients, elderly male patients who have benign hypertrophy of prostate. Because of alpha blockers or alpha blocking effect, it can lead to postural hypotension. Postural hypotension. Histamine receptor blockade can lead to sedation. No, all antihistamines, they are sedative, so it can lead to sedation, it can lead to weight gain. Now, increased serotonin, that has a tendency to increase the appetite as well, and this can contribute a little bit to the weight gain. Now, overdose with TCAs. So what happens, because it leads to acidosis, so therefore the treatment should be by giving an alkaline agent. So here the treatment is sodium bicarbonate. Now it can lead to some of the atropinic symptoms, like because anticholinergic, that is the predominant symptom. What you do, you give a drug which is given in atropine overdose. So for example, you give your physostigmine. So you give physostigmine. For arrhythmias, what happens, because it can lead to QT prolongation, and for arrhythmias, so what is the best? You give an antiarrhythmic like lignocaine. Then we have SNRIs, which is selective norepinephrine reuptake inhibitor, right? So what is the role of this? So we have venlafaxine, desvenlafaxine, duloxetine, reboxetine, and milnacipran. So remember here, out of them, duloxetine is the longest acting, and it is used in stress urinary incontinence. Reboxetine is used in ADHD. Now these drugs, they are contraindicated in case of cardiac disease because they are inhibiting the norepinephrine reuptake. So there will be increase in the norepinephrine levels, which can trigger the receptors in the heart, the beta 1 receptors. So therefore, already if there is a cardiac disease present, then we should not give this drug, cardiac disease. Then some newer drugs. So what are the important points you should know about these newer drugs here? Is the first drug we have vortioxetine. It is called as MSSA, MSSA, which is multiple serotonin agonist, antagonist. So somewhere it is agonist, somewhere it is antagonist. It is called as MASA. Then vilazodone, it is called as SPARI. This is serotonin partial agonist and reuptake inhibitor, right? So another important point about this drug is that it has no ejaculation issue, right? So no erectile dysfunction. No erectile dysfunction. Esketamine is a drug which blocks the NMDA receptors, and this was a question. It is used as nasal spray, available as a nasal spray in case of resistant depression. Brexanolone is a GABA receptor modulator and it is used for postpartum depression. So these are some newer drugs and their mechanisms of actions. Okay, now moving on to the atypical drugs and what are their important side effects which you should be aware of. So bupropion, very important. It is a norepinephrine and dopaminergic reuptake inhibitor. Its main use we have done in smoking cessation. Smoking cessation. Major side effects that this drug actually brings down the threshold for seizures. So it can cause, in high dose, it can cause seizures and it can lead to anxiety as well. Mianserine, it blocks the presynaptic alpha-2 receptors. So the alpha-2 receptors which are present presynaptically, it will block these receptors. So what is the alpha-2? You remember alpha-2, these are like the brakes. So when you're blocking them, there'll be increase in the release of norepinephrine. That is important. Again, it can predispose the person to seizures. Amoxapine, important. Amoxapine is very amicable drug. So it is causing the D2 block and inhibits the norepinephrine uptake. It has this special action. Mirtazapine, remember this is called as NASA. Remember we have done MASA, which is vortioxetine, but NASA is mirtazapine, right? So M is repelling each other. So M will come with N. Mirtazapine is NASA, not MASA. Okay? So MV, you remember that is, and this is MN. Mirtazapine. So what is this? This is noradrenergic and specific serotonin antidepressant. So affects certain specific serotonergic receptors, right? So it is norepinephrine or adrenaline and specific serotonin antidepressant. Now mirtazapine has a very important property. It's a very sedative drug and it can increase the appetite also. So therefore, where do you use them? Therefore, used in case of depression with insomnia. And also, let's say patient is losing weight, then also it is helpful. So it will lead to weight gain also. So if there is depression with insomnia and weight loss or loss of weight, so this is a very good drug to be given, and it is usually given at night so that patient can sleep well. Then we have nifazodone, which is causing the 5-HT2 block. Now this is a hepatotoxic drug. Hepatotoxic drug. Now trazodone, very important drug. So trazodone means 3. So it does 3 things. What? Number 1, it blocks the 5-HT uptake. Number 2, it causes alpha. And number 3, 5-HT2 block. Remember trazodone. So this is also called as SARI. We had a SPARI, right? Vilazodone was a SPARI and this is a SARI. So that was a serotonergic or serotonin partial agonist and reuptake inhibitors. This is serotonergic antagonist. It is blocking the 5-HT uptake. So it is serotonin antagonist and receptor inhibitor and reuptake inhibitor. It inhibits the reuptake as well. So it is increasing the basically 5-HT levels, but it is causing the alpha and 5-HT block as well. So this is SARI, right? So this is very important. And what else is important here to know? That's the side effects which are asked usually, that this is a drug which can cause priapism. It is no longer used actually because of this, the priapism. And what else is important? It can cause sedation. And because it is blocking the alpha receptors, it can cause postural hypotension as well. Postural hypotension. So this is SARI. Let's highlight these important ones. Then this is NASA, which is mirtazapine MN, right? Then here we had SPARI and we had MASA. So these four terms you should know. MASA is vortioxetine MV, vilazodone is SPARI, trazodone is SARI, right? So NASA is mirtazapine, M with N, not with M. So M will always be followed by N. So mirtazapine is NASA and vortioxetine is NASA, vilazodone is SPARI, and this is SARI. And it is trazodone. So three things. It blocks the 5-HT uptake, alpha, and 5-HT block as well. Okay. Now again another one here. Let me tell you about the MAO inhibitor, which are also antidepressants, monoamine oxidase inhibitors. So only thing to remember about the side effects, it can cause cheese reaction. So if you give it with other drug or food which contains tyramine, then it can aggravate the cheese reaction. So what is the treatment of this cheese reaction? Is give an alpha blocker, which is phentolamine. Okay. So let's do this MCQ here. A 45-year-old patient with a history of depression was initially being treated with sertraline, but the symptoms were not adequately controlled. His medication regime was changed to include a monoamine oxidase inhibitor and amitriptyline. So there was MAO inhibitor and amitriptyline. So shortly after the change in medication, patient developed agitation, seizures, hyperreflexia, and tremors. Which of the following is the most appropriate treatment for this patient? So basically what is happening is amitriptyline MAO inhibitor. So both of them, when they are given together, there is increase in the level of serotonin. So this high level of serotonin leads to a condition called as serotonergic syndrome. So these are all the signs and symptoms of a serotonergic syndrome. There is agitation, seizures, hyperreflexia, and tremors. So I told you when there is serotonergic syndrome, what is the best thing you can do is you can block the 5-HT receptor. So here, one of the 5-HT antagonists we have to look out for. So the drug here is cyproheptadine. Because what is flumazenil? It is a benzodiazepine antagonist. Okay. What is L-carnitine? It is a valproate antagonist. And what is leucovorin? We give leucovorin rescue. This is for methotrexate overdose or toxicity. Right? So cyproheptadine is the correct answer for us. Moving on to the antipsychotics. In the antipsychotics, we have typical and atypical. In the typical one, we have chlorpromazine, thioridazine, fluphenazine, haloperidol, and droperidol. Now, again, these typical antipsychotics, the main role is that they are only actually, or the main effect is because of the blocking of the D2 receptors. And because they block the D2 receptors, what they lead to is they only actually treat the positive symptoms well. So there is treatment of positive symptoms. Now, because of D2 block, the major adverse effect which is seen with this drug is extrapyramidal syndrome, and there is hyperprolactinemia. Okay. Now, they also block the other receptors. So, just we've done like the way we did in tricyclic or in the antidepressant, similar action here. What if H1 is blocked? So, if H1 is blocked, what side effect can occur for us? It is sedation. If alpha 1 is blocked, it can lead to hypotension. If muscarinic receptors are blocked, it can lead to dry mouth, constipation, and another one with us is urinary retention. Right? Also remember that such drugs can trigger the attack of glaucoma as well, right? Why? Because anti-muscarinic action, right? Muscarinic action would be causing the meiosis, so the anti-muscarinic is causing mydriasis, can precipitate an attack of glaucoma as well. Now, where do we use droperidol with fentanyl? It is used in a condition that is called as neuroleptic analgesia. It's analgesia. Chlorpromazine is also used in case of, apart from the antipsychotic effect, it has a role in intractable hiccups. It is not getting treated by any other way. So, this is called intractable hiccups. We can use them. Major problem with these groups, typical or atypical, is metabolic syndrome. So, there is a mix of diabetes, hyperlipidemia, etc., weight gain. So, which are the drugs which show maximal metabolic syndrome? So, out of the typical ones, we have thioridazine, maximum thioridazine. While the most potent out of this, the typical haloperidol is considered to be the most potent. But the most potent ones are least likely to cause metabolic syndrome. So, least is with haloperidol. Now, apart from thyroidazine, the atypical ones, they are known to cause metabolic syndrome. The two major drugs which are important here is clozapine and olanzapine. Then, which drugs have no tendency to cause weight gain? So, one we have aripiprazole and ziprasidone. Okay. Now, very important now is atypical antipsychotics. More important than typical, we have atypical antipsychotics. We know that their main action is to cause the 5-HT2 block, and this is responsible for decreasing the negative symptoms which are more difficult to treat. Decrease in the negative symptoms like apathy, the patient is secluded, withdrawn, and there's emotional flattening. They are very, very difficult to treat. So with typical, actually, they are not. In typical ones, the positive symptoms like there is delusions and hallucinations, agitation, that is treated. But the negative symptoms are less effectively treated with the typical antipsychotics. So here we have the 5-HT2 blockers, which are the atypical antipsychotics. They have more effect on the negative symptoms. Right. So, some important atypical antipsychotics, and this is the most important antipsychotic for examination point of view, one is clozapine. So, clozapine, this is used for resistant schizophrenia. Resistant schizophrenia, drug of choice. Right? Why only for resistant and not for the routine? Because it has a lot of side effects. So, what are the side effects? You remember a mnemonic, SAM. Not same, SAM. So, SAM, S is for seizures. Now, this is a dose dependent effect. So, when you go on increasing the dose, the threshold for seizure goes down. Then A stands for agranulocytosis. Now, this is not dose dependent. So, you can say dose, here we write dose dependent, and here write dose independent. So, this can occur in anyone in any dose range. So, therefore, you need to monitor the WBC count. right? So you have to weekly monitor the WBC count. So M stands for myocarditis. S stands for Cyalloria, or also called as the wet pillow syndrome. And it also leads to sedation. So 2 here, S is sedation and Cyalloria. Then A stands for acute congestive glaucoma. And the last M stands for metabolic syndrome. So you can cause metabolic syndrome. So metformin can be used in this case. So these are the important points to know about clozapine. It is used in resistant schizophrenia, and what are the major adverse effects. Now risperidone, out of the atypical drugs, has the maximum risk. Risk and risk. Risk of what? Maximum risk of causing the D2 block and therefore causing EPS and hyperprolactinemia. So which of the atypical antipsychotics has a maximum tendency to cause EPS or the hyperprolactinemia? It is risperidone, because it has maximum D2 block effect as compared to the other atypical antipsychotics. So it is used in OCDs. Then aripiprazole. Now aripiprazole, what is important here is to remember, it is a partial agonist at the, apart from this, it is a partial agonist at D2 and 5-HT1 receptors. So, right, it is a aripiprazole. So, it is a partial agonist, PA, at the D2 and 5-HT1 receptors, and it has least tendency to cause weight gain, so, and less tendency for weight gain as well as EPS, because it is a partial agonist at D2. Remember, because of the partial agonistic activity, less tendency to cause EPS. Alright, then we have pimavanserin. What is important about pimavanserin? Now, pimavanserin has no D2 blocking action. So, it causes no D2 block. So, what will happen therefore? There will be therefore no risk of EPS. So, where can you use them? In case of Parkinson's induced psychosis. Induced psychosis. Why? Because it will not block the D2 receptors, because all the other drugs are going to block the D2 receptors and they will further aggravate Parkinsonism. But because it has no effect on the D2 receptors here, this drug can be safely given in Parkinson's induced psychosis. Right? So, this is the drug of choice here. 𝗲𝗡𝗏 is a drug which also has a prokinetic action. So, which antipsychotic also has a prokinetic action? This is 𝗲𝗡𝗏, prokinetic action. So, we can use it in gastroesophageal reflux disease. Alright. So, moving on to the important points here on the EPS. This is very, very important. So, what is important? Different types of extrapyramidal symptoms that we can see, and what is the treatment. Now, the first one is acute dystonia occurs earliest, right? It is earliest to occur. And there is, you can say, sudden movement. So, what is in dystonia? There is spasms. So, there are spasms of neck or the eye muscles, right? And or what is this called as torticollis or oculogyric crisis. All this is called. So, earliest to develop, and what is it because of? Because there is D2 block. So, when the D2 gets blocked, there is enhanced activity of the cholinergic part. So, we need to give some anticholinergic which are centrally acting. So, we have centrally acting anticholinergics like 𝗡𝗵𝗄. So, this is the drug of choice, 𝗡𝗵𝗄. Or because this is not very readily available, we have other antihistaminics readily available in the hospital which also have an anticholinergic action. So, we can give them also. So, we have promethazine. It is an antihistaminic but also has an anticholinergic effect. So, promethazine. Akathisia. Now, akathisia is one of the most common, you can say, the EPS. And what happens here, the patient is restless. He moves about here and there and without sitting at one place. Even if he is sitting at one place, he'll be moving his legs. So he can't sit still. So patient is restless, patient is anxious, he moves around, right? To and fro. So this can be treated with a drug which will bring down his anxiousness, anxiety. So here the drug of choice for us is a beta blocker, propranolol. That is the first drug to be given in such case. Then we have Parkinsonism. So this is because of the drug-induced Parkinsonism, right? So here what happens if you give levodopa, it will not be effective because here D2 receptors, they are blocked. So levodopa is going to eventually give out dopamine, and that dopamine is not going to act on the receptor because the receptor is blocked. So what you do here is in Parkinsonism, because there is a balance between the dopaminergic and the cholinergic activity. So if dopaminergic activity is going down, you will see relatively the cholinergic activity will be much more relative, you can say it is much more higher. So what you do here is the tremors and everything which is happening here because of the cholinergic overactivity. So you bring down the cholinergic overactivity here. So here in Parkinsonism, what is happening here? It will be the rigidity, there will be tremors, which are important, right? Rigidity and tremors, these are important, and because of this, you need to give again 𝗡𝗵𝗂, right? So again, 𝗡𝗵𝗂 is important in rigidity and tremors. Even there will be decrease in the movement, which is called as bradykinesia. Then we have tardive dyskinesia. Now this is different as compared to the others. Now all the others are because of dopamine block. Now this tardive dyskinesia, which occurs very late, after years of the treatment, even sometimes after stopping the therapy, after years of treatment. So what is happening here is, this is because of the dopamine receptor supersensitivity. So receptors become super sensitive because initially you have been giving these antipsychotics which are blocking the D2 receptors. So continuous pressure of an antagonist, what happens is they increase the dopaminergic sensitivity. So what was happening here? So this is the presynaptic neuron. So here there is dopamine. So right. So the receptors, the D2 receptors here, because they are blocked by these drugs, so over a period of time there will be enhanced or super sensitive upregulation also of these dopaminergic receptors. So when there is dopamine release, so even after years, what will happen when the even small amount of dopamine is released, it is going to act on these receptors, extra receptors, and this is going to lead to dyskinesias. Now, what is the best thing to do here is you have to decrease the effect of or decrease the release of dopamine. Now, in this vesicle, this is a storage vesicle here, we have transporters, which is called as the VMAT, vesicular monoamine transporter. Now, this is a VMAT2. So, this is responsible for carrying dopamine inside the storage vesicle. If dopamine lies outside, it will be metabolized, right? This can be metabolized if it is outside. For it to be there as such, it needs to get stored in the vesicle. But if you block the VMAT2, so what you do, you are going to block the VMAT2 here. If you block this VMAT2, so dopamine is not going to be stored in the vesicle and not going to be released, but it is going to be destroyed here. That's our aim, because we want to decrease the release of dopamine here so that it is not able to act on the super sensitive or the upregulated receptors. So what is the best thing we do? We give VMAT2 inhibitors. So you give VMAT2 inhibitors. So here the drug treatment is different. VMAT2 inhibitors. So we have tetrabenazine, 𝗔𝗵𝗂𝗏𝗔𝗡𝗏𝗏𝗔𝗔. important. Then malignant neuroleptic syndrome is the most fatal out of them. So it can lead to high-grade fever, lead pipe rigidity, right? And there is increase in the CPK levels. So what you do immediately, this is a very, very life-threatening condition. So first and foremost, you have to stop the drug. Now, because this is because of increase in the calcium release from the sarcoplasmic reticulum, which is going to cause the increase in the muscle stiffness and the contraction. So you want to block that release. And you know that in the, if this is the cell here and this is the sarcoplasmic reticulum, which is going to release the calcium. So here we have the receptors present which cause the release of calcium, and these receptors are called as ryanodine receptors. So when you block these ryanodine receptors, the calcium release will be stopped and this calcium will no longer lead to contraction of the muscles. So what you give here, you give a drug which is going to block this ryanodine receptor, and that drug with us is dantrolene. So dantrolene is a drug of choice, right? Because it blocks the ryanodine receptor 1 and it inhibits. Then we have other drugs. So this is the drug of choice. We can also give bromocriptine. It's a D2 agonist. That you can also. So this is very, very important table of all the EPS because they can be asked like which is the drug of choice for this particular condition. Moving on to the next, which is mania. The topic is mania and we have various drugs used for mania. So we have first important is lithium. Very, very important from examination point of view. So lithium, what is the mechanism of action of lithium? Now lithium is a drug which is going to act at this level, that it inhibits the conversion of IP2 to inositol phosphate. So therefore, when it is blocked, it will not be able to release inositol, which is a precursor for formation of PYP2, because then ultimately it is going to form DAG, IP3, etc., and the action is going to come because of this. So what it does, it will stop or it will inhibit the production of the raw material only. So what is the raw material that you're giving? This IP2. This IP is the raw material. So you're inhibiting the supply of the raw material. That is important. But know that the lithium action is not very quick, not very acute. It takes about 2 weeks to produce the effect. So in acute mania as such, it won't be able to stop the attack or take care. But yes, when you start it, it is going to prevent the further attack of mania, and prophylactically it is going to be helpful for us. So this is the important point here, that inhibits the conversion of IP2 to inositol phosphate. ADRs of lithium, very important. So you can remember again a mnemonic. Lithium, L-I-T-H-I-U is here only, and M. So L stands for leukocytosis. I stands for insipidus, diabetes insipidus. T stands for tremors, the fine tremors actually, and these are most common. H stands for hypothyroidism. I stands for I is increase in the nausea and vomiting. And M stands for mothers. So what is in the mother should not be given in pregnancy because it is teratogenic. And it causes a condition in the fetus which is called as Epstein anomaly, which is the abnormal tricuspid valve. Now coming to the maintenance levels in BPD, how much should be the levels, because it has a very narrow therapeutic index. So if you are giving it in acute and maintenance, you have to maintain it within a particular range. So maintenance level in bipolar disorder should be 0.5 to 0.8 milliequivalent per liter, and this should be in acute 0.8 to 1.2 milliequivalent per liter. If it goes high, there will be toxicity. And earliest toxicity symptoms, if you go above some over 2 milliequivalents per liter, you will see tremors also again, but these are actually coarse tremors. Normally you see fine tremors, but they turn into coarse tremors in course of time when we give this. And there can be increase in the nausea, vomiting, diarrhea. So what you do here, the treatment is basically that you are going to give, going to cause diuresis and give sodium bicarbonate. Sodium bicarbonate along with diuretics. If the toxicity goes more than 4, this is an indication for us to start hemodialysis. So when to start hemodialysis? If the levels are above 4 milliequivalents per liter. And another important thing to know is that this lithium is a drug which has anti-suicidal property. Which has anti-suicidal property. From the previous drugs, also clozapine has the same effect, right? Clozapine also has an anti-suicidal property. So also we can write here clozapine. So which of the drugs has anti-suicidal property? Here it is clozapine, and there it was clozapine, here it is lithium. Now let's do the important drugs, points, or the various phases of stages of mania. In acute mania, the best drugs which we give are atypical antipsychotics. I told you lithium has a lag period, can't be managing the acute phase. So atypical antipsychotics. So we can give olanzapine, right? We can give aripiprazole. You can combine it with benzodiazepines for quick effect. If it is not showing an effect like lorazepam or diazepam, we can give. Prophylaxis, we have to start lithium alongside, right? So oral lithium can be started alongside because it will prevent the further attacks. What if bipolar disorder occurs in pregnancy? So you know that you cannot give any drug in pregnancy. So lithium also has a tendency to cause teratogenic effects. So it is not very common, it's a rare effect, but still we would like to avoid it, and the drug of choice here becomes your atypical antipsychotics. Atypical antipsychotics. In rapid cyclers who have more than 4 attacks per year, the drug of choice is valproate. Which anti-epileptic drugs also can be used? Yes, so we can use drugs like valproate. We can use carbamazepine. We can use lamotrigine. Which atypical antipsychotics can be used? As I told you, we can use olanzapine. We can use risperidone. We can use aripiprazole, and we can use quetiapine. Remember, these are the atypical antipsychotic which can be used in case of mania. These are the antiepileptics which can be used in case of mania. Remember that we cannot give any other drug as such. So these are the important points to be remembered from mania and all the other psychopharmacological drugs. So we are going to do today diuretics. So first, let's see the target sites of the various diuretics. So this is right. So you can see in the nephron, here we have the cortex and this is the outer medulla. So starting from the proximal convoluted tubule, so the first site or on the PCT itself, the diuretics which act are the acetazolamide, right? So here the acetazolamide act. Then Osmotic agents like mannitol also act on the proximal convoluted tubule, but alongside they also act on the descending loop of Henle, right? So here somewhere in the loop of Henle, so they act here as well as on the PCT. Loop as the name suggests, the loop diuretics, they act at the level of the thick ascending limb of the loop of Henle. Thiazides, they act on the distal convoluted tubule, and then we have the potassium sparing diuretics which act on the collecting tubule. Then we have the ADH antagonists also which work at the level of the collecting tubule. So for the diuretics, if you want to remember them according to their site of action and in this manner, so you remember a mnemonic which is called COLTS. So first it is carbonic anhydrase inhibitor, then we have the osmotic diuretic, then we can remember the loop agents, then we remember the thiazides, and then we have spironolactone. So moving on to the important features or points I'm going to do in comparison, a tabulated form. How can we compare them? It is very easy therefore to understand and also to form a memory of it. So we have carbonic anhydrase inhibitors like acetazolamide. So we have carbonic anhydrase inhibitors which are topical also like 𝗤𝗏𝗏𝗏, brinzolamide that we use in the eye in the cases of glaucoma. Osmotic diuretic we have mannitol and glycerol. Loop diuretics furosemide, torsemide, bumetanide. In the thiazides, a longest acting apart from hydrochlorothiazide we have chlorthalidone. Right, so this is the longest acting. Now, in the potassium sparing diuretic, remember the mnemonic EATS. So, E stands for eplerenone, A is amiloride, triamterene, and S stands for spironolactone. So, these are the potassium sparing diuretics. The site of action should be in the proximal convoluted tubule, and the target is they inhibit carbonic anhydrase. Okay. Now, the next is osmotic diuretics. The site of action is PCT and in the descending limb of Henle. Target is they are going to basically work by the osmotic process. So, they draw the water by osmosis. So, they will enter inside the kidneys in the lumen and they will draw the water by osmosis, and this will lead to a solute free water loss. So, it's more water, less of solute. So, solute free water loss. The third, the loop diuretics, they act at the loop of Henle. So, ascending thick limb of loop of Henle. What is the target site? So, they are going to inhibit sodium, potassium, 2-chloride sympota. So, they also, apart from this, they are going to increase the renal prostaglandin synthesis. So, because of this, they are going to enhance the renal hemodynamics, vasodilatation and all they cause. So, this is another important thing, because that's why if you give them along with the non-steroidal anti-inflammatory drugs, they are going to inhibit the prostaglandin synthesis. So, therefore, they will blunt the action of these diuretics. Then we have the thiazides. Thiazides, where do they act? They act at the distal convoluted tubule, and what they do? They inhibit the sodium chloride symporter. Okay, again they are also going to enhance or increase the renal prostaglandin synthesis. Last we have the potassium sparing diuretics. So they are going to target the collecting tubules. Remember, all the other diuretics, they are going to act through the lumen of the diuretic. So what I mean when I say this, so let's say this is the nephron, and all the other diuretics, they are going to first enter inside the lumen and then they are going to have their action. This is the only diuretic which is going to act from the luminal side, right? So here it is going to act somewhere here. So on the CT, but this is going to act from the basolateral side, outside, basolateral side. Okay. Now, the target for this is, there are two targets here. So the first group of drugs, they are aldosterone antagonists. Aldosterone antagonists. In this we have spironolactone and eplerenone, finrenone, all those drugs. Number two, these are the drugs which are going to inhibit the epithelial sodium channels. Epithelial sodium channels inhibitors. So what are these drugs? These are your amiloride and triamterene. So remember, one is aldosterone antagonist, the other one is epithelial sodium channel inhibitor. Both are going to work in a similar manner and they are going to cause increase in the potassium levels. Major side effects now let's do. So major side effects of the first group, which is estazolamide or carbonic anhydrase inhibitors. The most important is it can cause metabolic acidosis. Now, 25% of the sodium is reabsorbed in the proximal convoluted tubule, but this is not allowing the absorption. So most of the sodium is going to be now retained or reabsorbed at the level of the last part in the collecting tubule, and in exchange a lot of potassium is going to be given out. This group of diuretics, they are going to cause maximum hypokalemia. So hypokalemia and maximum hypokalemia amongst all these diuretics. Then they can cause rashes, right? That is very important, and they can lead to renal stones. The second one, which is the osmotic diuretics. So pulmonary edema is one of the, can be a drawbacks, and if pulmonary edema is present, it should not be given in that condition. Loop diuretics. So loop diuretics and thiazides, they almost they share the similar, you can say the side effect profile, except for one difference. So both of them we can say, if I talk about both of them, right? So they are going to cause low PMC. The difference is low potassium. So they are going to cause hypokalemia. Low magnesium. But for the calcium, loop is going to cause calcium. But in the case of thiazides, they are going to cause high calcium levels. Right? So remember, loop loses calcium. That means it is going to cause hypocalcemia, while thiazides are going to retain calcium. So they are going to cause hypercalcemia. That's the only difference right here. And they are going to cause, loop is low is this, and high glue. Remember, low PMC, high glue. High glue means hyperglycemia, hyperlipidemia, hyperuricemia, high uric acid, right? So these are the important, you can say, the drawbacks. Only please remember that this is the difference between thiazides and loop diuretics, that the loop diuretics are going to cause hypocalcemia while the thiazides are going to cause hypercalcemia. Then another important, only restricted to loop diuretics, would be ototoxicity. Ototoxicity, and that too with the drug 𝗧𝗘𝗃𝗧 acid, not with thiazides. 𝗧𝗃𝗃 acid, it is no longer used now because of this, so but it's one of the loop diuretics. So moving on to the last group here, that we have the potassium sparing diuretics. So obviously they're sparing potassium or keeping potassium inside the body. What will they do? They will lead to hyperkalemia. So their drawback is hyperkalemia. The spironolactone has an additional drawback. It can cause gynecomastia, but this is not seen with eplerenone. So you can see gynecomastia, it is seen with spironolactone. So eplerenone does not have this action. Then it can lead to acidosis, right? So these are the important side effects that we, in a comparative fashion amongst all these diuretics. Now, some important one-liners from here. Which is the most potent loop diuretic? That is bumetanide. Bumetanide. So loop diuretic with the longest half-life, torsemide. Highly ototoxic, 𝗧𝗃𝗃 acid. E for ear and E for 𝗧𝗃𝗃 acid, ototoxicity. Diuretics which can be used in renal failure. So one we can use loop diuretics. And the only thiazides which can be used is called as metolazone. Thiazides used in calcium stones. So these are the renal stones. So if there is increased calcium in the urine, we need a drug which doesn't throw more calcium in the urine, rather retains the calcium. So we have thiazides. And maximum hypokalemia is caused by which we already discussed. These are your carbonic anhydrase inhibitors or acetazolamide, if they ask you the question specifically. Now, the other comparators we have are the uses. So let's do the uses of these. So firstly, the acetazolamide or the carbonic anhydrase inhibitor, it is a drug of choice in case of mountain sickness. Now, it can be used for prophylaxis as well, and it can be used for treatment as well. But the first or best thing when there is acute mountain sickness is to get the patient down. It should descend first, and then treatment should be started. That's the first major thing that you can do. The other uses is glaucoma. So systemically acetazolamide is used in case of narrow angle glaucoma, but then we have topical carbonic anhydrase inhibitor like dorzolamide, brinzolamide that can be used in glaucoma. So it is used in case of glaucoma. It can be used in case of urinary alkalinization, right, and in case of catamenial epilepsy. Mannitol is a drug of choice for cerebral edema. Can be used in cerebral edema. Also, it is used in other conditions like in case of acute congestive glaucoma. Acute congestive, it's not a drug of choice, but yes, it can be used. Acute congestive glaucoma. And number 3, it can be used in dialysis, disequilibrium, syndrome. Loop diuretics now. Now, loop diuretics are a drug of choice where number 1 in case of pulmonary edema, right, seen with left ventricular failure. In case of renal insufficiency, so when the GFR is more less than 40. So these are effective even if the GFR is less than 40. Number 3, in case of hypercalcemia of even malignancy. So what you can do is you have to give a drug because it causes hypocalcemia. It will lose the calcium. So therefore it can be given in hypercalcemia of malignancy. Thiazides are a drug of choice in case of when there is hypertension along with edema. They are useful here, and they are useful or drug of choice in nephrogenic diabetes insipidus. Then where else can it be used? In case, remember, if there is less GFR or GFR is less than 40, then this is ineffective. So remember, it is ineffective in renal insufficiency. Ineffective in renal insufficiency. Then it can be given in case of hypercalciuria. So there is stones, more calcium in the urine. So you want to give a drug which doesn't give away calcium in the urine, rather it will retain calcium. So this is a drug which retains calcium, can be given in hypercalciuria. Then we have the potassium sparing diuretics. Where are they used? So there are drug of choice in number 1. One is called as cirrhotic edema because there is a lot of aldosterone present here. Number 2 is Conn syndrome, which is also called as hyperaldosteronism. So where there is more of aldosterone in the body. Then we have resistant hypertension. So the patient is resistant to at least 3 antihypertensive drugs. One of that must be a diuretic. So can be given in resistant hypertension also. It is used in these conditions. Very important. Then amiloride. It is the drug of choice in case of lithium induced diabetes insipidus. Okay, that is the important role. Contraindications of them. So the first, carbonic anhydrase inhibitors, because it can cause acidosis. So metabolic acidosis remains a contraindication. In case of hepatic failure, osmotic diuretics, they're absolutely contraindicated in case if there is any kind of intracranial bleed or hemorrhage. So in case of cerebral edema, you have to rule out whether there is an intracranial bleed or hemorrhage. If there is, then we cannot use them until the bleeding stops. And it can trigger pulmonary edema. So therefore, pulmonary edema conditions, we should not be giving this drug. Then contraindication of loop diuretics or both rather that they are contraindicated in patients of gout. That is important because they cause increase in the uric acid levels. Thiazides as such, they are contraindicated in case there is a lower GFR, renal insufficiency, they're contraindicated, right? So that additional where loop diuretics are preferred in such cases. Then in case of potassium sparing diuretics, definitely if there is already cautious use with other drugs that retain potassium, right? ACE inhibitors, ARBs, they are quite often employed in case of heart failures along with spironolactone, but then you have to keep on monitoring the potassium levels because both have a tendency to cause hyperkalemia. So rapid fire or very, just one important liners out of them. So what we should know, diuretics used in nephrogenic diabetes insipidus. Which diuretic is used? The diuretic used is thiazides. Thiazides. In cirrhotic edema, as I told already, it has a lot of aldosterone present. So the drug we will use is spironolactone. Diuretic of choice in pulmonary edema, we have loop diuretics. But the diuretic which can cause pulmonary edema, that is your mannitol. Read the question carefully, what they're asking. Diuretic of choice in cerebral edema, acute congestive glaucoma, again remains your mannitol. And diuretic used in lithium-induced diabetes insipidus, we have amiloride. Okay. Now, two questions from the previous years. Let's discuss. A female patient suffered a head injury due to road traffic accident and was found to have elevated intracranial pressure on examination. Which of the following diuretics is the drug of choice for reducing the intracranial pressure in this condition? So it's very simple here. They have increase in the intracranial pressure. So there can be edema or some cause. And what do we use in such a condition? We use mannitol, the best drug. Only thing you have to be careful if there is intracranial bleed or not. If there is an intracranial bleed, then we cannot be giving this drug. So a patient with gout and elevated uric acid levels present with hypertension also, which of the following medication should be avoided in the patient, right? So there is hypertension, yes, but there is increase in the uric acid level. So definitely any drug which will further cause a retention of the uric acid in the body should not be given. So thiazides and loop diuretics, they cause the retention. Therefore, hydrochlorothiazide is contraindicated, or it is not supposed to be used in this particular condition. So then we have a few lines about the antidiuretic drugs. So antidiuretic drugs, okay, so like ADH, antidiuretic hormones, they are the analogs of that. So we have these two antidiuretics or the vasopressin. We have two receptors, V1 and V2. So V1 is mostly concerned with vasoconstriction and platelet aggregation. Platelet aggregation. Then the V2 is present in the collecting duct, and this is responsible for the kidney actions, right? On the renal, whatever action on the renal system. So the agonist, we have some agonist and we have drugs which are the antagonists. So agonists are going to work like the antidiuretic hormone. So where do you think they can be used? Now, because this property actually of V1, vasoconstriction, has been employed in cases of bleeding, esophageal varices. So terlipressin, drug of choice for bleeding esophageal varices. Desmopressin is a drug which is used in case of central diabetes insipidus. In case of central diabetes insipidus, because what is happening is there may be lack of the antidiuretic hormone, so they are going to function like them. They are agonists or analogs of them, and they are going to stimulate the V2 receptors in the kidneys. That's the central diabetes insipidus, number one, and then they can be used for nocturnal enuresis, especially in children, bedwetting at night, so that can be prevented. Now, what happens is the ADH, if there is too much ADH, and that can lead to syndrome of inappropriate ADH secretion, and when it's too much of ADH, that's antidiuretic hormone. So there is a lot of water retention in the body, and that can ultimately lead to dilutional hyponatremia, right? So we need to give the antagonists, V1 and V2 antagonists. V1 antagonist we have is relcovaptan. So these all have vaptans in them. Then we have relcovaptan, we have TLMC. So we have tolvaptan, we have lixivaptan, then we have mozavaptan, and we have conivaptan. So all the above three, they are oral, and conivaptan is given by the IV route. So now, what are the important drugs for diabetes insipidus that you need to know? So the first drug is the drug for neurogenic or central diabetes insipidus, which is now did, that is desmopressin. desmopressin. Nephrogenic diabetes insipidus, because here there is problem in the receptors. If the ADH is normal but the receptor is a problem, so therefore you cannot give any drugs like desmopressin because they won't be responsive. So here we give drugs which work by any other mechanism like thiazides. Then lithium induced diabetes insipidus, it is amiloride. So these are the important points that you must know from this topic of diuretics and antidiabetics. Today we are going to do drugs for heart failure. So what are the drugs that are used or effective in acute heart failure? So you know that in acute heart failure, the most important problem to solve is that there is a lot of edema, pulmonary edema. So you have to decrease the fluid overload in the patient. So the best drugs for that are loop diuretic, which is furosemide, and we give it by the IV route. So what it does is it takes care of the acute pulmonary edema. Acute pulmonary edema, or we can say the preload also. Right? So these are the drug of choice for acute management of heart failure. First line therapy. Adverse effect because of any diuretic. So it most important here is decrease in the potassium levels, that is hypokalemia, and it can cause hypotension as well. Then you might have to add then nitroglycerin sodium nitroprusside IV. This is not sufficient alone, because similar way they decrease because it releases nitric oxide, and this causes decrease in the preload mainly and also decrease in the afterload. But mainly it's the preload that is decreased. So again the similar line of action. So this can also lead to hypotension and headache. It's a vasodilator, so it leads to headache as well. Now remember, because it has a tendency to cause hypotension, so we take care if the BP is already, the systolic blood pressure, if it is less than 110, then we do not give. So avoid if the systolic blood pressure is less than 110 millimeters of mercury. Then what are the other drugs which can be used? We have hydralazine, which is an arteriolar dilator, therefore it causes decrease in the afterload. Then nesiritide, it is a BNP analog. Now because of this BNP analog, the most important thing is it increases the cyclic GMP levels, and this leads to vasodilatory effect as well as natriuresis. Again, this has to be given by IV route. So this is the role of the nesiritide. Then we have drugs. So this was one part of the problem that we solve in acute heart failure, that is the pulmonary edema, to decrease the fluid overload. Then we need drugs which have a positive inotropic action as well. So the drug of choice for this is 𝗏𝑉𝑅𝑚ine. So 𝗏𝑉𝑅𝑚ine you give it by the IV infusion rate or the infusion route here, that is continuous infusions, and what it does, it acts on the beta-1 receptors of the heart. Now remember, the classical thing about this 𝗏𝑉𝑅𝑚ine is, though it acts on the beta-1 receptors, it primarily has an effect on the force of contraction. So it mainly increases the force of contraction that is required, inotropic action. It has less effect on the heart rate. So it causes little increase in the heart rate. So because of this, there is little increase in the heart rate, the myocardial oxygen demand will also be less. But yes, if you give it in a higher dose, it can later on trigger tachycardia, which can predispose to arrhythmia. Alright, then if it doesn't work, then we add on another drug, which is milrinone or enoximone. So what is milrinone? So these drugs are called as inodilators. So what is the meaning of inodilator? That it has an inotropic effect plus it is a vasodilator. So there is positive inotropic effect and also it leads to vasodilatation. Why? Because it causes the phosphodiesterase 3 inhibition. Right? So this is milrinone enoximone, and the major problem because of this would be hypotension. Hypotension. Then we have levosimendan pimobendan, which is available in Japan. So what is levosimendan? The role of levosimendan is that it is a calcium sensitizer. Right? It is a calcium sensitizer. Therefore, it will go and increase the sensitivity of the contractile myofilaments to calcium. Okay? It's a calcium sensor. Wherever calcium is there, it's going to increase the force of contraction, right? Contraction increases. So it's a direct calcium sensitizer. Then we have a drug which is called as omecamtiv. Omecamtiv is what? It is going to cause myosin modulation. Right? So myosin, remember, important for contraction. So it's causing myosin modulation. Then we have digoxin, which is not a primarily used drug, but for exam point of view, this drug is very, very important. So digoxin, it is going to act on the sodium potassium ATPase, and what it does, it increases the ultimately the calcium levels inside the cell, so increases the force of contraction, and therefore it will also increase the cardiac output. The important adverse effects here are mostly GIT related, which are more common. So we can find nausea, vomiting, and there are different types of arrhythmias which occur with it. So we are going to deal with digoxin in a little bit more detail later on. Alright, then very important, which are the drugs which decrease the mortality in heart failure patients? Very important to know. Right? So which are these drugs? The first group we have ACE inhibitors or ARBs. So remember, any drug which is going to decrease the aldosterone level will definitely decrease the mortality, because aldosterone is responsible for the ventricular remodeling of the heart, the left ventricular damage, the myometrium, the cells which become fetal type of cells, destruction of the cells, apoptosis of the healthy cells, and instead the cells which come and take its place are the fetal cells. You know, they are not very capable of taking up the action of the contractility. So therefore, the left ventricle becomes weak, it fails. That leads to death of the patient. So that is most important. The agent which is going to cause this remodeling is aldosterone. To an extent, even the sympathetic overstimulation causes it, but aldosterone is the most important factor which is causing ventricular remodeling. So any drug which is going to decrease the level of aldosterone will increase the or decrease the chances of mortality in the patient and prolong the survival rate. So ACE inhibitors, ARB, which are the AT1 antagonists, because they are going to ultimately decrease the level of aldosterone. So therefore, they decrease the ventricular remodeling. So they decrease the aldosterone levels. Therefore, they are going to have anti-remodeling effects. Then very important drug, if you can't give ACE inhibitors, ARBs, then we can also give ARNI. What is ARNI? It is an angiotensin receptor and neprilysin inhibitor. So your sacubitril and valsartan, or rather valsartan is an angiotensin receptor blocker and sacubitril is the neprilysin inhibitor. So what this drug is doing, it is ultimately going to cause vasodilatation, it is ultimately going to cause natriuresis. So again, angiotensin receptor blocker is a part of it. So this again is going to decrease the mortality chances in the patient, and this is used for chronic heart failure. Chronic heart failure. Its main adverse effect is, which we have to take care of, is angioedema. Angioedema. So we don't combine ARNI with ACE inhibitor, because again there will be increase in the risk of angioedema. Then very important group of drugs are beta blockers. Now, not all beta blockers are approved in heart failure. There are 4 beta blockers important which are used, which have been proven to be effective in heart failure. So, we have B, which stands for bisoprolol. Then we have carvedilol. Then we have metoprolol, and we have nebivolol. These are the 4 drugs which have been found to be effective. Out of them, the first 3, these are the first line. Nebivolol is not the first line drug, but first 3 are the first line drugs. So, whenever we give beta blockers, take care that we do not give it in acute heart failure or acute decompensated heart failure. Always when the patient is in a compensated state, then we start with these drugs, because beta blockers are going to inhibit the beta 1 receptors, which is further going to aggravate the heart failure. So, we started at a later stage when the patient is more stabilized. So, we start with less dose, slow dose. So, we use low dose of this, and we use it every 4 weeks. You can then increase the dose, but low dose is used, and in case of stable heart failure, not in acute decompensated failure. Now, what they do is they also decrease the heart rate. Important thing, they decrease the heart rate, and when they decrease the heart rate, they will decrease the myocardial energy consumption also. Right? That is very important. Also, they decrease the arrhythmias and sudden death because of arrhythmia. So, they decrease the chances of arrhythmias and therefore sudden death. That's very, very important for this. Then we have spironolactone, eplerenone, and finerenone. Again, they are directly going to inhibit aldosterone. SGLT2 inhibitors, what are they going to do is, they are like, these are your gliflozins. Initially, primarily, they were just the anti-diabetic drugs, but now they have been proven to be effective in heart failure, especially with low ejection fraction. So, if there is diabetes along with heart failure with low ejection fraction, these are the preferred drug or the drug of choice here. Because what they do, they inhibit the SGLT2 and they prevent the reabsorption of glucose as well as sodium. So, this factor is important for decreasing the fluid load, because with sodium, water is also reabsorbed, so they decrease the fluid load. They have been found to be very effective and decrease the mortality in the patients. Then hydralazine also has been found to be effective there, especially if you use with nitrates, isosorbate dinitrates. Then ivabradine. So, ivabradine, as the name suggests, these are the drugs which cause bradycardia, pure bradycardia. Unlike beta blockers, which also inhibit the force of contraction and conduction, they only are going to inhibit the heart rate or decrease the heart rate. Therefore, they cause bradycardia only. Bradycardia only. So, when they decrease the heart rate, obviously they are going to decrease the myocardial oxygen demand. Okay, so that is important for them. So, they are approved for grade 2 to 4 heart failure. So, this drug, it is given if there is a contraindication, to beta blockers. And we can't give this drug if already the heart rate of the patient is low. So, contraindicated if heart rate is below 70 beats per minute. Already there is a low heart rate, you don't want to further aggravate the condition, so we do not give this. So, based on these, what we have done, so there was an MCQ in the previous years, which of the following drugs acts on both ACE and NEP, which is neural endopeptidase pathways indicated by the arrows. So, these two, ACE and neural endopeptidase thereby influencing both vasoconstriction and natriuresis. Why? Because ACE is involved in the formation of angiotensin II, which is going to cause vasoconstriction by acting on the receptor, and neurolipidopeptidase, it ultimately it is associated with the degradation of the BNP and ANP, which are diuretics and which are natriuretics and vasodilators. So what you do, any drug which is going to inhibit this and this, what is it going to do? It is this pathway, no formation of angiotensin II here, so therefore it is going to cause, or it is going to block the vasoconstriction, while the drug which inhibits the NEP is not going to cause degradation of these natriuretic peptides, so therefore there will be increase in the vasodilatory effect and there will be natriuresis. So which drugs out of them does the same, whether it is omapatrilat, sacubitril, losartan or nesiritide? So let's see omapatrilat. So omapatrilat is a drug which inhibits both ACE inhibitors and NEP. So this is the correct answer. Sacubitril, we just did in the ARNI, that is only a neprilysin inhibitor. So it acts only at this level. Losartan is only acting, it's an angiotensin receptor blocker. This is a neprilysin inhibitor. And nesiritide, it is a BNP. Right? So the correct answer is omapatrilat. Now remember, this drug is banned. Why was it banned? Because by both the pathways, it increases the chances of angioedema. So because of angioedema, that is the main issue with this. So therefore, this is not used, but it was asked in one of the exams. Now digoxin is a very, you can say, an exam favorite of most of the examiners. So one or two questions do come from this chapter and on digoxin. So digoxin, important things to know. So we know that digoxin is a drug used for heart failure. Yes, half-life of digoxin is around 40 hours, right? So if you have to give digoxin, so what, the steady state level is reached in 4 to 5 half-life, so about 200 hours. So many days are required for it to produce effect. Therefore, you have to give a loading dose of this drug whenever you give digitalization, that is called. Levels of digoxin. Again, this has a very narrow therapeutic index. So you have to be very careful while dosing the drug. So it should not go from it should stay between 0.45 to 1.4 nanograms per ml. As soon as you go more than 2 nanograms per ml, the toxicity starts showing. And in some patients, it can start even at low dose, even at 0.91. So most of the times, digoxin toxic does not really actually, it's not directly proportional to the concentration. You only have to check the signs and symptoms in the patient. It can occur even in the so-called therapeutic range. So you have to keep a check on the patient symptoms actually. Because levels are not a very clear or a true indicator whether there is toxicity or not. So most common cause of toxicity is in case the patient has some renal problems. So in renal insufficiency, because it is accumulation of the drug. So renal insufficiency. Alright. So which is the earliest and the most common symptom? Those are your GIT symptoms, like there is nausea and there is vomiting and there is anorexia. Most common type of arrhythmia which is seen with this is ventricular bigeminy. Never seen with this drug is atrial flutter or Mobitz type 2 block. Mobitz type 2 block. It causes a classical vision defect which is called as the yellow vision or xanthopsia. The name is xanthopsia. So what are the treatment for the various adverse effect it causes? So if the ventricular arrhythmia occurs, it can be very, very fatal. The treatment for such kind of arrhythmia is lignocaine. So digoxin induced ventricular arrhythmia, the treatment or drug of choice is lignocaine. Lignocaine is a class 1 antiarrhythmic. Atrial arrhythmia, then what you do, your main concern is to prevent the conduction of the impulses from atrial to the ventricle. So we give something which will delay or which will prolong the AV conduction here. So here we can give beta blockers. beta blockers. AV block has occurred. Then you need to give a drug which is going to reverse that AV block. So what you give antimuscarinic like atropine. So in bradycardia or in AV block, atropine is a drug of choice, and you can also do temporary pacemaking. Temporary pacemaker you have. So what happens when there is toxicity with digoxin? Is there an antidote available? Yes, there is an antidote available. That is called as digibind or digiFab. What it does, it is going to form a complex with digoxin, and therefore it is going to remove it from there. Triggers, what can trigger the digoxin toxicity? So if there is hypokalemia or there is hypomagnesemia. Obviously, there's hypomagnesemia, the opposite is calcium hypercalcemia. So all these three are going to trigger, because it acts on the sodium potassium ATPase. That is the site here. So if there is hypokalemia, more of digoxin is going to act at this particular point, because actually it's competing with potassium here. So if there is less of potassium, then this will get more chance to bind. So remember, digoxin, it cuddles calcium, but it kicks potassium. So kicks potassium means it doesn't like. Kick starts with the K, so it kicks potassium. Potassium is K, and it cuddles calcium. Calcium with a C. Remember this important trick, right? So it doesn't like potassium, it kicks it off. So hypokalemia, actually it can trigger digoxin toxicity. It cuddles calcium, it lies. So hypercalcemia, it is important for its effect or toxicity. That is what is there. All right. So with this, we come to the end of the important points of the drugs which are used in case of heart failure.